Hello.
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 Mhm. So, so what do you? What? So I think well, first of all, a very good morning to everybody. Maybe we should something like start because all the relevant persons are online, I think. Good morning, Dr. Ali Mokhtar. Is just about to connect. Um,
Hello.
Hello?
Can you hear me now?
Yes, now
Hi,
we can hear you.
I'm sorry.
Okay, very well
Okay.
then.
Thank you. So let's start. A very good morning to all. I extend a warm welcome to all participants, students, and delegates for the Scientific Global Digital Gathering at the 8th Emirates Pathology and Digital Pathology Conference. I'm Dr. Ali Mokhtarpour, anatomical pathologist and a fellow of the Royal College of Pathologists of Australasia, consultant in Dr. Nooruzpour Diagnostic Pathobiology Lab in Iran. And I will be the chairperson of today's sessions, along with Dr. Andreas Lopke from Germany. So, few words about UCGConferences. Utilitarian Conferences Gathering offers a wide range of events, meetings, conferences, workshops, and symposia. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerate with best ideas and strategies. Utilitarian Conferences Gathering is a pioneer in the area of event management and collaboration. We are a full-service event provider specializing in the field of medical, clinical, healthcare, life sciences, pharma, and environmental science for academic and industrial sectors. We stand out distinctively from our competitors for our commitment to quality, round-the-clock service, and unmatched price. We are able to provide you with the best event and meeting experience under one roof. We at Utilitarian Conferences Gathering make sure that you as a client choose the most appropriate event. I thank you all for finding time in your busy schedule to be here today. Today marks the major activity in the brief existence of the UCG conference, a moment where we are interacting, sharing experiences, and reflecting on various areas. 8th EPUCG 2021 is a remarkable event which brings together professors, researchers, and students in the field of breast pathology and cancer, making the online conference a perfect platform to share experience, foster collaborations across industry and academia, and evaluate emerging technologies across the globe. We cordially welcome you to join us and witness the advances in this field together. The conference has attracted delegates who have come from all over the world, across the continents, and subject of the conference is surely of global importance. UCG thanks all the individuals and organizations who have worked to make this conference a grand success. UCG Program Committee has put in long hours with many creative efforts. And finally, I would like to extend my appreciation to the participants of this conference. We hope you enjoy the conference and that our participation will contribute to our professional development and relationship. Because of the COVID-19 pandemic, we had to shift our conference to virtual space entirely. Similarly, pathology has also been going virtual in the past few years. However, transitioning to digital pathology has not been an easy or simple task. There have been concerns about the reliability, affordability, and even the speed. We all love having the ability to start reporting in seconds of receiving the slides. In this context, I'd like to introduce you to Morpho Labs, a US-India-based company that markets the perfect whole slide scanner at a happy price. As of today, Morpho Labs is trusted by users across the globe. We are glad to have them with us today, and their representative will be giving a talk at 11:40 UK time. Please don't hesitate to get in touch with the Morpho Labs if you would like to know more. So few points about the timing. So the speech timing for our keynote speakers will be 40 minutes today. For speakers will be 25 minutes. And for poster presentation, around 15 minutes. And certification will be provided on August 14th, 2021. So I would like to introduce our honorable keynote speakers now. And with this, I take the immense pleasure of introducing our keynote speakers at the 8th Emirates Pathology and Digital Pathology Conference, which will be held from today until 12 August 2021. Our first honorable keynote speaker, Dr. Philip McKee, Fellow of Royal College of Pathologists from USA. Dr. Anil Parwani, Vice Chair, Anatomical Pathology, Director of Pathology Informatics and Digital Pathology from USA. Dr. Marilyn Bui, Senior Member and Professor of Pathology from USA. Dr. Zef Leifer, President, the Leifer Institute of Molecular and Digital Pathology from USA. Dr. Joanne Martin, Director of Blizzard Institute, Honorary Consultant from Barts Health NHS Trust from UK. Dr. Andreas Lupke, Dr. Andreas M. Lupke, Head of Orthopedic Pathology and Vice Head of Cytopathology from Germany. Mr. Felix Faber, CEO and founder of MindPick from Germany. Prof. Tarek Ali, Professor of Internal Medicine and Senior Consultant Physician from UAE. Dr. Michael Retzky from University College London from USA. Dr. Alina Bridges, Director of Immunodermatology, Richfield Laboratory of Dermatopathology, Dermpath Diagnostics from USA. Ms. Bridget Muller, Head of Business Development from Precision from Germany. So thank you all. We'll now begin the sessions. Without any further ado, let's start with our first speaker, Dr. Amrita Malini from UAE. I'm passing her the stage to deliver this speech. Dr. Malini, please.
A very good morning to everyone. I'm sharing my screen.
Yeah, please share your screen. Pressing the green button, yeah.
Is my screen visible now?
Yes.
Yes.
Go on, please.
Yeah. So very good morning to everyone. It's a great pleasure for me to be with you today morning virtually to talk on papillary lesions of breast. Before I begin my topic, I would like to extend my sincere gratitude to the organizers of this wonderful conference, the 8th Emirates Pathology and Digital Pathology Conference. Myself, Dr. Amrita Malini, I'm an anatomic pathologist working at Burjil Hospital and Burjil Medical City, Abu Dhabi. So I have no disclosure to declare. This talk is primarily based on WHO classification of breast tumors 2019 5th edition, and I have some inputs from College of American Pathologists virtual lecture series. So WHO classifies the papillary lesions of breast as intraductal papilloma, papillary DCIS, encapsulated papillary carcinoma, and solid papillary carcinoma or SPCs, and the new entity tall cell carcinoma with reverse polarity. So the learning objectives are to differentiate benign papilloma from atypical papillary lesions, to understand when to use the immunostains for challenging papillary lesions, and to distinguish in situ and invasive carcinoma in EPC and SPC and T staging accordingly. As when I think about this topic, papillary lesions, I feel people find it difficult at times to differentiate entrapped glands in case of sclerosed papilloma or displaced epithelium, particularly following corneal biopsy to distinguish this entity from invasive malignancy. And sometimes it's challenging to distinguish in situ versus invasive status in solid papillary carcinoma and determination and quantification of atypia. That means whether it is ADH or DCIS in benign papilloma and distinguishing this entity from papillary DCIS. So with that background, first we'll focus on the first topic, that is intraductal papilloma. WHO defines this entity as a benign breast lesion within a central or peripherally located duct with papillary projections with fibrovascular core which are covered by the epithelial and myoepithelial layer. So mammography may show dilated duct or rarely macrocalcifications, and ultrasound can show solid hypoechoic nodule, and the Doppler can demonstrate vascular pedicle of this papillae. And grossly, the size can range from few millimeters to more than 5 centimeters, and it will be a well circumscribed round tumor, and it will be seen attached to the dilated duct with a pedicle, and peripheral papillomas can be multiple. And microscopically, there will be a broad fibrovascular core, more pinkish appearing fibrotic core, and which in turn lined by this clear myoepithelial cells and in turn covered by the epithelial cells. From H&D sections itself, it's easy to identify this morphology, but if in doubt, we can use myoepithelial markers like smooth muscle myosin heavy chain, calponin, or P63. So there will be a distinctive myoepithelial with running along the papillae as well as surrounding the dilated duct. As I mentioned, peripheral papillae can be multiple in number, and this epithelial cells are columnar and show low-grade nuclei and can show apocrine metaplasia. Now, sometimes the core of the papillae can undergo extensive sclerosis. Then they are called sclerotic papillae, which results in marked distortion of ducts and entrapment of glands. A potential pitfall associated with this problem is that sometimes, depending on the sampling, particularly in corneal biopsy, you may get only the sclerotic part and few entrapped glands in the biopsy. Like in this case, this is a papilloma, the periphery of which has undergone sclerosis. So imagine a situation where in a corneal biopsy, you will get only the sclerotic part with few entrapped glands. Like in this case, it's okay because there is the remaining papillomas there. But if you get only this part and in a corneal biopsy, it will look like this. So there will be a stroma or sclerotic stroma with few glands. So we naturally may think this, we are dealing with an invasive malignancy, that is invasive glands invading the stroma. So this situation, it's very crucial to do myoepithelial markers to confirm the presence. And another thing with papillary lesions is apocrine metaplasia. So the thing is that they have to be very careful, because once the papillary lesions undergo apocrine metaplasia, they may not express the myoepithelial markers. Another potential pitfall is squamous metaplasia, particularly after biopsy procedure. So after biopsy, then there can be hemorrhage, necrosis, and infective necrosis and reactive squamous metaplasia. So this also is very challenging, particularly in small biopsies. If you see only the squamous area with necrosis, we may think we are dealing with a metaplastic carcinoma. So it's very important. We have to look for the clues of biopsy artifact like hemorrhage, hemosiderin-laden macrophages, fibrosis, cholesterol plus, and these are all clues that we are dealing with a reactive process rather than a malignancy. Another diagnostic pitfall is epithelial displacement, which is defined as entrapment of benign glands along needle tract and displacement of these glands into the stroma or vascular spaces. So like in this case, some of the part of this benign gland of the papilloma that can get entrapped in the stroma or sometimes in vascular spaces due to the biopsy procedure, due to the in the needling tract. So this may result in again a potential misdiagnosis as invasive malignancy. And another challenging thing is that sometimes when these glands get entrapped in the stroma, they may not take the accompanying myoepithelial cells. So we'll definitely think we are dealing with a tubular carcinoma or low-grade invasive malignancy. So if there is accompanying myoepithelial cells, we can demonstrate their presence. But if no accompanying myoepithelial cells, we have to be very careful. We have to look if there is any hemosiderin-laden macrophages. Like in this case, you can see some hemorrhage hemosiderin macrophages here. And papillomas can undergo or atypical ductal hyperplasia. Usual ductal hyperplasia, like elsewhere, it will heterogeneous or polyclonal proliferation. And here also you can see the swelling and streaming pattern characteristic of usual ductal hyperplasia. And this is atypical ductal hyperplasia that is seen associated with papilloma. Here, as opposed to usual ductal hyperplasia, there will be punched out spaces, and the proliferation is mostly monotonous proliferation. And the distinction between ADH and low-grade DCIS is based on extent of size. If it is less than 3 mm, it is low-grade DCIS. But you have to remember this is applicable only for low-grade DCIS, because once it is high-grade DCIS, it automatically becomes high-grade DCIS irrespective of the extent or size of the lesion. So the important things, the importance of distinguishing this UDH from ADH is that if it is UDH, the risk of subsequent malignancy is around 0.5 to 2 times, whereas if it is ADH or ADH, it is 4 times risk. Also, this is again a picture showing DCIS arising in papilloma. There is monotonous cells with cytologic and architectural features of low-grade ductal neoplasia. If you do myoepithelial markers, it will stain only the periphery, and you can see CK fiber 6. It will be absent in the proliferation, whereas estrogen receptors, where if you do ER, it will be diffusely strong positive, and it can demonstrate this characteristic polarization around spaces in case of DCIS. This is some of the myoepithelial markers. This table I have taken from WHO classification of breast tumors. Like in my usual practice, I always do at least 2 myoepithelial markers, because each myoepithelial marker, they are associated with a drawback. Like P63, it is an excellent nuclear marker, but the problem is that we are using this marker to demonstrate myoepithelium, but it may stain the nuclei of papillary carcinomas. Similar muscle, smooth muscle actin, they are all cytoplasmic proteins, but they may stain, particularly in case of papillary lesions. It can stain the pericytes and endothelial cells that we see in the papillary lesions. So it is always advisable to do at least 2 myoepithelial markers in case of confusion. And the distinction between UDH and ADH, it can be done based on the H&E morphology itself, but if it is doubtful, you can use the marker CK fiber 6 and ER. And ER high CK fiber 6 low profile predicts atypia, whereas ER low and high CK fiber 6 expression is favoring an usual ductal hyperplasia. Now, DCIS, it is a subtype of DCIS, and WHO defines it as a morphological subtype of DCIS with arborizing fibrovascular core lined by neoplastic epithelium with absence of myoepithelium running along the fibrovascular core with a retained myoepithelium at the periphery. So, this picture I got from Twitter, and this is an intraductal papilloma where you can see the myoepithelium and epithelium. But here, this is the intraductal papilloma with ADH and DCIS, which shows the papilloma here with a small portion of it has undergone neoplastic transformation, whereas papillary DCIS, the entire thing is neoplastic. That is the difference. And the papillary DCIS is usually seen in postmenopausal females, and this is in comparison with the papilloma, it's more pinkish. This is bluish, and it has a broad fibrovascular core. And this is, the entire thing is neoplastic, and the papillae themselves part of the neoplastic process. And the component cells, they are columnar nuclei with low to intermediate nuclear grade and usually strongly ER positive, and there will be presence of myoepithelium at the periphery. Like we have discussed for papilloma, this papillary DCIS can also undergo sclerosis by other patterns of DCIS as well. And like in this case, you can see if you do myoepithelial markers running along the papillae, it's absent. Whereas you can see it is only the periphery, in contrast to a papilloma where they will be present in the periphery as well as along the papillae. Now, sclerosis can also occur for papillary DCIS, and it is staged as PTIS. And the importance of recognizing this entity is it is 5 to 7-fold increased risk of invasive breast carcinoma. And in micro-invasion, DCIS is defined as 1 or more foci, none of which measures more than 1 millimeter diameter. Now, the third entity is encapsulated papillary carcinoma. It's also a variant of DCIS. Here you can see the papillary proliferation within a cystic space and surrounded by fibrous capsule. So it also affects elderly females. The size varies from 2 to 3 centimeter, can present either as nipple discharge clinically or a palpable mass. And this is the gross picture. You can see this friable mass within a cystic space surrounded by a fibrovascular, it's surrounded by a capsule. And microscopically, there is thin papillary froms with low to intermediate nuclear grade. There is myoepithelial cells will be absent in the papillae, within the papillae as well as in the periphery. That is how we distinguish this entity from papillary DCIS. So here also it's the papillary proliferation is seen within a cystic space with a capsule, and myoepithelium is absent within the papillae as well as in the periphery. So encapsulated papillary carcinoma is staged and managed as PTIS, usually ER/PR positive and HER2 negative. So, but a word of caution is there is a subset of encapsulated papillary carcinoma that is called high-grade EPC, which constitutes 3% of cases. It's usually seen in younger age into females, and they may show high-grade nuclei with brisk mitosis. So WHO recommends to classify these lesions as not as PTIS, but according to their size. The T staging should be according to their size. And this encapsulated papillary carcinoma, usually it is staged as PTIS, but invasion in case of EPC is defined as presence of invasive elements that permeate beyond this fibrous capsule. Like in this case, you can see some detached cell papillary clusters touching the fibrous capsule, but this is not invasion. So invasion capsule, and for T staging you have to measure only the size of this frankly invasive component. So then you can report in your report there is an invasive invasive carcinoma that is seen in association with encapsulated papillary carcinoma. And older studies states that larger tumors needs mastectomy and they may be associated with lymph node metastasis. But recent studies says it has excellent outcome with adequate local therapy. And encapsulated papillary carcinoma, the molecular pathology, it's almost resemble those of low-grade ER positive invasive breast carcinoma, no special type. But it has a similar frequency of PK3CA mutation, but TGF-beta expression is increased. That leads to the formation of this thick fibrous capsule. Similarly, this matrix metalloprotein expression profile is intermediate between DCIS and invasive carcinoma. That is why this entity is regarded as a carcinoma in progression to invasive carcinoma. Now, the next entity is solid papillary carcinoma. It is also seen in elderly individuals, can present as bloody ripple discharge, and microscopically it show well-defined solid nodules with perivascular pseudorosets, and similar to EPC, they also lack peripheral as well as internal myoepithelium, usually low to intermediate nuclear grade features. An important feature of solid papillary carcinoma is its neuroendocrine differentiation. And you can see this solid nodules with a rounded contoured nest, and this is the solid arrangement. And some particularly in corneal biopsies you may not be able to identify this thin delicate fibrovascular core carcinoma. They can show neuroendocrine features. So a pitfall with this is, particularly in small biopsy, is we may misdiagnose this as neuroendocrine carcinoma. And if we do neuroendocrine markers, that will be positive also, but you have to carefully look under intermediate or high grade power to identify this presence of this delicate fibrovascular core, to identify this as solid papillary carcinoma. And it can show this sort of signature like morphology and also spindling of cells. And here also you can see some mucin vacuoles and spindling of cells, and they are also associated with intracellular as well as extracellular mucin secretion. And the myoepithelial cells, as I mentioned, the myoepithelial cells may or may not be present at the periphery of this nodules. So this may create confusion. So WHO has resolved this for us by stating that in the absence of any conventional invasive carcinoma, solid papillary epithelial cell layer is present or absent. So even if it is myoepithelial cell layer is absent or present, is regardless of that, if the contours, the nodules are like rounded contoured once, then we should call it as PTIS. As I mentioned, they may express neuroendocrine markers, synaptophysin and chromogranin, and they can show extracellular mucin. But mere presence of extracellular mucin doesn't mean we are dealing with an invasive malignancy. But mucinous carcinoma can arise in a background of solid papillary carcinoma. Like in this case, you can see the clusters of cells floating in mucin, or sometimes it can be an invasive breast carcinoma of no special type. and rarely it can be a solid papillary carcinoma itself. So defining invasion in solid papillary carcinoma is very challenging, and for me, I'm still finding it difficult sometimes to call whether a solid papillary carcinoma is in situ or invasive. So the WHO criteria is that it should be irregular coalescent papillae with a nodule with showing a jigsaw puzzle-like pattern. So instead of the rounded contours in the solid papillary carcinoma in situ, you can see it will be like irregular contour and infiltrating tumor nest with smaller nest at the periphery, perineural invasion, and also lymph node metastasis. And for the measurement for T staging, you should measure only the size of the frankly invasive component. Sometimes it will be really challenging. Then you have to put it like in your report, like solid papillary carcinoma invasive arising in a background of solid papillary carcinoma in situ, and the invasive component measures so and so centimeters, but it is seen admixed with in situ carcinoma. So that makes the exact measurement of the invasive component challenging, something like that. And it will be usually strongly and diffusely positive for ER, PR, and HER2 will be negative. And as I mentioned, it will be positive for synaptophysin and chromogranin, and it will have a few copy number aberrations compared to IDC of usual type. In next entity is invasive papillary carcinoma. It shares same gene expression profiles as EPCs and SPCs. But in order to call something as invasive carcinoma, there should be more than 90% papillary architecture, lacking myoepithelial markers throughout. And it usually shows a frankly invasive growth and resembles papillary carcinoma elsewhere, like it can resemble ovarian serous carcinoma or papillary carcinoma or pulmonary papillary adenocarcinoma or thyroid carcinoma. So in doubtful cases, you can do the IHC panel to distinguish if it is primary or metastatic, like CK7, 20, mamma globin, GATA3, WT1 for ovary and thyroglobulin, and TTF1 for lung primary. So next entity is invasive micropapillary carcinoma. So in order to qualify something as invasive micropapillary carcinoma, it should be present more than 90% of tumor, and it consists of hollow morula-like tumor structures, nodules, or nest in empty spaces. You have to be very careful. These empty spaces are not lymphovascular spaces. At the same time, this invasive micropapillary carcinoma is associated with peritumoral lymphovascular invasion as well as lymph node metastasis. So in doubtful cases, you can do D240 to confirm whether they are lymphatic spaces or not. And microscopically, it shows reverse polarity. That means the apical pole of the tumor cell membrane faces outward. It is called the inside-out pattern. You can demonstrate this inside-out pattern with EMA immunostain, and it's always there is higher incidence of lymphovascular invasion and nodal metastasis. Usually ER/PR positive and HER2 3+ positivity, but sometimes can show a weak staining, like a basolateral staining pattern, that is 2+ positivity, that is also seen. That can be seen, or some studies even report a triple negative phenotype for this entity, invasive micropapillary carcinoma. So because of this peritumoral lymphovascular invasion and frequent axillary lymph node involvement, it is associated with worse prognosis. Next entity is a recent entity, is tall cell carcinoma with reverse polarity. Like the name suggests, it resembles tall cell carcinoma of thyroid origin, papillary carcinoma, tall cell carcinoma variant, and it can show reverse polarity, and it is usually associated with IDH2 mutation. And you can see tall cells with reverse polarity. And sometimes in the fibrovascular core, we can appreciate foamy macrophages or cystic spaces with colloid-like material. And it can also show a solid and papillary-like pattern with thin, delicate papillary core. And the individual cells are tall columnar cells with eosinophilic cytoplasm, and the nuclei can show nuclear grooves and inclusions like papillary thyroid carcinoma. They may express calretinin and express low molecular weight as well as high molecular weight cytokeratin. And here it's a picture showing CK5/6 positivity. and the myepithelial markers may be absent or can show weak nuclear staining. And if you do mitochondrial antigen, you can demonstrate this the reverse polarity pattern of this entity. And it usually harbor IDH2 mutation. So IDH2 protein expression by IHC is highly sensitive and specific for this entity. And as I mentioned, it shows GATA3 positivity, but the TGF1 will be negative, and low risk of lymph node metastasis and local recurrence. So with that, I finish my topic. So in summary, these are the different papillary lesions as per WHO. This table also I have taken from WHO: intraductal papilloma, papilloma with ADH and DCIS, how to distinguish this ADH and DCIS, and to distinguish this entity from papillary DCIS, encapsulated papillary carcinoma and solid papillary carcinoma, in situ and invasive, and the criteria for invasion, and invasive papillary carcinoma. So the take-home message is always assess for the presence of mycelium in case of doubt with at least 2 markers, and you have to be very cautious regarding the biopsy artifact, particularly infarction, squamous metaplasia, all sort of this biopsy artifact. And EPCs with invasion must be beyond the capsule, and when you have to do the T staging, it's only you have to take the measurement of the invasive component for T staging. So these are my references, and these are the books from which I got the images. And thank you.
All right. Thank you, Dr. Amrita Malini, for the wonderful speech. So any questions from the audience for Dr. Malini? All right, if no question, we just straight away move to our next speaker, Dr. Poonam Sharma from India. You can always post your questions to the chat box, and so if there's no time, because we are facing actually some time constraints, so after the morning session, so you can directly ask the speaker and get your answers. So Dr. Poonam Sharma from India is our next speaker. I'm passing her the stage to deliver the speech. Dr. Poonam?
Yes, just turning on my presentation.
Okay. Just share your screen, please.
Is the screen visible now?
Not yet to me. We can see you, but not your presentation yet.
It's not visible.
Just share your screen, press the green button.
I have shared it.
Okay, and maximize the PowerPoint. I mean, just can you open your PowerPoint now?
Pardon?
So you have to maximize the size. I mean, you have to actually share, and then please try not to minimize it.
Is it visible now?
Not yet, no. Could you please just share your screen again? You can just turn it off and switch on again. Okay. If there is difficulty, so we'll share your slides. No problem.
Just give me a minute. I'll try it again.
Yeah. We can see now your presentation. Just please tell us to move to the next slide like that. So we can see your presentation now. You can start, Dr. Poonam.
It's written that somebody other is sharing the screen.
Yes. You can start now. Our technical team has already shared slides.
It's written that you cannot share the screen while other participant is sharing.
Okay. Okay, now it's fine. So we can see your screen now.
Okay.
You may start now.
Is it fine now?
Yes, please.
Okay. Sorry for the inconvenience.
No problem.
My name is Dr. Poonam Sharma. I am lecturer, GMC, Jammu from India. The topic of my presentation is fine needle aspiration cytology of salivary gland lesions, a retrospective study in a tertiary care center of North India. So this is, we have a pair of parotid glands, submandibular glands and sublingual glands, along with the minor salivary glands present in the oral cavity and the oropharynx. And here is the cytology of histopathology of a parotid gland, which is predominantly composed of serous acini, and these are the few striated ducts. So salivary gland lesions are common in Indian setup. Diffuse or nodular enlargement of the salivary glands may be caused by inflammation, cystic lesions, degenerative process, benign malignant neoplasms, and it needs correct diagnosis for proper management. FNAC of the salivary gland lesions is an excellent technique in the diagnosis of suspected salivary gland lesions. Now, it has two important roles. The primary goal of FNAC is to distinguish salivary gland lesions from non-salivary head and neck masses, especially those of the lymph node origin, but also soft tissue lesions and skin adnexal masses. Because the normal parotid gland contains more than 20 intraparotid and periparotid lymph nodes, primary lymphomas and metastatic tumors mimicking salivary gland neoplasms are commonly seen. Secondary, preliminary diagnosis about the nature of the disease process can be established before proceeding to definite management plan. However, certain disadvantages of FNAC are that it is less sensitive and specific compared to biopsy, and sample adequacy depends on experience. Now we see a number of false negative diagnoses in FNAC, which are principally a result of inadequate sampling of the lesion, most frequently those that are cystic. Cystic neoplasms, example, Warthin tumor, low-grade mucoepidermoid carcinoma, metastatic squamous cell carcinoma are the most likely causes of false negative diagnosis. Cysts frequently yield non-specific fluid, not representative of the underlying lesion. When a cystic salivary gland lesion is aspirated, any residual mass should be resampled after fluid is withdrawn. So salivary gland neoplasms, they pose a number of challenges to the cytopathologists. So firstly, there are more than 35 salivary gland tumors of epithelial type, many of which are rare, placing familiarity with them out of reach for most practitioners. Secondly, most salivary gland malignancies are low grade, displaying few overt cytological features of malignancy. Thirdly, the less common high-grade malignancies are readily recognizable as malignant, but they are difficult to distinguish from one another. Fourthly, some benign tumors, example basal cell adenoma, have a malignant counterpart, that is adenocarcinoma, that is morphologically identical, except that there is an infiltrative growth pattern, which cannot be assessed cytologically. Lastly, many different salivary gland tumors share similar cellular constituents. It is the architectural relationship and relative abundance of these constituents that ultimately determines the tumor type. Also, a precise cytological diagnosis is not possible with many FNAs that show basaloid cells only. A frozen section is often necessary to guide appropriate surgical management. So, there can be neoplastic, inflammatory, lymphoid, and cystic nature of the lesion, which depends on the cellular constituents. So, hypercellular specimens are typical of neoplastic lesions. Inflammatory cells are prominent in sialadenitis and cystic lesions. Stone fragments are diagnostic of cytolithiasis. Abundant lymphoid cells can be seen in a variety of salivary gland lesions. Not all of them are exclusively lymphoid in nature. Also, the presence and character of matrix material also provides an important diagnostic information. For example, mucin, which is pale magenta in Romanowski preparations and translucent blue-purple on Pap smears, suggests a mucoepidermoid carcinoma, mucocele, retention cyst, or mucinous metaplasia. Likewise, a chondromyxoid matrix is characteristic of pleomorphic adenoma, and stromal spares are typical of adenoid cystic carcinoma, but neither finding is entirely specific. And such findings, along with a more detailed impression of the cell type seen, that is myoepithelial, duct lining epithelial, basaloid, oncocytic, mucinous, squamous, acinic, sebaceous, and clear cells, they enable one to refine the differential diagnosis. So with this, this is the normal salivary gland cytology that we see. It comprises of rounded clusters of serous or mucinous acinar cells. Also, we have flat sheets and tubules of ductal cells and adipose tissue. Now, cytomorphology of the common salivary gland lesions that we encountered. So, acute sialadenitis, it shows neutrophils, necrotic debris, stone fragments if cytolithiasis is present, and scant ductal cells. In chronic sialadenitis, there is scant cellularity, small sheets and tubules of basaloid ductal cells with sharp borders. There's paucity of acinar elements, blood proteinaceous debris and mature lymphocytes may be seen, and fibrous tissue fragments are also seen. So lymphoepithelial sialadenitis, it shows a cellular aspirate and a mixed population of lymphocytes, plasma cells, tingible body macrophages, germinal center fragments, and lymphoepithelial islands. Now, squamous lined cysts, they show a cellular aspirate comprising of histiocytes, keratin debris, and anucleate squams, small clusters of squamous or columnar cells, mixed population of lymphocytes with or without germinal center fragments with tingible body macrophages, absence of lymphoepithelial islands. A mucin containing cyst. These are sparsely cellular, extracellular mucin may be seen. Histiocytes are seen. Amylase crystalloids is a non-specific finding, and scattered inflammatory cells may be present. Pleomorphic adenoma, if we summarize the findings, it is comprised of epithelial cells, myoepithelial cells, chondromyxoid matrix, and sometimes tyrosine crystalloids may be seen. Myoepithelioma, it comprises of loose aggregates and isolated cells which have a spindle cell, clear cell, epithelioid or plasmacytoid morphology. There is lack of honeycomb-like sheets of epithelial cells. There is lack of chondromyxoid matrix. Basal cell adenoma, it has small sized and intermediate sized basaloid cells which show a peripheral palisading. There is a dense non-fibrillary stroma at the periphery of the cell groups. So coming to Warden's tumor, it comprises of classical three findings, that is lymphocytes, oncocytes, and a granular debris. Oncocytoma, it is a cellular specimen comprising predominantly of oncocytes in a clean background with no lymphocytes. Now, mucoepidermoid carcinoma, it comprises of mucus cells which predominate in the low-grade tumors, and epidermoid cells which predominate in the high-grade tumors. Intermediate cells are also seen. There is presence of extracellular mucin, and in high-grade tumors, overt cytologically malignant features are evident. The differential diagnosis of a high-grade mucoepidermoid carcinoma includes carcinoma ex pleomorphic adenoma, salivary duct carcinoma, oncocytic carcinoma, and metastatic carcinoma. So coming to acinic cell carcinoma, it is a cellular smear with serous type acinar cells, which may be seen in sheets, crowded clusters, and isolated cells. These are large polygonal cells with abundant vacuolated cytoplasm. Fast positive diastase resistant cytoplasmic zymogen granules may be seen. They have indistinct cell boundaries, bland nuclei, and naked nuclei with or without lymphocytes may be seen. So adenoid cystic carcinoma, classically it presents with a variably sized, often large, three-dimensional acellular hyaline matrix globules and linear branching structures. The matrix is acellular with sharp borders. We see basaloid cells, and in the solid variant, numerous basaloid cells with scant matrix is seen, which may be confused with the basal cell neoplasms. Salivary duct carcinoma, it shows overtly malignant cytology and comprises of polygonal cells with abundant granular or vacuolated cytoplasm with prominent nucleoli, and these are arranged in sheets, clusters, papillae, and cribriform groupings. Also, necrosis may be evident. The differential diagnosis of clear cell carcinoma includes the benign as well as the malignant spectrum, and comprises of pleomorphic adenoma, myoepithelioma or myoepithelial carcinoma, oncocytoma, lipoma, acinic cell carcinoma, epithelial myoepithelial carcinoma, mucoepidermoid carcinoma, metastatic renal cell carcinoma, sebaceous adenoma or carcinoma. Now coming to the reporting terminology on FNAC, the Milan system for reporting salivary gland cytopathology has been recently introduced. So it comprises of diagnostic categories with the risk of malignancy in each category and management designated to each category. The first one is the non-diagnostic, which has risk of malignancy of 25%, and here clinical and radiological correlation or a repeat FNAC is required. In second non-neoplastic category, the risk of malignancy is 10%. Clinical follow-up and radiological correlation is required. Atypia of undetermined significance, here the risk is 20% and repeat FNAC or surgery is required. In the fourth category, that is neoplasm, it has two subtypes, the neoplasm benign, which here the risk is very less than 5%, and surgery or clinical follow-up is required. And neoplasm, salivary gland neoplasm of uncertain malignant potential sum, risk is 35% and surgery is indicated. Fifth category is suspicious for malignancy, 60% risk of malignancy, surgery is required. And the last one, sixth, malignant, risk of malignancy is 90% and surgery is required. The non-diagnostic category includes non-mucinous cyst contents, normal salivary gland elements in the setting of a clinically and radiologically defined mass, and samples with very scant or absent cellularity and lacking atypia. Exception to these non-diagnostic cytological criteria include mucinous cyst contents, aspirates with atypia, and specimens that contain abundant acellular matrix material or abundant inflammatory cells without an epithelial component. The non-neoplastic category includes benign conditions like reactive, metaplastic, and inflammatory processes, including acute, chronic, and granular matter sialadenitis. Another common non-neoplastic entity is the reactive lymph node. A majority of FNA samples classified as atypia of undetermined significance will represent reactive atypia, or in some cases, poorly sampled neoplasm. Different scenarios in this category include reactive and reparative atypia, low cellularity samples that are suggestive but not diagnostic of a neoplasm, cystic lesions with abundant mucin and or scant epithelial component, and parotid gland aspirates indefinite for a lymphoproliferative disorder. The neoplasm benign subcategory is used for those aspirates where a definite diagnosis of specific benign neoplasm can be made based on the presence of conventional cytomorphological features. And the most common entities included are pleomorphic adenoma and Warthin tumor, as well as lipoma, schwannoma, lymphangioma, and hemangioma. The neoplasm subcategory of SUM, that is uncertain malignant potential, is adopted for FNAs in which the morphological features are compatible with the neoplastic process, but a Specific diagnosis cannot be made. More important, a malignant neoplasm, usually low grade, cannot be entirely excluded. FNAs diagnosed as some are associated with a differential diagnosis, which includes both benign and malignant entities. The cytomorphological features of suspicious of malignancy are characterized by a sample that is highly suggestive of a malignant neoplasm, but the cytomorphological features are not definite. The diagnostic category malignant includes a broad range of different primary malignant neoplasms from both the major and minor salivary glands. A majority of neoplasms in this category will be carcinomas, and they also include secondary metastatic carcinomas to the salivary gland lymph nodes. So with this brief overview, I'll start with my study. The aims of my study were to analyze the cytomorphological spectrum and distribution of salivary gland lesions in a tertiary care center in North India, and to determine the accuracy of FNAC in the diagnosis of salivary gland lesions. Material and methods. It was a retrospective study conducted for a period of 1 year in the cytology section of postgraduate department of pathology. Inclusion criteria: patients with suspected salivary gland lesions who underwent FNAC in our department, and exclusion criteria were uncooperative patients. Study was approved by the Institution Ethics Committee. Clinical data pertaining to patients' age, sex, and site were recorded from the requisition forms and data registers. All the aspirations were performed using a 23 to 24 gauge needle attached to a 10 cc disposable syringe. 1 to 2 passes were given and the aspirated material was smeared onto glass slides. Smears were fixed in 95% ethyl alcohol and stained with PAP. GIMSA stain was done on air-dried smears. ZN staining was done wherever required. In cases where fluid was aspirated on FNA, the fluid was centrifuged and the smears were prepared from the sediment followed by the above staining methods. The stained FNA smears were examined by 2 cytopathologists independently for cytomorphological findings, diagnosis, and differential diagnosis where needed. Cytohistological correlation was performed wherever possible. So the observation of our study were 82 cases who underwent FNAC formed the material of the study with age range of 5 to 70 years. Majority of patients were seen in the 4th decade of life, followed by the 5th decade. Aspirations in 6 cases were reported as unsatisfactory due to scant cellularity, and repeat aspiration was advised. And a wide variety of lesions were seen, which included inflammatory, benign, and malignant lesions. So this table summarizes the results of our study. There were a total of 82 cases, 9 non-diagnostic, there were 6 cases. Non-neoplastic category, there was 19 cases of chronic sialadenitis, 18 of acute sialadenitis, 6 cases of abscess, 6 cases of mucus retention cyst, 5 cases of sialadenosis, 3 cases of granulomatous sialadenitis, and 2 cases of lymphoepithelial cyst. In benign, pleomorphic adenoma was the commonest with 13 cases, 4 cases of Warden's tumor, that is 4.9% cases, basal cell adenoma, schwannoma, and myoepithelioma, 1 case each. In malignant category, mucoepidermoid carcinoma was the commonest with 3 cases, followed by adenoid cystic carcinoma, 2 cases, and 1 case each of acinic cell carcinoma and poorly differentiated carcinoma. The parotid gland was involved in the majority of cases, 51.2%, followed by submandibular gland and sublingual glands. Non-neoplastic lesions accounted for 59.8% cases, followed by benign tumors, 24.4%, and malignant tumors, 8.5%. Chronic sialadenitis was the most common non-neoplastic lesion, 38.8% cases, followed by acute sialadenitis, 16.3%, abscess, 12.2%, and mucus retention cyst, 12.2%. Pleomorphic adenoma, 65%, was the most common benign neoplasm, followed by Warden's tumor, 20%. Mucoepidermoid carcinoma was the most common malignant lesion, 42.9%, followed by adenoid cystic carcinoma, 28.6%. Histopathological correlation was available only in 28 cases, as the rest of the cases were lost to follow-up. The solitary case each of mucus retention cyst and pleomorphic adenoma was diagnosed as a malignant tumor on subsequent histopathology. That is, they were false negative. All cases diagnosed as malignancy on FNAC underwent histopathology with 100% concordance. Rest of the cases had a good correlation between FNAC and histopathology. Sensitivity of FNAC in the diagnosis of salivary gland lesions was 92.9%. Discussion, coming to the discussion, swelling of salivary glands, specifically parotid and submandibular glands, are a common problem. Although the clinical examination and radiological techniques help to narrow the differential diagnosis, the tissue diagnosis still remains the gold standard. FNAC provides useful information on the management of salivary gland lesions and prevents unnecessary surgery in cases of non-neoplastic lesions, and identification of malignancy helps the surgeon in deciding the type and the extent of surgery. Now, in developed world, core needle biopsy is the preferred procedure as compared to FNAC. However, in developing countries like India, even today, core needle biopsy is still not practiced routinely as most of the medical centers. In a resource-limited country like India, FNAC is preferred in comparison to core needle biopsy, as it is cheaper, less invasive. Sampling of different areas of the lesion in the same sitting can be done at no added expenses and usually fetches good results the same day. Rapid on-site evaluation will reduce inadequate rates and costs to the system by reducing the need for repeat procedures and triaging cases for ancillary tests. Chronic sialadenitis was the commonest non-neoplastic pathology, that is 38.8% cases, followed by acute sialadenitis, 16.3%. Abscess and mucus retention cysts were also seen. Smears in chronic sialadenitis comprised clusters of ductal epithelial cells along with the presence of lymphomononuclear cells in the background. Acute sialadenitis showed numerous polymorphonuclear neutrophils and cell debris, while aspirate in cases of mucocele was mucoid in consistency, and smears exhibited numerous foamy macrophages admixed with lymphomononuclear cells. Majority of the cases in our study were seen in the fifth decade. The males accounted for majority of cases with male-female ratio of 1.8:1. Parotid gland was involved in majority of the cases, 51.2%, followed by submandibular 42.7% and sublingual glands 6.1%. On cytological evaluation, adequate aspirations were seen in 92.7% cases, while inadequate aspirations were seen in 7.3% cases. Of the adequate aspirations, the neoplastic lesions were seen in 59.8% cases, while non-neoplastic was seen in 59.8% cases, while neoplastic lesions were seen in 52.9% cases. Aspirates with neoplastic cytology, they were further categorized as benign 24.4% and malignant 8.5%. Pleomorphic adenoma was the commonest benign tumor in our study. It is a notorious neoplasm, which is readily identified because of its biphasic pattern comprising epithelial and myoepithelial cells along with magenta chondromyxoid stroma in a classical setting. However, it exhibits wide morphological spectrum varying from predominantly epithelial types to predominantly stromal types, which often pose diagnostic challenges to the cytopathologists. That is, if epithelial component predominates, then the tumor needs to be differentiated from monomorphic adenoma, myoepithelioma, and low-grade carcinoma. While in cases of increased stroma with or without hyaline globules, adenoid cystic carcinoma is a differential. Bothin's tumor was the second commonest benign neoplasm in our study. The three main components are, as I have already told, oncocytes, lymphocytes, and a dirty fluid background. And the differential diagnosis of a Bothin's tumor include lymphoepithelial cysts, chronic inflammatory and obstructive duct lesions exhibiting oncocytic metaplasia, and lymphocytes. The commonest malignancy seen was mucoepidermoid carcinoma, followed by adenoid cystic carcinoma. Verma S. et al. Observed mucoepidermoid carcinoma as the commonest malignancy in this study, while Sandhu V.K. et al. Observed adenoid cystic carcinoma as the commonest malignancy. The aspirates from adenoid cystic carcinoma usually have two components, epithelial cells and the acellular basement membrane material seen as homogeneous spherical structures. The cytological smells from mucoepidermoid carcinoma show presence of mucus-producing cells and intermediate cells exhibiting varying degree of atypia, according to which the tumor is categorized as low, intermediate, and high grade. Low-grade tumor has to be differentiated from Gordon's tumor, benign salivary duct gland cyst, brachial cleft cyst, cyaloelithiasis, and pleomorphic adenoma with excess of lymphoid stroma. With this, the conclusions of our study were: the study highlights the role of FNAC as a simple, rapid, safe, and minimally invasive technique for diagnosis of salivary gland lesions. It also helps to study the pattern and epidemiology of salivary gland lesions in our setup, and adequate sampling, high quality smear preparation, and experienced cytopathologist can diagnose majority of non-neoplastic and common neoplastic lesions on FNAC. Thank you for your patient listening.
All right. Thank you very much, Dr. Poonam Sharma, for the wonderful speech about the interesting topic of FNAC of salivary gland lesions. Any questions from the audience for Dr. Poonam Sharma? Yeah, do we have to do FNAC for every salivary gland mass? This is one of the questions in our chat box.
There are radiological and clinical lesion. We have clear-cut evidence of something we may not require, but I think that many of the salivary gland lesions require a FNAC. Either they'll turn out to be non-neoplastic or ultimately neoplastic. So we require if there is a palpable lump, we have to do a FNAC. It may turn out to be a salivary gland lesion. Maybe it is not even a salivary gland mass. It may be a node at that side. It could be a skin or adnexal lesion.
So of course, the final aspiration cytology, will be done on palpable masses. Pathologists can do that, and radiologists will do for non-palpable ones. All right. Thank you very much, Dr. Sharma. Any further questions?
Thank you so much.
Thank you. Okay, so we'll move on to our next speaker, Dr. Ali Akhtar from UK. Okay, Dr. Akhtar, I'm passing him the stage to deliver this speech.
Hello, can you hear me?
Yes, Dr. Akhtar. Yes, please.
I'll share the.
Yep.
Can you see me? Hi, my name is Dr. Ali. I am one of the junior doctors working in the NHS UK. I may not be an expert in the field because I'm working as a junior doctor, but today I'm here to present a case. It's a case report on malignant thyroid type papillary neoplasm in stroma ovary. So let's move on. Yeah. Right. So it's going to be a brief case report. It's not a huge or whole summary. I'm just going to highlight a few of the points and then I'll walk by here. So let me. Yeah. So coming over to the introduction. So stroma ovary is basically defined as the presence of a single predominant type of immature thyroid tissue in coexisting ovarian tumors. Majority are benign tumors, and we call it as teratomas. Rarely, a malignant type of tumor may arise in the background of a type of thyroid carcinoma. To date, only about 200 cases have been so far reported, and it ranges between the ages of like 40 to 60. And my discussion today is about a variant of the malignant stroma ovary, which in focus a classical or a conventional type of the papillary thyroid carcinoma. So coming over to the case, So we had a 51-year-old lady who presented us with a 4-month history of left lower abdominal pain, distension, indigestion, and weight loss for the last 2 months. There was no family history of any cancer or no any background history. Physical examination was consistent with a palpable pelvic mass on the left side. Well, usually with these cases, these can be asymptomatic, but in our case, she had a mass. We did a CT tap, which is the thorax, abdomen, and pelvis, which showed a large left adnexal mass containing solid and cystic components. Well, at this point, we were not really sure what's going on with her. But then we did a complete scan and there was no lung involvement. We did some serum CA-125 levels, which were raised, measuring about 413, whereas normal range was 0 to 35. We did a few of like the cancer markers like thyroid profile, serum LDH, alpha fetoprotein, and beta HCG, which were all within the normal range. Therefore, based on the imaging results and the raised serum CA-125, the initial diagnosis was of the primary ovarian tumor. Subsequently, our patient underwent total abdominal hysterectomy with bilateral salpingophorectomy. So on gross examination of the surgically resected specimen, a multiloculated solid cystic tumor was seen. However, there was no involvement in the right ovaries and as well as the bilateral fallopian tube. So there was no cross involvement of that. Histopathological studies of the left ovarian mass revealed a focus of a classical papillary thyroid carcinoma, which was measuring about 2 centimeters in the background of stroma ovariae. The focus of the carcinoma lacked features of surface involvement as well as capsular rupture. So this is the CT we did, and we saw the imaging. And if you could see, this is the coronal section of the CT, which shows a complex left multiloculated adnexal mass with solid and cystic components, and it is giving a stained glass appearance. This is the same as the sagittal section of the CT, which showed the mass, and it was on the left side, showing a large left adnexal mass. Coming over to the diagnosis. So as you can see from the image, we have the majority of the portion covering on this side is you can see is the papillary thyroid carcinoma-like presentation. Over here, it's the mature teratoma, which has some of the well-defined and well-circumscribed sebaceous glands, and which has an overlying stratified epithelium. There's also a patch of a small area of PTC, and there's also mature teratoma over here. On the right top corner, you can see that there's a benign-looking thyroid follicular tissue with eosinophilic colloid material, and this can be seen over here on the top side. All right. So diagnosis. Well, if we see on a low resolution, it appears like it has multiple complex and branch papillary-like structures, and there are central fibrovascular cores seen within. It's difficult to appreciate samoma bodies in this because it's a low resolution, and it may be more prominent on higher images, but maybe we can see somewhere over here, somewhere beneath over here, but it's difficult to visualize on that. So now this is one of the very interesting slides I see, because if you see on the higher resolution, you may notice a lot of things going on over here. The papillary structure is quite evident now. We can see the fibrovascular cores, and with the black, with the black arrows, you can see the classical appearance of an orphan and 9 nuclei, which have a clear ground glass chromatin. And with the green arrows, if you follow, you see that there's a lot of nuclear overcrowding, which is also very evident, as seen over here in this one. And with the yellow arrows, I've highlighted it as a coffee bean appearance, which is a typical nuclear groovings, and with longitudinal grooves due to nuclear membrane enfoldings. Yeah. So moving on to the next slide. So coming over to discussion and conclusion. Papillary thyroid carcinoma can exist in coexistence from it's a very rare malignancy. Usually it's asymptomatic, but it manifests with abdominal symptoms such as palpable mass, pain, distension, and possible ascites. It is usually diagnosed post-operatively, and histopathological diagnostic criteria remain identical to that of the papillary carcinoma of thyroid. So it's more or less similar to that. The majority of the stroma ovariae cases are benign, with only 5 to 10 cases being malignant. Histopathological, histologically, if we see papillary carcinoma and follicular carcinoma are the two most common subtypes arising in stroma ovariae. This is, for me, it's quite interesting because we followed up this lady for at least 2 years. Initially, preoperative stage, she had CA125 of 413, which after surgery, 1 month, it went down to 26.7. In the first follow-up, it was then 18.3. Second follow-up, it was a slight peak of 38.3, but then it gradually regressed to 18, and then fourth follow-up was 14.7. So the mass was diagnosed based on the histopathology as PTC and stroma ovariae. Furthermore, patient did not receive any adjuvant treatment. The patient has been disease-free for 24 months post-surgery and is now scheduled for a regular biannual follow-ups. All right. So I thank you all. That's the end of my case report.
Okay, thank you, Dr. Ali Aftar, for presenting such a nice case study. So, any question from the audience? Okay, how common is a primary papillary carcinoma thyroid in cases of monodermal teratoma having PTC cases? I mean, the frequency of,
well, it's not very common. I mean, it's not day-to-day, slides we see. It's a very rare. I would say it's around like it's less than 4% or 5%. It's not very common.
Yeah. So in general, we can divide them into somatic malignancies and germinative malignancies, those arising from germ cells or those from somatic cells. Yeah. So papillary thyroid carcinoma is regarded as those malignancies arising from somatic cells. So it's, anyways, an interesting case, Dr. Aftar. Thank you very much. Okay. So without further ado, I would like to invite our next speaker to deliver her speech, Dr. Carmen Sara Castinas from Romania. Dr.
Hello,
Castinas.
everyone. Hello.
Hello.
Greetings from Romania.
Yeah, please share your screen.
All right. I hope it works. Can you see my screen now?
Not yet.
All right. 1 second, please.
Okay. Just press the green button, share screen.
All right.
Yeah, it's, yeah. So,
good.
So you may start.
So, greetings again from Romania. My name is Carmen Sara Castinas, and under the guidance of lecturer Idomir from University of Brasov, Transylvania, I would like to present you my study about Acinetobacter species resistance pattern and the pathogenic role in hospitalized patients. Acinetobacter genus includes aerobic, non-fermenting, gram-negative cocoid rods. These germs are non-sporulated, non-motile, sometimes encapsulated, conditional pathogens. They are commonly found in soil and in water. Why is so important to know about Acinetobacter species? Well, they can survive extended periods of time on surface of medical equipment in hospital. And the number of human infections caused by these is increasing, especially as nosocomial infections. They are the culprit of serious infections, especially in critically ill patients that undergo invasive medical procedures, such as mechanical ventilation, central venous catheterization, urinary catheterization, and nasogastric tube use. Antibiotic resistance profile of these germs shows a multi-drug resistance patterns, especially in hospitals. What is the current situation in the world and in Europe? In January 2017, World Health Organizations labeled Acinetobacter species as critical level or priority. The data collected by the European Antimicrobial Resistance Surveillance Network during 2014-2017 shows that the highest levels of resistance are recorded in Southern and Eastern Europe. The spread of resistance to carbapenems is a serious threat, especially worrying in Acinetobacter species. Now let's focus on the current situation in Romania. From the European Antimicrobial Resistance Surveillance Net data published in the period 2014-2018, it results that my country faces an alarming situation. Causes that have led to the current situations are excessive consumption of antibiotics, especially those of broad spectrum, deficiency in the medical system, such as poor infrastructure, poorly trained medical personnel, deficiencies in the prevention and control of nosocomial infections, and the poor monitoring of antibiotic resistance. And Acinetobacter species resistance was greater than 50% for fluoroquinolones, aminoglycosides, carbapenems, and combined therapy. What are the study objectives? We wanted to investigate the prevalence of resistance anti-Acinetobacter species strains collected from patient samples from Clinical County Emergency Hospital of Brasov, to determine which medical departments are most effective by this pathogen, and of course, to analyze what types of infections are associated with Acinetobacter in hospitalized patients. Materials and methods. This is a retrospective descriptive study that includes 178 Acinetobacter strains isolated from patient samples from Clinical County Emergency Hospital of Brasov during 1st of January 2020 up to 31st of December 2020. Bacterial identification was based on biochemical testing and the disk diffusion method to determine the antimicrobial susceptibility of microorganisms. The results were, of course, confirmed by automated Vitek2 compact. The results of the study. The distribution of Acinetobacter species strains in the hospital wards. We can see from this graphic that the majority of Acinetobacter species strains were isolated from patient samples from intensive care unit, 51.69%, followed by general surgery with a percentage of 12.92%. The lowest number of cases were registered in gastroenterology department with only 1.69%. The spectrum of infections with Acinetobacter species in the studied period. Acinetobacter species strains were identified in different patient samples, but mostly from respiratory secretions, 42.13%, followed by wound infections, 23%, and pus, 10.67%. The samples that were least likely to have Acinetobacter species were pleural fluid, 0.56%, and pharyngeal secretions, 0.56%. The resistance to antimicrobials for Acinetobacter species. Resistance, as we can see in this graphic, over 80% resistance occurred in ceftazidime, cefepime, piperacillin tazobactam, meropenem, imipenem, in gentamicin and amikacin, but also in levofloxacin and ciprofloxacin. Resistance was recorded under 35% for ampicillin sulbactam, tobramycin, and minocycline. Very interested was to discover that all strains isolated from patient samples were sensitive to colistin. And now we shall discuss in details the resistance of Acinetobacter species, strains that we found, to different classes of antibiotics. So in case of penicillin's beta-lactamases inhibitors, we can see that our strains were most sensitive to ampicillin sulbactam, almost 60%, compared to piperacillin tazobactam, only 12.5% of the strains were sensitive to piperacillin tazobactam. In regard to resistance to cephalosporins, we tested for ceftazidime and cefepime, and we can see from the graphic that there are no huge differences between these two antibiotics. The resistance was high for both of them, above 80%. When it comes to carbapenems, the resistance is also high, again above 80% for both meropenem and imipenem. The resistance of Acinetobacter species to aminoglycosides. We discovered that the strains we isolated were more sensitive to tobramycin, almost 70%, compared to amikacin 12.27% and gentamicin 16.66%. The resistance of Acinetobacter species to fluoroquinolones are high, above 80% for ciprofloxacin and again above 80% for levofloxacin. Well, we tested our strains for other antimicrobials like minocycline. The sensitivity to minocycline is 72%, and we were happy that all our strains were sensitive to colistin, making it our last resort drug to deal with this serious infection. And now the limitations of the study I conducted was, of course, the short period of time, 1 year, and then the relative small number of samples we investigated, 178. As a summary, I would like to remind that Acinetobacter species have been frequently identified in patient samples, mostly in intensive care units, 51.69%, followed by general surgery, 12.92%, and plastic surgery department, 8.43%. The majority of samples with Acinetobacter species were tracheobronchial secretions, 42.13%, followed by wound secretions, 23.03%, and pus, 10.67%. Acinetobacter species recorded high level of resistance at tested antibiotics, with the only exception being made by colistin. As a conclusion, it is very important to constantly monitor the antibiotic resistance in these germs with the aim of optimizing the treatment prescriptions, especially in empirical antimicrobial therapy. I would like to offer my special thanks to my mentor, passionate microbiologist Idomir Mihaela, and to thank you all for your time, and if you have any questions for me.
Thank you so much, Dr. Kamen. Yeah, there are a few questions for you. So what was the most common complications seen in your study cases by these Acinetobacter strains? This is the first question.
I have not studied the complication. This is a retrospective study, So I only collected the data that we had in the laboratory to see what are the most affected departments and the samples that we collected, which samples are.
Okay. The next one is, the question is, what was the most common cause of antibiotic resistance in your study other than antibiotic sensitivity?
So the most common cause of resistance.
Cause of antibiotic resistance in your study other than antibiotic sensitivity. It's written like that. Perhaps it's not clear, is it?
Yeah, it's not very clear. If
okay, no problem, no problem. So they can post again their questions more clearly, and you can answer later. So thank you so much again, and we'll now move on to our next speaker. You're welcome. Dr. Tanjam Rachika Devi. I would like to invite Dr. Tanjam Rachika Devi from India to deliver the speech.
Hello, am I audible?
Yes, doctor.
I hope my screen is visible too.
Not yet. Could you please try again? You have to share your screen.
Actually,
so press the
button, I
button.
have shared a while ago.
Yep. So I'm not sure, but if it's not working, our technical team.
Yeah, I'm sharing again.
Okay. Yeah, it's coming up.
It's visible now?
Yeah. Yes, we can see your screen, but not your PowerPoints yet.
Yeah. Still in the process. Now it's fine.
Yes, please.
Okay. Thank you so much, Dr. Ali and the UCG team for giving me an opportunity to be a speaker on this prestigious event. And first of all, can I see? First of all, did you know why I put this graph in the first place? This is an infant mortality rate current situation in India, where there is 28.771 death out of per 1,000 live births and 3.610% decline from 2020. And despite of improving infant mortality rate, do you know that birth defects is one of the main leading cause as per the CDC, that is the Center for Disease and Control Prevention has said, and it accounts 9% of the infant mortality rate as mentioned by the UNICEF. So in this 9% of congenital defects, today I'm going to speak case study which I have been encountered, and it's on a particular cause which is like rarely talked about in the medical forum. And I am talking about a case which has a least preventable care and there is no cure yet. And hello, this is Dr. Tanjam Rachika. I am a postgraduate student in the Department of Pathology in the Kahir's Jawaharlal Nehru Medical College, Belagavi, Karnataka, India. And as I'm going to present my case study in the Porter syndrome, while we talk about it rarely, Porter syndrome, it is a critical factor in the infant mortality rate, because of which we have that this condition occurs with the severe complication, then the affected developing fetus used to be fatal at birth or shortly after birth. And also, if this condition occurs with the bilateral renal agenesis, then the Potter's syndrome, the life is incompatible. And because of which there is no standard therapy till date worldwide, and there is increasing morbidity and mortality rate. Please allow me to provide a bit of context on Potter's syndrome. This is the scheme of my presentation. Potter's syndrome was first described by Edith Potter in the year 1946. And he was a pathologist working in Chicago. The three terminologies, Potter sequence, the Potter syndrome, or oligohydramnios sequence, these three terminologies are used interchangeably in the medical literature. We all know oligohydramnios occur due to decrease in the amniotic fluid, and this may be due to decrease in urine output, and decrease in the urine output is secondary to the bilateral renal agenesis, urinary tract obstruction, or due to prolonged or the chronic rupture of amniotic membrane. And these oligohydramnios, they leads to a typical appearance known as Potter facies. And these Potter facies, they are characterized by a flat nasal bridge, low set ears, and the thick prominent epicanthic folds along with the recessed chin or the hypoplastic chin. And the main cause of the Potter syndrome is still not known yet, but the overall incidence, it varies from 1 in 2,000 live births to 1 in 5,000 live births with a recurrence rate of 3 to 6%. Also, recent research has also found that the condition occurs more commonly in males than as compared to females. And there is no known method to prevent this fatal disorder, but prenatal ultrasound is recommended for mothers with oligohydramnios. It is believed that Potter syndrome may have high prevalence as they have deadly consequences, which is incompatible with life, and they are often fatal or at shortly after birth. So the present study aimed to report a fetus with Potter syndrome, which was diagnosed on autopsy. So to understand furthermore, we receive a male fetus of 21 weeks of period of gestation weighing 445 grams with an obstetric history given as a primary gravida with breech presentation. And we do inquire to the clinician regarding the previous ultrasound report, but they failed to give the documentation. And also after we receive a placenta weighing 120 grams with attached umbilical cord measuring 8.8 centimeter in length. And placenta measures this. On external examination of the fetus, we found if we examine the facial structure, we found that the fetus have a depressed nasal bridge with the thick epicanthic folds along with the low set ears, while the recessed chin or the hypoplastic chin was not so prominent in this case. And on further examination, we found that there was some changes in the skin. Redundant skin were visible in the lateral side of the body, along with some defective spines, also known as scoliosis, towards the right side. And we have another picture on further examination. Going to the lower parts, we have the left foot showing clubfoot, or also known as congenital talipes equinovarus. And on further examination again, on anal inspection, the anal orifice was not patent. So for further workup, we did infantogram. On infantogram, this is the lateral view, and this is the AP view. This is the lateral view, and this is the AP view. In infantogram, since the fetus have got multiple skeletal deformities, they can hear the bilateral lungs were not aerated, and you can see over here the scoliosis of the dorsal spine towards the convexity towards the right side, and there is the overcrowding of the ribs, and on the left side of the foot there is dorsiflexion of the left foot. And the lateral view was to see for any vertebral abnormalities or any sacral agenesis is there. So we did perform a fetal autopsy on dissection. We found all organs were in situ except for kidney. Both the kidneys were absent, and we have removed by using the method of end mass removal using the lateral technique. And on gross examination, we found the brain appears normal. These are the meninges. You can see the corpus callosum, it's normal. The heart appears normal on gross, but the lungs, it appears hypoplastic. And how we say hypoplastic, we measured the total weight of the lung divided by the total body weight of the fetus. It was coming under the criteria for less than 28 weeks. The ratio was less than 0.012, and we have given that bilateral lungs has both hypoplasia. And this is the gross picture of the liver, and this is the spleen. Spleen and liver both appears normal. And this is the picture showing again the umbilical cord along with the placenta and the membranes. The umbilical cord has 3 vessels, and the placenta membrane appears to be shiny, translucent, and it appears normal. On microscopy examination, this is the brain in the low power view showing a mild congestion. I'm sorry, I could not provide the higher power view. And next we have is the heart H&E section in the low power view. This is the high power view showing the intercalated disc and the nucleus. They appear normal in the high power. And this is the low power of the left lung. Again, here in the parenchyma, you can see the tubular structure closely packedly arranged, and there is no secular pattern. You can see here as the lung is still developing, and few areas of the alveoli, they show congestion. The same way on the right side of the lung, it appears the same closely packed tubular structure. In the high power view, this epithelial lining was seen as low cuboidal epithelial lining on both the same sides. And we have given bilateral lungs as a congestion. Both bilateral lungs are congested. And we have this liver in the low power view showing the portal triad here. And in the another picture, we have the spleen of the low power view. And in the high power view, you can see here again, there is congestion of the liver as well as few extramedullary hematopoiesis going on, along with, again, same in the spleen, there was congestion and extramedullary hematopoiesis. And in the umbilical cord, we saw in the H&E low power view, there were 3 vessels, 2 umbilical artery and 1 umbilical vein. In the next image, in the H&E section, we saw under 200X, the placenta and membranes show congestion as well as some areas of infarction too. So with all the above findings, we have given the diagnosis as Potter syndrome. As we move on to discussion, Potter syndrome is rare fatal disorder which is predominantly seen in male fetus and occurs in primigravid mothers, which is also similar in my case too. And the bilateral renal agenesis, urethral obstruction, or chronic leakage of amniotic fluid leads to the decrease in amniotic fluid, which is also known as oligohydramnios. These were the main cause in my case that the fetus has got bilateral renal agenesis, because of which there was oligohydramnios and the fetus lung was not developed properly, leading to hypoplastic lung. And this leading oligohydramnios, they causes the movement and movement restriction, leading to a typical appearance of the Potter syndrome features. And the incidence, it varies from 1 in 2,000 live births to 1 in 5,000 live births. Almost all the studies have mentioned the same thing. And in the study of Srikant M. Sastry, Meher Banu, and Latika, they also describe Potter's feature as flattened nasal bridge, low set ears, prominent epicantic folds, and recessed chin, which in my case, recessed chin was not that prominent. And also Stoyan Kostov and Srikant mentioned regarding the manifestations as skin changes, imperforate anus, clubfoot, and pulmonary hypoplasia, which in my case, all these features were seen too. There were few limitations in my study where we could not perform genetic testing or the chromosomal analysis. And we presented this case to accentuate the rarity and fatal conditions of the Potter syndrome and to focus the importance of family history of any renal abnormalities and also to focus on the regular antenatal checkup or for further workup for chromosomal analysis, and to go for any stillbirth born without any known cause, but suspicious of any syndromes, one can go for workup on autopsy so that the chances of recurrence can be lesser, as in this case, the chance of recurrence is quite high, 3 to 6%. And also all parents should be aware and educate regarding the oligohydramnios and the long-term consequences of the developing fetus. So last but not the least, I would conclude by saying we believe that strong correlation between the clinicians, radiologists, and pathologists will help detection of Potter syndrome on time, and also to prevent the recurrence of these fatal disorders in the subsequent pregnancies. That's all for today. These are my reference. Thank you so much for your patience.
All right. Thank you so much, Dr. Thangjam Rochika Devi. Thanks for joining us and presenting such a wonderful and informative research. So any question for Dr. Thangjam? Okay. Is there a specific trimester in which the loss of amniotic fluid leading to oligohydramnios can cause Potters, or it can happen in any trimester? This is the question for you.
Yeah, well, actually, the first amniotic fluid, it depends on the mother, but later after 16 weeks of pregnancy, it will start depending on the urine output, like how much urine the baby is secreting. So I would say if there is any fetal abnormalities related with the kidney, then only the oligohydramnios will start, and it may not be Potters also. It can be any disease like related with renal, not only Potters, it can happen. But one should start seeing after 16 weeks. So one should go for regular antenatal checkup so that we can prevent all these consequences.
Yep, wonderful. Yeah, thanks, Dr. Thangjam. It's a nice case on Potter syndrome.
Thank you so much.
So, yeah, thank you. So we'll move to our next speaker, keynote speaker and chairperson, Dr. Andreas Lubke from Germany. Dr. Andreas?
Yes, hello. Can you hear me loud and clear?
Yes, please.
Okay.
Yeah.
I will start to share my screen. There it is.
Could you please introduce yourself, Dr.
Yes,
Andreas?
of course. I will just so yes. Well, my name is Andreas Lübke. I'm head of orthopedic pathology and vice head of cytopathology at the University Medical Center in Hamburg-Eppendorf in northern Germany. And I kindly thank Utilitarian Conferences for the opportunity to present this keynote lecture. And as a topic, I chose bone metastasis, a practical approach to differential diagnosis, because this is what I'm doing every day, first of all. Second, we will cover many fields of pathology, because as you know, any bone tumor can any tumor can metastasize to the bone, and therefore we'll see a lot of different pathological disciplines. And one other thing is, when we are dealing with artificial intelligence, this might be a really challenging topic. So we go through it, and after that, you can decide whether this is easy or maybe challenging. So just a second. Yeah. So we start with the basic principles. First of all, bone metastases are more prevalent than primary bone tumors, about 25 to 1. And the most common primary sites are well known. It's the lung, the breast, the prostate, kidney, and the thyroid. And frequently affected bones are the spine, the skull, the ribs, the pelvis, humerus, and femur. So it can appear almost anywhere in the body. And it depends on the type of clinicians you are working with. For example, if you've got a well-working spine center, you got a lot of biopsies from the spine. Bone metastases are more frequent in elderly patients because, as we know, elderly patients frequently get cancer. And the bone is the third most frequent site of metastases after lung and liver. So if you are a hepatopathologist or a lung pathologist, you will truly see metastases like in the bone. So it doesn't matter whether it's the bone, the liver, or the lung. And usually the marrow space is affected. In the long bones, metastases frequently involve metaphysis. But in the distal to the knee and in the tibia, you rarely find metastases. It's important to know that any malignant tumor can metastasize to the bone. So you should stay open-minded for any differential diagnosis. How do bone metastases become apparent? First of all, we got pain. We can have pathologic fracture. We might detect the metastases at a PET CT, which is very sensitive, and also an incidental finding. So same as primary bone tumors. On radiology, there's a broad range of appearance, from lytic to sclerotic. Well, basically, depending on the type of tumor, for example, renal cell carcinoma creates more lytic metastases, or thyroid carcinoma does the same. And prostate cancer, breast cancer, and neuroendocrine carcinomas are known to produce so-called osteoblastic metastases. That is true, but from my own experience, and especially on the microscopic level, you will see that any tumor can produce any kind of metastases. But those are some basic rules of thumb. The differential diagnosis includes primary bone tumors, which have to be differentiated from the metastases, of course, and then hematologic neoplasms, of which the plasmacytoma is most frequent. So it's a more philosophical question whether the plasmacytoma is a primary bone tumor, because the bone is the home of the bone marrow, and therefore you might classify the plasmacytoma as primary bone tumor, or you can just classify it as an hematological neoplasm. But today we won't talk about hematological neoplasms in the bone because this is quite difficult and this is very complex, and it's very difficult to manage this in the time of 40 minutes. Another important issue can be epithelioid vascular tumors, especially due to the fact that those are positive for cytokeratin. So the general approach to bone metastases is to think of the patient's history and clinical context, because this gives you a lot of information what is in the differential diagnosis. And after that, you first of all, as usual, go to the conventional histomorphology. And those two facts combined, the clinical context and the conventional histomorphology, are the most important clues to your solution. And always keep in mind what is frequent is frequent. So you will find lung carcinoma, breast cancer, prostate cancer, kidney cancer, and thyroid cancer very frequently in bone metastases. Additional stains can be very useful, especially when your resources are limited. The most important stain for me in the bone metastasis is the Astra stain, because you find bright blue mucinous vacuoles, which speak for adenocarcinoma, if you do have an adenocarcinoma. The iron stain is very helpful in differentiating hemosiderin from other endogenous pigment. And what is also very useful are frequent sections of H&E slides, because sometimes the bone metastases can be created of a limited number of cells. So do more sections always. When I got a tumor suspicion and I do not see a tumor in the first slide, I always do at least one immunohistochemistry, basically one cytokeratin, and 2 to 4 additional slides. And if I see no tumor, I can truly say, well, this is negative for a tumor. Next thing is immunohistochemistry. the most important tool when we are dealing with metastases. And here are the 5 most frequent tumors that metastasize to the bone with the according markers. If we got a lung adenocarcinoma, it's very useful to test for TTF1 and nepsin. Well, nepsin can fall out if TTF1 is negative, because nepsin is downstream of TTF1. But never forget that some lung cancers, adenocarcinomas, can be TTF1 negative. The most reliable marker for the breast is the nuclear marker GATA3, followed by mammoglobin, which is very sensitive. And you can also add GCFP50. In the prostate, very sensitive and very specific markers are PSMA and the androgen receptor and NKX3.1. PSA frequently falls out and is not expressed anymore. PSAP can be quite sparse in some cases, and ERK is basically limited to the prostate carcinomas with temporary ERK aberration. The thyroid carcinoma is marked by TTF1 and thyroglobulin, and additionally of PEX8. So if you got a neoplasm which is positive for TTF1 and PEX8, this is very likely to be a metastasis of thyroid carcinoma. And the last frequent one, the renal cell carcinoma, stains nuclei for PAX8 and also the classical marker RCC. And the clear cell renal cell carcinoma is positive for carbonic anhydrase number 9, which is quite a specific marker in this particular question. A pitfall can be tumors with keratin positivity other than carcinoma. And first of all epithelioid vascular neoplasms are positive or can be strongly positive for keratin. But if those cells are without any atypia and look vascular, it's not a real big problem. Then the osteosarcoma can make cytokeratin expression, usually not as strong as in carcinoma, but on small biopsies, it can be challenging. In the right location, for example, in the tibia, where metastases are not that frequent, an important differential diagnosis for cytokeratin epithelial elements is the adamantinoma. But you can have some aid with Chem 5.2 because this is negative in adamantinoma. And last but not least, malignant mesothelioma is always positive for keratins, especially pan-cytokeratins like AI, AE1, AE3. So if you got any suspicion of malignant mesothelioma, better check with some mesothelial markers like WT1 and calretin. So what is my practical panel for an cancer of unknown primary? Well, that's what I do quite frequently. It's this small panel, one special stain, the Astra, followed by cytokeratin, TTF1, PEX8, CK7, CK20, TDX2, and GATA3. That's for all. And for the women, I also add the estrogen receptor and the progesterone receptor. And in men, I include the androgen receptor and PSMA. So that's how I start when I would like to know where the metastasis comes from. So now we have worked out the theoretical basics. And now we do some exercise. I prepared 6 cases of very common bone metastases as a warm-up, and then we go into the real life, 12 cases from infrequent to challenging. So this is a little bit like rapid fire pathology, but I think it's a good training and sometimes a good quiz to see whether you recognize something that might be of your own special pathology discipline. So the first case, a 52-year-old male. He's got a lesion in the thoracic vertebra, number 7. And the history tells us that there's a clinical suspicion of lung cancer. So now we take the first histological image. The low power image has a blue look. We go to higher magnification. The look is still blue. The nuclei are a little bit smudgy. And if we go to a higher magnification, you see that the chromatin is something like salt and pepper-like. You see some crowding and some molding, like here. The cytoplasm is basically scant, but sometimes of intermediate size. And you see frequent mitoses and apoptosis, like here and here and here. So another image with lots of mitoses. So I give you 1 or 2 seconds just to make your thoughts. And then I will provide some immunohistochemistry. Of course, the salt and pepper chromatin, the smudgy appearance, and some nuclear molding, a high proliferation rate is a little bit suggestive of neuroendocrine differentiation. And we would like to see whether this is true. The cytokeratin is not very intense. I have to say that this might be alterated or even missing in some small cell carcinomas. And basically, we find a rim and dot-like pattern, which is quite well to be recognized here. Not very intense, I know. So, but if we go for neuroendocrine, we have to use an endocrine marker. So this is synaptophysin, and this is strongly positive. So it's an endocrine neoplasm. We add chromogranin with also reliable positivity. And you got another marker, the CD56, not very specific, but usually strongly positive in neuroendocrine differentiated tumors. The Ki67 is very high. So in summary, this fits well to a poorly differentiated neuroendocrine carcinoma of the lung. And follow-up presented a 7 centimeters measuring tumor in the right upper lobe of the lung. The next case is a 76-year-old man, again, suspicion of lung cancer, again with an osteolysis in the lumbar vertebra number 4. So this is the low power view. You see the bone. And you see that the bone marrow is replaced by a lesion here. We take a closer look. Again, some time to think on your own. And then I go to higher magnification, and you see that this tumor forms glandular structures. So this is a gland, also a gland. Maybe those are some vacuoles, but it's difficult to interpret. The tumor cells are polymorphic and show some nuclear atypia. Some atypia is very strong. This is an atypical mitosis. Prominent nucleoli and high variation in size and shape of the cells. And of course, this is cytokeratin positive. And then we go to our special stains, the Astra stain, which highlights the intracytoplasmatic vacuole. So this is adenocarcinoma. And if we got suspicion of lung cancer, of course, we do TTF1. This is positive. And with this simple pattern, it's possible to make the diagnosis of adenocarcinoma with very simple methods. Of course, keep in mind that you might add 1 or 2 additional markers just to be safe. So this is metastasis of adenocarcinoma of the lung. The next case is a 74-year-old woman with suspicion of renal cancer. And she's got an osteolytic lesion in the pelvis. This is the low power view. Here is the bone. Here is the bone marrow. And this is the lesion. the higher magnification. Almost no tumor left, just the lesion. And then we go to the highest magnification, and you see that the nuclei are quite small, but with recognizable and noticeable nuclei. You got a clear cytoplasm, and you get some nested and trabecular architecture with a loose vessel pattern background. And of course, when we think of the possible differential diagnosis, renal cell carcinoma, especially renal cell carcinoma with this clear cell appearance, is highly likely. So what do we do to prove this diagnosis? Of course, cytokeratin, always useful. Then we go for PAX8, a very specific and reliable marker for renal cell carcinoma. Vimentin is a more classic marker, not very specific, but in the past used quite frequently, and of course, positive in renal cell carcinoma. I do not use the Vimentin in the routine panel, but sometimes for reasons of illustration, it works quite well. And the more new and more specific marker would be the carboanhydrase number 9, which we do see here with a very clean green membranous staining. So this all fits to a metastasis of clear cell renal cell carcinoma. Our fourth case, a 73-year-old man. He suffered from prostate cancer in 2012, and now he's got a fracture of the thoracic vertebra and is paraplegic. So when we go for the bone histology, of course, we think, well, first differential is prostate adenocarcinoma. Thus, this might fit to our histology. So this is the bone. And of course, we see some infiltrates. So, and the first question is, might this be prostate adenocarcinoma? So this is more glandular structures with a high level of atypia. It's not possible to recognize any single gland or structures like in the Gleason 3 pattern. It's more like fused glands and high nuclear atypia with some focal area of necrosis. And well, to be sure, to have carcinoma, we do keratin, which is positive. And the glandular appearance lets us think of adenocarcinoma. So what can we do to prove that this is a prostate cancer? We start with PSA. And as I said before, PSMA can be lost by the tumor, especially in advanced stages. And some patients progress even under the PSA surveillance. And if the tumor loses PSA, he goes beyond the screening, and then the tumor can grow and progress. And this might happen here. So we see the PSA staining is in single cells apparent, but most of the tumor cells lost it. Also, a marker that can be challenging to interpret is PSAP. It's basically on the apical side or one side of the tumor cells, but scattered cells are positive. Then we go now to the more specific and sensitive markers. PSMA is a very good marker, therefore it's included in the first panel. And you can see this is a very clean positivity for PSMA. And another very attractive feature for PSMA is that PSMA stains endothelia. So you've got a beautiful internal positive control on your slides when you see those small capillaries. The next marker is very strong and very reliable and very specific. It's the androgen receptor, usually with a strong nuclear positivity and cytoplasmatic co-staining. And also very specific is NKX 3.1. Well, in our hands, it's a little bit cleaner than the androgen receptor, and again, highly reliable. So if we have this bunch of markers positive, the metastasis of prostatic adenocarcinoma is very clear. The next case is a 57-year-old man, and he's got an osteolysis in the rib. This is the low power view. You see that there's very few bone trabeculae, and basically this is all the lesion. We go to a higher magnification and see that this is very well vascularized, lots of vascular spaces. Now the highest magnification. Just make your thoughts. Well, and then you see that those tumor cells are quite small. They have a dense chromatin, and they've got intranuclear inclusions, this brighter areas here. We do not really see grooves. The cytoplasm is quite indistinctive, it's quite clear, and you can imagine some follicular structures. So quite monomorphic, not very atypical tumor. So first of all, this proof, is it cancer? Is it epithelial? Yes, it is. So we go further on in our panel. There's a positivity for CK7. Of course, CK7 is positive in adenocarcinoma, but in many, many other carcinomas. So what I try to highlight is that CK7 is a very useful keratin, but it's no proof of an adenocarcinoma. Then we go to TTF1, and now we've got a quite distinctive selection. So this is likely to be adenocarcinoma of the lung or thyroid cancer. And to go for this, we can make another marker like PAX8. And if we got a nuclear PAX8 positivity along with a TTF1 positivity, it's basically the proof of thyroid cancer. And to go further on, we can do thyroglobulin. And if this is positive, the diagnosis is perfect. And what I did not tell you in advance, this patient had papillary thyroid carcinoma in 2014, had radioactive iodine treatment, and bone metastases are known for a long time. And this osteolysis was a new one. And what I would like to add is that it's difficult to tell which histology the primary tumor was. Of course, this neoplasm has some features of papillary thyroid carcinoma, like the intranuclear inclusions, but of course they are not very specific for papillary thyroid carcinoma and metastasis. So it's very difficult to tell the primary histology, but what we can tell, this comes from the thyroid. So the last case in our warm-up, this is a woman, 92 years old. She had breast cancer in 2019 with liver metastases, and now she's got a spontaneous fracture of the femoral head. This is the bone. Now we go to a higher magnification. You see the bone, and this is the tumor. In the higher magnification, we see gland-like structures, sometimes a little bit nested architecture, epithelioid cells with an intermediate variation in shape and size. We can see visible nucleoli. So, and this is basically the description. What we can also do, we can do the astrostain, which is positive with intranuclear vacuoles. So this might be adenocarcinoma. It's positive for CK7. And in our panel, we have a nuclear staining for GATA3. So if we got adenocarcinoma that's positive for GATA3, it's highly likely to be breast cancer. We can add mammoglobin, which is very sensitive, but can be inhomogeneous. And same with GCDFP15, which also is quite reliable, but not always positive. And if we got the suspicion of breast cancer, we also do the hormone receptors. At the top level, we see the estrogen receptor, and on the bottom, the progesterone receptor, which is also positive. So this is a quite characteristic histological panel and immunohistochemical panel of a metastasis of breast cancer. So this is the warm-up, and now we go to the challenging cases. 12 cases. I try to go through this quite fast, so we see all the 12 cases. A 70-year-old man, he had prostate cancer and colon cancer, and now we got a lesion from the thoracic spine. This is the overview. You see here some woven bone of a fracture region. We see this, atypical glandular structures. And if you show this image to a gastroenteropathologist, I think he will have no worries, because this is the classic morphology of this entity. We see elongated atypical nuclei and gland-like structures with a quite characteristic architecture. And when we do our special stains, of course, it's positive for keratin, and we've got some mucin in the ester stain. More specific markers are CDX2 and CK20. And if you would like to add a fancy marker, you can use the ZB2. So now the pattern is completely finished, and this is the characteristic morphology of colorectal adenocarcinoma. So the final diagnosis is metastasis of colorectal adenocarcinoma, early visible even at the conventional histology. Here's a 80-year-old man. He's got infiltrates in the calvarium bone. Here we see the bone, and here we see quite dense infiltrates. I give you a higher magnification. And here you see nested and whorled tumor cells with psammoma bodies. There are three tumors that do make psammoma bodies. It's the thyroid cancer, it's the cancer of the ovary, and this is the third one that can produce psammoma bodies. And if we do a cytokeratin, it's negative. This is also quite characteristic for this tumor, because meningothelial tumors do not express keratin. So, and this is highly suspicious of meningioma, because we've got nested and meningothelial-like appearance, and we got this psammoma bodies. What can we do to prove this? Of course, it's S100 negative, and it's a bone not very far from the meninges, so it's the calvarium bone. And if we go further on, we can do an EMA stain, which is positive. We can do a somatostatin receptor. We can also do E-cadherin, and meningiomas are also positive for the progesterone receptor. So the final diagnosis is meningioma of WHO grade 3, because we see a characteristic meningothelial architecture, no high-grade atypia, and no elevated mitosis rate. The next case is a 85-year-old female, and she's got painful osteolysis in the humerus. This is the low power view. And now I give you a high power view. And what you see a malignant epithelioid neoplasm with a high level of nuclear atypia and variation in shape and size. The chromatin is coarse. The nuclei are sometimes very prominent. And what you also see, you see a brown pigment. And if you do an iron stain, this is negative for iron, and this lesion is also negative for cytokeratin. So what can you do to go for further analysis? Of of course, you got an endogenous pigment, you got an epithelioid tumor. So malignant melanoma is a very important differential diagnosis. To prove this, you can stain for S100, you can stain for SOC10, that should be nuclear positive. So the final diagnosis in this case is metastasis of malignant melanoma. The next case is a 42-year-old man, and he suffered from a thyroid tumor 6 months ago, and now he's got an osteolysis in the left femur. This is the tumor. This is the higher magnification. So, and this is the maximum image. You see it's an epithelioid neoplasm with mitosis. It's very well vascularized, has some slit-like spaces. It's clearly atypical. The chromatin is coarse. And it's cytokeratin positive. So you might go for carcinoma, but then your whole bunch of immunohistochemistries is negative, including the specific markers for thyroid, like TGF1 and PAX8. So this is the problem, and all others are negative. So we go back to the conventional histology. And if you got an epithelioid neoplasm that shows some aspects of basal formation and is well vascularized and you see a lot of erythrocytes, maybe in the cytoplasm very close to the nuclei, like here, of course you should check for a vascular differentiation. So, and we do this. This is ERK, a nuclear marker for a vascular differentiation. This is CD31, also strongly positive. So this is a vascular neoplasm. And this is high grade. This is malignant. So in summary, this is angiosarcoma. Possibly it's the metastasis of a primary thyroidal angiosarcoma, or maybe an anaplastic thyroid carcinoma with vascular differentiation. We also see the primary tumor, and it was exactly the same image, a malignant vascular tumor with those two possible origins. The next case is a 25-year-old man. He's got a retroperitoneal tumor with compression of the left urethra with clotting. This is the low power view. And this is the high power view. We see gland-like structures. So this is a highly malignant tumor with apoptosis, mitosis, and strong nuclear atypia. And it's cytokeratin positive. So we think of metastatic carcinoma. Unfortunately, all our markers are negative. So the possibility that this is, for example, urothelial carcinoma is quite low. So, but then we think about the age and location. It's a retroperitoneal tumor in a young man. So if you got this, always think of a germ cell tumor. One reliable marker for a germ cell origin is Sol4. You can even take OCT3/4, but Sol4 is the most reliable. And additional clinical information after talking with a doctor, he had a very small lesion in the left testicle. So, and this is a metastasis of testicular cancer here with the appearance of an embryonal carcinoma. It was also CD30 positive, and the patient was treated accordingly. The next case is a 76-year-old woman. She had a previous diagnosis of metastasized malignant mesothelioma and now an osteolysis in the lumbar vertebra. This is the low power magnification. And this is the high power. And we see that this is a basaloid neoplasm with solid architecture, some reminiscent glandular elements. And we see that there are two different kinds of cells. larger cells, and smaller, more basaloid cells. So what might this be? Is this mesothelioma? So, might be. It is strongly positive for cytokeratin, but the other mesothelial markers were negative. Calretinin was negative and WT1 was negative. So we looked for the differential diagnosis of other basaloid tumors, and we found some positivity for S100 and SMA. So if you got cytokeratin, S100, and SMA positivity with a basaloid solid neoplasm, you might go for a MIP translocation, which was positive in this tumor. So this was the metastasis of an adenoid cystic carcinoma of the lung, previously mistaken as a malignant mesothelioma. The next case is a 78-year-old man with an osteolysis in the lumbar spine and a known hepatocellular carcinoma. We see dense infiltrates of a tumor that forms glandular and strand-like structures. And this might be well compatible with a hepatocellular carcinoma, as we have got prominent eosinophilic nucleoli, characteristic architecture, a quite broad cytoplasm, and a large variation in size and shape of the nuclei. To prove the hepatic origin, we can go for HepAR1, which was positive in this case. We can add glypican-3, but the most reliable thing we can do is an in situ hybridization for albumin, which is positive in about 50% of all hepatocellular carcinomas. So this albumin fish proves the metastasis of hepatocellular carcinoma. The next case is a 15-year-old boy, and he's got multiple osteolyses in the left lower extremity, tibia calcaneus, and lots of other bones. So this is the low power view. This is the higher power view, lots of reactive bone. So this is the lesion. It's more spindle cell with intermingled osteoblasts. And of course, this looks quite benign. And from the conventional histology, this also might be a non-ossifying fibroma. But if you do cytokeratin, it's positive. And if you see this architecture, this might be a clue for the nature of the lesion. As we know that vascular neoplasms are also positive for cytokeratin, we can do some vascular markers. And this is ERK, strongly positive on the nuclear level. And we've got C31, which is also very positive. So this is a benign, or well, this is a benign but aggressive growing neoplasm. So this is epithelioid hemangioma of bone. One vascular tumor of the bone that is positive for cytokeratin. Case number 16, a 41-year-old woman. She's got an osteoblastic lesion in the right humerus. There we see dense infiltrates and reactive sclerotic bone. A quite monomorphic lesion, a little bit gland-like. And the nuclei are something like hyperchromatic with some salt and pepper appearance. So first of all, we check for cytokeratin, which is positive. So this is some epithelial tumor. And then we had a positivity for CDX2. And given this bland morphology and the positivity for CDX2 and the neuroendocrine appearance, we tested for neuroendocrine markers, and synaptophysin was positive. Usually it's very difficult to name the location of the primary tumor. But in this case, we extended our panel and we found some positivity for somatostatin receptor and also for islet-1. And therefore, we could make the conclusion of metastasis of pancreatic neuroendocrine tumor, G2. So the next case is a 71-year-old man who had prostate cancer, and now he had an osteolysis of his thoracic vertebra. So this is the low power view. This is the higher power view. And this does not look like a prostate cancer. This doesn't look more like a spindle and pleomorphic sarcoma. So let's see whether there is some positivity for cytokeratin. We had this. And so we went on to look the whole material. We found this, some glandular structures. And those glandular structures were very positive for cytokeratin. And then we went for prosthetic markers. So this is the androgen receptor, and we see positivity in the glandular structures and less intensive, but true in the spindle cell component. Then we added NKX 3.1. And interestingly, we had some co-expression of CK7, which is very unusual for prostate cancer, and also CK20, which might be. But in the end, this is a metastasis of a sarcomatoid carcinoma of the prostate, luckily with some reminiscent gland-like structures. Otherwise, this would be a very, very difficult diagnosis. So quickly, the last two cases. This is a 56-year-old man with non-malignant pleural mesothelioma, suspicion of bone metastasis. This is it. And in the intermediate power view, you see an epithelioid tumor with large nuclei and a broad cytoplasm with a mesothelial appearance, with a variation in size, but not so much in shape of the nuclei. Of course, this is cytokeratin positive, which can be a pitfall. But if you do additional markers like BRP4, this is negative. But keep in mind that malignant mesothelioma can be positive for BRP4 in about 20% of the cases. But what you can do, you can prove the mesothelial origin with WT1. You can add calretinin, and so you come to quite a good conclusion to a metastasis of malignant mesothelioma. So I go to the last case. This is quite short. This is a woman, 48 years old, and she had a solitary fibrous tumor in the calf 2013. Now she's got multiple pathologic fractures in the spine and lung metastases. This is the image of a bone metastasis. This is the higher magnification. And if you go deeper into it, we see this characteristic patternless pattern. Today, it's not very en vogue to say patternless pattern, because if you say patternless pattern, everyone says, yeah, well, this is solitary fibrous tumor. But we've got one more thing, this HPC-like vessels, arborizing vessels that are a little bit dilated. So what we can do to prove this, we can make one immunohistochemistry, which is STAT6, that should be positive on the nuclear level. So this is the metastasis of a malignant solitary fibrous tumor with a delay of about 7 years, which is not very uncharacteristic for solitary fibrous tumor. So the take-home message is bone metastases, as I said before, are more prevalent than primary bone tumors. The most common primary sites are lung, breast, prostate, kidney, and thyroid. Any bone can be affected, and bone metastases are more frequent in elderly patients. It's very important to know the patient's history. About half of the cases could be solved with the patient's history in the conventional histology. The immunohistochemistry was only to prove this diagnosis. So patient's history, clinical context, and conventional histomorphology on H&E are most important. Any malignant tumor can metastasize to the bone, and please stay open-minded for any differential diagnosis. Now the acknowledgements, well, I would like to thank Dr. David Doom, who's my frozen section backup, because unfortunately I'm on frozen section this week. Thanks to Doris Höfelmeier, she's my orthopedic pathology backup, and she takes some cases from me that the pulse don't kill me today. And thanks to Dr. Maximilian Larratz and Niklas Blessin, who gave me technical support in introducing me into the scanning facilities, because all the images I made have been made with a scanning facility. Well, and now it's up to you to see whether artificial intelligence will solve all these 18 cases. If artificial intelligence solves all these 18 cases, I will retire at once. So, and with this in mind, I thank you for your attention, and I'm happy to answer questions. Thank you.
Thank you so much, Dr. Andreas, for being with us again and for presenting such a fabulous practical topic on bone metastasis. Personally, I really enjoyed from your warm-up cases and also challenging ones. I would like to ask the audience if they have any questions. Please ask from Dr. Andreas. Any question? Okay, thank you, Dr. Andreas, for the presentation again. Yeah, so for now, we move on to our next speakers. So we have three speakers, honorable speakers from Morpho Lab. So I welcome first I welcome Dr. Sandhya Sundaram, HOD Pathology Department, SRMC, and then Mr. Rohit Highwell, CEO Morpho Labs, and Mr. Sonal Daniel, VP Morpho Labs from India, to present their workshop. So please, Dr. Sandhya.
A very good afternoon. Sir, I think there will be first a presentation by Daniel from Morpho.
Okay, all right.
After which I will be presenting my study, collaborative study with IIT Madras. Or if you want me, I can start directly also. Daniel, are you there? Mr. Daniel?
If not, you just go ahead, please.
Okay, then I'll go ahead. Yeah, sure.
Yeah.
Let me just share my screen here. Yeah, 1 minute, sir. I'll just share my screen.
And again, introduce yourself, Dr.
Yeah,
Sandhya, please.
Yes, I will
Thank
introduce myself. Yeah. So let me first share my screen, sir, so that I can. Can you see my screen here? Are you able to see my screen, sir?
Yes, it's good.
So I will just, first let me introduce myself, and then I will go on to. So I'm Dr. Sandhya Sundaram, Professor and Head, Department of Pathology. This is from Sri Ramchandra Medical College and Research Institute, which is in Porur, Chennai. Chennai is the southernmost part of, Chennai is in Tamil Nadu, capital of Tamil Nadu. And this is a work that I have done in collaboration with IIT Madras, which is also in Chennai, India. And basically, this work is about analysis of tumor infiltrating lymphocytes. Let me just open my screen, full screen. Yeah, so let me open it full screen. Yeah. Yes, so the heading of the title of my study is Analysis of Tumor Infiltrating Lymphocytes and its Subset in Carcinoma Breast Using Computational Algorithms. And my co-authors are Mahalakshmi Ramadas, Punita, Dr. Ramakrishnan, and Dr. Devarajan Karnakaran. And this is a collaborative study. And breast cancer is one of the commonest malignancies that we see here in India. And there are many parameters which we use on day-to-day basis actually to analyze breast cancer. But a new concept that has come is the tumor infiltrating lymphocyte and its subset, which have a critical role in malignancy, and they influence tumor behavior. And they also predict response to therapy in breast cancer tissues. So these are the inflammatory cells which are seen around the tumor. And it has been shown that the degree of lymphocytic infiltration is now known to influence tumor behavior. And in the tumor infiltrating lymphocyte, there is a subset called the CD8 T cells, which plays an essential role in mediating response to chemotherapy and clinical outcome. And this is also a very promising target for immunotherapy. And so with this background, we thought that an objective evaluation of tumor infiltrating lymphocyte and its subset, the CD8 T cells, across the tumor tissue may be of great value. So as you can see, this is the tumor microenvironment, which consists of plenty of cells. So these are the tumor cells, and around the tumor cells, now this is actually in histology, as you see, you can see these large tumor cells, and just outside of the tumor cells, infiltrating them, you can see these dark blue cells, which are lymphocytes. Now, initially, they were thought to play, they were just thought to be bystanders, innocent bystanders. But now we know with major papers that these seem to have a definite role. They seem to play a definite role in tumor behavior, and therefore analysis of tumor infiltrating lymphocyte seems to have a major prognostic importance. Now, currently, breast cancer, we categorize according to morphological classification, whether it's infiltrating ductal, whether it's a lobular carcinoma, whether it's a medullary carcinoma, etc. Or we look at histological grade, depending on the Nottingham's Bloom-Richardson grading of whether it's grade 1, grade 2, or grade 3. And then we go and do the molecular subtyping using the ER, PR, HER2/neu, and of course Ki67. And then a clinical and pathological staging, the TNM staging is done, which depends on tumor size, nodal status, and metastasis. But this information remains inadequate because sometimes similar features have different outcomes. And the major lacunae is in predicting aggressiveness and metastatic potential. And so there is a need to identify more parameters which will separate the low risk from the high risk cases. And so the TILs, that is a tumor infiltrating lymphocytes, and its subset T cells are now evolving into important parameters, and they may play a major role in deciding the behavior pattern of breast carcinoma. So with this background, the aims and objectives of our study was to analyze tumor infiltrating lymphocytes in breast carcinoma tissue across molecular subtypes, and then to evaluate the CD8 T cells, which is a subpopulation of tumor infiltrating lymphocytes, particularly the triple negative type of breast cancer in neoadjuvant chemotherapy settings. And then with the help of IIT Madras, we also designed the computational algorithms, which will help us to evaluate the TILs and CD8 T cells, and then to comprehensively analyze all these results and then correlate them with clinico-pathological parameters and tumor characteristics. So these were our aims and objectives, looking at tumor infiltrating lymphocytes and CD8 T cells, which is a subpopulation of tumor infiltrating lymphocytes. So what we did is we first looked at tumor infiltrating lymphocytes in freshly stained hematoxylin neosin stained slides of breast carcinoma cells. And these slides were digitally scanned by our Morphal scanner. And then we took 10 patches. We looked across the scan slides and we took 10 patches which had the maximal tumor infiltrating areas. And these were photographed across from the face section of the slide. And then the immune cells in the area were meticulously annotated. We had to look at the area which had the tumor infiltrating lymphocytes. And then a computational algorithm was designed, which was based on, this was of course purely a machine learning algorithm, the MATLAB software that they used to actually create an algorithm which will help us to look at the TIL area. And then a TIL area was calculated looking at the area of blue cells divided by area of the entire area of the stromal area minus the area of the tumor into 100, which gave us a percentage of the tumor infiltrating lymphocyte area. So if it was less than 10%, it was considered as low TIL. If it was 11 to 49%, it was considered as moderate. And if it was greater than 50%, it was considered as high. And these results were then analyzed using statistical methods. So we did it in 50 cases and then divided them into low, moderate TIL infiltration and high TIL. So these were the parameters that were analyzed. So this is just to show how we use the Morphal scanner to scan the entire slide. And then we picked up the area where there was a lot of TILs and 10 patches were drawn. As you can see, this is a tumor area and this is the TIL area where you can see these dark lymphocytes infiltrating the tumor cells. These are the tumor cells. And so we drew the area of the tumor infiltrating lymphocytes. The other part of the study was looking at the CD8 T lymphocytes. Now, all of them were stained. The TN triple negative, which is very rich in tumor infiltrating lymphocytes, was stained by IHC for CD8 T cells. The slides were again digitally scanned by Morphle, and then the immune cells were annotated. And here we counted the CD8 count and made that into percentage using again the same algorithm, the computational algorithm, which was designed to actually help us to count the CD8 cells. And this was again done on a MATLAB software by contrast enhancement, segmentation, and morphological reconstruction. And once the CD8 count was determined, we correlated the count with the tumor characteristics and chemotherapy outcome. The percentage of CD8 cells were calculated by depending on the number in this particular picture. The CD8 T cells are very nicely, marked by the brown color of the cells. So this is the TIL area among the tumor cells, and the ones which have taken up the brown stain are the CD8 T cells. And so we calculate the percentage by using this formula: number of brown cells by total number of cells into 100. So we got a percentage of CD8 T cells. So this is how it looks. This is again a scan slide which helped us to actually annotate these CD8 T cells. As you can see, again, these brown colored slides are the CD8 T cells. Now looking at the results. Now, tumor infiltrating lymphocytes, we were evaluated based on computational algorithm. We evaluated them based on the guidelines of the International Working Group for TILs. This algorithm, which was constructed, as I said, was in MATLAB software. And this gave us an objective assessment of TIL in the stromal area. And then we assigned a grade to the tumor infiltrating lymphocytes into low, moderate, and high. And the segmentation of the cells gave clarity to the TILs, which facilitated in the counting. This is the example. Now, this is the original picture. As you can see, these are the tumor areas. And this is the stromal infiltrating, the tumor infiltrating cells in the stromal area. Then there was using the software, we enhanced the image. And then using the computational algorithms, all the cells which were tumor infiltrating were marked. And then a percentage was drawn using the algorithm. In this case, it came as the TIL area came to 61%. Now we all know that as I said earlier in my materials and methods, anything about 50% was considered as high. So this case is TIL grade high. And this was then the 50 cases were analyzed depending upon whether they had low TIL, moderate TIL, or high TIL. Right? And so when we analyzed it statistically, we found that triple negative, the one type of breast carcinoma, the molecular type, showed the highest TIL when compared to other subtypes. TIL was also seen in high-grade tumors. That means higher tumor-infiltrating lymphocytes were seen in high-grade tumors. They were also positive in node-positive cases. Whichever were node-positive showed high TILs. But of course, no association was seen between age of the patient and size of the tumor. So the tumor-infiltrating lymphocytes correlated positively with the grade, with the nodal status, and with the molecular subtype, that is the triple negative, showed the highest TIL in our study. The second part is the CD8 T lymphocytes. As I said earlier, that we used IHC, immunohistochemistry, to mark out the CD8 T cells. So this is the original image of the tumor infiltrating area, which has marked out the CD8 T cells. And then we did the contrast enhancement of the image, and then a clustered image was created to mark out these brown cells using the algorithm. And then we took out all the cells, all of the binary cells were counted, and only the brown cells were again counted. So this gave us a percentage. That means the total number of brown cells were 577. All the cells were 766. So the percentage of brown cells was 75, which means the CD8 T cell percentage was 75%, which means that the CD8 T cell grade is high and the patient has a good immune response. So this particular algorithm helped us to give an exact percentage of CD8 T cells among the total TIL population. And so this helped us to analyze the CD8 T cells. Now this was analyzed in our 30 samples of the triple negative breast carcinoma. And as you can see, high CD8 T cell percentage was seen in high grade lesions. Whichever had high grade lesions were seen in high grade lesion, you saw high CD8 T cells. A good pathological response. This was done in biopsies. So when the patient underwent chemotherapy and we got the final mastectomy specimens, we looked at the percentage of chemotherapy. We looked at the chemotherapy response, and it showed that high CD8 count, that is those which had high CD8 count, for example, this one, wherever there was high CD8 count, there was good pathological response. So 60% with high CD8 T cell count showed good pathological response, and 42% with moderate CD8 showed good pathological response, though this was not statistically significant. Nodal metastasis and tumor size did not show any association with CD8 T cell count. So, one thing was interesting to note, that higher the CD8 count, in our case, we saw good pathological response following neoadjuvant chemotherapy. So the conclusions of our study, this is a small, a pilot study with tumor infiltrating lymphocytes in 50 cases and CD8 T cells in 30 cases. The TIL grade showed positive correlation with tumor grade and nodal status. Triple negative, which is one particular molecular subtype, showed high TIL density among the subtypes. CD8 T cell, which is a subtype of the tumor infiltrating lymphocytes, were analyzed using computational methods, and those who underwent subsequent surgery, we analyzed whether they had a good pathological response, and we found that a good pathological response was seen in patients which had high CD8 T cell count. Of course, this was not statistically significant. Our sample size was only 30 cases. And one thing we realized is digital scanning of these slides, which we did with the Morphal scanner, helped us in evaluating the tissue sections effectively, so that we could look at the hotspot areas where there was tumor infiltrating lymphocytes, as well as also to localize the areas of CD8 T cells. Of course, this is a prelim study, and we have to further investigate the role of other immune cells. Here we have looked only at main tumor infiltrating lymphocytes and CD8 T cells, but definitely there will be there are other immune cells like CD4 cells, and you have the FOXP3 cells, etc., which may also have influence in tumor behavior, and that is the future scope. And of course, we also need to build up multi-parameter algorithms, digital algorithms using the digital scan slides, so that we can also determine other subtle tumor characteristics which may help us in risk stratification. Breast cancer happens to be the commonest malignancy across the world, and now it has become the commonest malignancy for past 10 years in the Indian subcontinent. And any parameter added which will help us to risk stratify would be of great value to the patient. And therefore, I thought my study would have a future scope if I do it in larger samples. I thank and acknowledge my co-authors. I thank the Applied Mechanics Department of IIT Madras, which helped me in making this computational algorithm. And of course, Morphal Digital Pathology Scanner, which we have and we use to scan all our slides. Thank you once again, and these are my references. I'll be more than happy to take questions if there are any. Thank you once again for this wonderful conference, for giving me this opportunity to present my work and also to present my findings to this very august audience. Thank you.
Thanks a lot. Thanks a lot, Dr. Sandhya Sundaram, for being with us and presenting such a wonderful topic. So I would like to now, if there is any question from Dr. Sandhya, please, from the audience. If not, for now, we just move on to our next speaker from Morphal Labs, Mr. Rohit Highwell or Mr. Sonal Daniel.
Yeah, hi, this is Rohit from Morphal. Hello, everyone.
Hi.
Hi. Hello, Dr. Ali. Thanks for the opportunity to present what we have.
No problem.
Awesome.
No problem. Please, yeah. Please share your screen and presentation and introduce yourself again.
Yes. So more than presentation, we actually have more of an interactive digital pathology session. So where we are going to try and tele-report a slide that we have here. So see, the idea is that we build whole slide scanners. We have sold many of them, and we have lots of customers using for different purposes. Like Dr. Sandhya, who is using it to accelerate her research with computational pathology. There are a few other people who are trying to use it for educational purposes, hosting conferences, hosting digital seminars, or even day-to-day digital pathology teaching for their UG and PG students. But beyond that, the primary reason for scanners were invented has been the telereporting, of course, which is the most important use case. So what do you really need to tele-report a slide? You need a good image quality whole slide scanner and a viewer software that works on your phone or your tablet, your laptop with your kind of internet connection. I think that's all you need. And let's try, and if the idea here is to, of this workshop is to, try and scan your slide, and then I'll share with you a link which you can actually diagnose. So just to prove that, it can work on any device, any internet connection across the audience that we have today. So let us try that. So with me, I have this scanner, which is the 6-slide scanner. So this is how the cassette inside the scanner looks. So it can accommodate 6 slides at a time. We are putting a few slides here, so we can simply unclamp it here. It's as simple as that, pressing it down, lifting the slide, and for a new slide, we can just put it here in the slot and release the clamp. So it auto aligns in exactly one position, and that's all from the hardware interaction side. So once we have loaded the slides, we have to insert them into the scanner. And beyond that, the whole workflow is fully digital. So I'm going to share my screen from the scanner computer, which has the driving software. I hope you can see my screen now. All right, so right now we are at the control panel, which has the scanning option. So I'm going to click on that. Yeah. So it is asking me to place this cassette into the slot, which we just did. So I'm going to go ahead. Right. So now we have 6 slots in the scanner. So I'm going to try and scanning one of the slots for the workshop purpose. I'm going to scan the slot number 2, for example, and it has a macro camera which takes like a single shot overview image of the slide for you to understand like what's on the slide in a macro fashion. Like you can choose the region if you want to. Like here you can see there are 5 sections on the same slide. Let's say we scan just one of the sections. All right. I can just draw a box around the section that I want, and I just say click to confirm. It is auto detecting the tissue area, so it does not waste time scanning the rest of the slide. And I think that's all. Like everything is like pre-calibrated. Like there is also a barcode reader. In this case, there is no barcode. Otherwise, it will pick up the number from the barcode directly. Let's say we name the case as case 1. And yeah, that's it. Click to confirm, and you can just start scanning. It's that simple. It's like few clicks, and the scan is starting now. So the idea here is that it uses a 40x objective to scan the slide. I mean, like many of you might be aware of digital pathology, how it works, but 40x is the preferred magnification for primary diagnosis, and that's exactly the optics that we use here. Initially, it does like a coarse focus, like a regular microscope. The idea of the coarse focus is to understand the slide thickness, because the slide thickness can vary across labs, across procedures. And once the coarse focus is done, then it keeps moving around the slide, collecting multiple images. So it takes anywhere between 1 minute to 3 minutes for a typical histopathology slide. A cytology slide, which is like a full smear, would take like roughly 5 to 6 minutes. This would probably finish under a minute. Yeah, while it is scanning, let me show you how the viewer operates, because you will need to know how the viewer operates to tele-report the link I'm going to share with you. So yeah, so these are a few scans that we have historically. So when I share with you a link, you will get a dashboard link, which will have one slide, because we did just one slide, but something similar. And here you can just click on one of the scans. For example, let me click on the liquid-based cytology scan. And here you can use your mouse, or if you're using your phone, you can just pinch to zoom further. And it will seamlessly zoom till like 80x magnification. So it's very simple. You just pinch in and you zoom in. You can use your keyboard, if you have a keyboard, to navigate around, left, right, up, down. or you can also click and drag it to go across the different regions. So it's pretty seamless. Yeah. I think it will take another 10 seconds to 10-15 seconds to scan. So yeah. So let's just wait for like 10 seconds and I will be able to share a link with you for the scan that we have done. I guess it is just finishing up. It also has like a smart algorithm which can detect the slight tilt and it compensates for that, because the microtomy blade might be loose and the tissue may not be perfectly flat. And that's one of the major reasons, like, the scanning technology can have blurred images. And that is where we have tried to solve the problem using algorithms to, adjust the focus levels based on an image-based feedback loop that we have baked into our system. So, yeah. I think it will just take a few more seconds. Yeah, I think the scan is done here. The cassette has been ejected. You can see that I'm going to stop the screen share for now. So yeah, you can see that I have the cassette back. So, and the scan is done. I'm going to just share the link with you for a remote diagnosis. I'm sharing it with everybody in the chat section. Yeah. So you can just click on the link. For the purpose of this workshop, we have removed the password protection, so you don't need to enter any username password. Otherwise, you do need to do that. So please feel free to, so this is basically, I'll explain you how this link works. So this is something called as a static IP address. So our office here, the demo station is connected to internet through a static IP address, which you can get from any of your internet providers. And you can simply access this server from anywhere in the world. So that's exactly what we are going to do now. This is how most of our users are using telereporting across the globe. So I hope you can click this and diagnose. Would love to know any feedback on the image quality. You can message us in the chat section. So, all right. Thank you, Dr. Thanjam.
Rohit, how much of internet speed we need for the images to come on clearly, Rohit, if any?
I think typically 1 Mbps to 2 Mbps, as small as 1 Mbps should be good enough.
Wonderful. That's really good.
Yeah, so that's the important part. So that's why I would like to understand, like, if anybody is facing any problems, we can just understand like what's wrong with it. But it should work largely for everybody, even on your phones. So you don't need to download any software. That's the beauty of this. It just works on your Google Chrome or Firefox or Safari, any web browser. And it's a very seamless, very easy thing to use. So I'm going to do the same thing here. So let me just share my screen here. And once you click on the link, you will land up on a page like this. And you will see I have a case one here that we scanned. I'm going to click on it. And so you can see that it is scanned at 40x. So I can zoom in till 40x. I can clearly see even the nuclear details. This is at 40x. And I can enable digital zoom if I want to go beyond 40x. So it will go to 80x. Feel free to drop us any feedback around the image quality. If you're not able to access, let us know. All right. So, all right. So while you try and scan these, try and diagnose this, it's actually a spot diagnosis. It's a Signet's ring cell carcinoma.
Yes.
So,
I think Rohit is getting more familiar with
yeah. All right. All right. So while we are at it, let me show you a few other features for the viewer software, which are very useful in a typical day-to-day setting. I'm going to share my screen again. Yeah, all right. So there is one more very interesting feature that is super helpful for comparing IHC with HE sections at the same time. So as you can see on my screen, I have two sections. One is HE on the left, and on the right I have this is a bone marrow, and we have IHC CD3 CD20 multiplex, and you can see that I can scroll. I can navigate them together. So for example, I'll try to go to this lymphoid aggregate. Hold on, let me just sync it one more time. Yeah, so this is a lymphoid aggregate. So when I zoom into one lymphoid aggregate on the CD3, CD20, which is pretty easy to navigate to, I can see the same region under HE. So now conventionally, you would have multiple slides and you will switch between them. You may have a marker and you are marking on one and you're flipping the two. So it's very, very tedious. Here, on the other hand, because it is all digital, we can just overlay them side by side, and you get to see them together. And this is configurable to have for like a 4-slide panel or a 12-slide panel. This can extend into like multi-view system. So this is something super interesting. Apart from that, there are a few very important tools that are super useful for morphometry and annotations for research and even diagnostic purpose. So I'm going to cover that next. So let's say I go to, all right, this is a small biopsy. And so one of the most important tools here is a simple measurement tool. So I can just drop 2 points. I can choose this tool, line tool, drop 1 point and drop the other point. So I can see that it is giving me the measurement. It's 1.27 mm. And I can even do much smaller dimensions. So if I want to just, just go to ATX. Yeah. If I just want to do this diameter of a cell, I can get up to 6.74 microns. So it is very accurate. It is calibrated with a micrometer slide, and it helps you measure things at a micron level, which you cannot do otherwise on a microscope. So this is where like nuclear morphometry or any kind of morphometrical analysis is much easier to do with a digital system. All right. Next, we can just draw a box around a region of interest. For example, yeah, I can just draw a box and I can just label it. So you can see that the label comes across the box, and I can even leave some comments. Yeah, so something like that. And my collaborator, who can also log into the same case from another place, another laptop, and they can leave their comments on top of this. So it becomes like an interactive comments around the region of interest. So that becomes super helpful when you have multiple pathologists working on the same case, reviews happening, or it could also be like basically a surgical panel discussing a case. So these are very super useful tools. Now, there is one more pretty important feature for which we have built for, especially for cytology, where you need to track a few cells and you have some reference cells. So I'm just going to walk you through that. Yeah. So yeah, let me just open the LBC case. Here, while we annotate things, there is a very important feature that, I can, first of all, I can just simply annotate a cell. I can just draw a circle around it. And as you can see, like I'm getting a list of all the annotations that I have. And I can simply go to the grid mode and see all the cells together. So while I keep diagnosing, while I keep moving across the slide, I can refer to these cells. So this becomes super useful for diagnosis. Apart from that, cytology is also where you can't miss a segment, miss any region of the whole slide. And for that purpose, we have built this area tracking tool on the top. It's a pretty neat one. So when I switch on the area tracking, and then if I'm moving around, then it is painting the region that I have seen in green color, for example. And you can see that while I'm going in a snake pattern, I missed that small gap there. So this lets me understand that, and I can just drag it back and look at it again. So this way, I can objectively ensure that everything in the slide is seen. So these are some small tools. These are digital overlays on top of microscopy, which you couldn't have in like an analog setup, but that becomes possible in the digital space. And that is where digital pathology really shines for you. So yeah, I think these are some basic features that we covered. We have, if time permits, Dr. Ali, there is one more modality of digital pathology that is coming up recently called live mode for rows, like rapid on-site evaluation of cytology or frozen sections, where you are not scanning the whole slide, but it's more like a live mode with the low preview scanning, low magnification scanning, and a live mode. So we can actually cover that in like next 10 to 15 minutes, if time permits, with your permission.
Yes, please. Yes, please go on.
All right, all right. So we'll move to that in a minute. If there are any questions, should we take the questions now?
Any questions? Any questions from the participants?
Rohit, I have a question.
Yes, ma'am.
So basically, you said that IHC overlap feature, no?
Right.
The IHC overlap feature. Can it be done for multiple? I mean, we are using this morphal regularly for both teaching sessions and all the other things. This overlap that you said, the IHC and the HE overlap, can it be done for multiple images of different IHCs together, Rohit? Or how does one use that? Because that is a feature that I haven't used. That's why I'm kind of interested.
Absolutely, absolutely. So yes, it can be configured to have 4, for example, like you can have, let's say, 5 slides, HE, ERPR, HER2, KS67, all of them together on the same screen. Of course, you will need a slightly bigger screen to use it effectively, but yes, you can do that. Great. All right. So next, we are going to switch the camera to the next scanner, which is the latest addition, like on popular demand.
Rohit, we can't hear you. Rohit, we can't hear you.
Sorry. Yeah. I hope everybody can hear me now. So with me, I have the next version of the scanner, 6X. So this has a very important feature called live microscopy. So what it does is it takes a scan with just a 4X objective. It's very fast. It will take hardly 30 seconds to take the scan. So let's actually start the workflow. I'll explain you while we are with the workflow. So have you connected this? Okay. So let me just share my screen from here. Just give me 30 seconds. We need to connect this to Zoom.
Yes, please go on.
All right, we are all set. So you can see this is a special mode. This is called the live mode. So this is a FNAC slide that I have with me. And as you can see on the right, there are 6 slots. So the first 2 slots are loaded. For the purpose of demo, we have already loaded the previews of it. So this is the preview actually. I'm zooming out on the preview. So you can see that this is actually a whole slide scan, but not at a high power objective. It is scanned at a somewhere around 4x objective. So it is meant to be a navigation pad. And this scan will happen very, very fast. Even for like such a large, like full smear on a slide, it will take hardly 30 seconds. So here, I can just zoom into one of the areas. Of course, the cells are looking slightly blurry because this is a 4x objective that we have used. And once you click on one of the objectives, it gets me the image at 40x at the same place. So and there is something called the Z-stack feature on the left-hand side. So Z-stack means if I use my mouse wheel to scroll, it is scrolling from, you can see the layers here. It is initially it is at 0, then I can scroll it down to -5, and I can scroll it up to +5. So either both the sides the image will blur, but when the cells are overlapping, you will be able to see the different focal planes and the different features across the cells. So all right, so I can just zoom out in the preview and move around to the region of interest, and simply click on the region of interest, the cluster of cells that I want to see, and I get to see the full 40x image here. And so the beauty of this is that if you are trying to do adequacy evaluation for cytology and the patient is waiting and the radiologist is waiting whether to go for another pass or not, the pathologist can remotely report within a minute and get the diagnosis, not the diagnosis, at least the adequacy out. Even this can be used for diagnosis as per se, but this is designed for very urgent reporting kind of a use case. And most importantly, this is again like fully web based, so I can again share with you a link. Daniel, let's just share the link and share it with you. Yeah. So basically, meanwhile, let me show you while we share the link with you, let me show you the second slot as well. So sorry, this was the second slot. Now we are going to the first slot. So it is now taking a preview. It will take a few seconds to take the preview. So let's just wait for it. Yeah. So you can see that this is another smear, and I can navigate to any spot and I can click on it, and it will get me the Z-stack image at that place. Because this is the first field, it is doing the coarse focus, so it's going to take like 4 or 5 seconds extra. Yeah, we have it now. So you can see the Z-stack here. Like some of the cells, these are overlapping cells, and you can see the field of depth of field changing between the cells. Now, if you understand one more thing here, like we have this scanner has a cover slip and a no cover slip, both the objectives, so you can switch between the two. So basically, you may have smears which do not have cover slip and you want to report immediately, and you don't even want to wait for the cover slip to be put or to be dried. So a no cover slip objective is used in that case. And for the slightly older slides, you can of course use the cover slips where the cover slips are there already in place. Apart from that, there is also settings, so we can increase the exposures or the different parameters in real time. So if the slide is overstained, I can just increase the exposure to brighten things up. If I brighten it too much, of course it will wash out. So you can see that it is starting to wash out here. But yeah, I'll keep it in the mid-range for the best experience. And this is again tunable for you. So yeah. So Daniel, are we ready with the link? All right. So okay. All right, so I'm just going to share a link with you so this link will allow you to remotely access this the same live mode. So that's what you would do remotely in practice as well. Once you click on the link, you will land up on. It will ask you for a passcode. I'm giving you the passcode here, 8822. So yeah, please try and see if you can access the live mode. So there are two modes there. One is the controller mode and the observer mode. So one person can control and other people can observe. So maybe you can go into the observer mode while I control from here, because there are too many people in this case. Usually there will be like not more than 5 pathologists using this kind of a setup at once. So let me know if somebody is having any problems, experiencing being able to open the user interface. So
a new link or the same link, Rohit?
I have shared a new link here.
Okay. There's only one link.
We haven't received anything yet.
Yeah, there is only one link, Rohit.
Yeah, please.
Now there is.
Yes.
I've shared it now. Yeah.
Now there is another link.
So please try the link.
Yeah.
You enter the passcode and you actually enter the observer mode. Because whoever tries to control it first gets the control. We haven't placed the administrative control here, but so everybody join in so that I can control it and you can see it. Or maybe Dr. Sandhya, you can try controlling it and others can observe it. Like just one, there should be one control.
The link is still opening, Rohit. The earlier link opened. This one is still. Professor Ali, are you able to open the link?
I'll try now. Just a moment.
Achha, I think there are a lot of us trying to open it.
Please.
Maybe somebody has put up in the. I think Professor Sadia has put something there. I'm still trying to open it, Rohit. It's just trying to come.
Right. So, anyways, meanwhile, let me show you a few more things here. So there is a layer count and the step size here. So the layer count is 11 and the step size is 0.5 microns. This means that it is taking, when it is going into the Z-stack mode, it is taking 11 steps of 0.5 microns.
Okay.
And the main focal plane plus minus 5 microns. Sorry, plus minus 2.5 microns is what it is doing. So it's like a full volume of 5 micron getting sliced into 11 layers of half micron. So that is how it is done. Typically for a cytology, if you have like thick sections, thick smears, or like any kind of thick sections, you can again increase this. So I can increase this from 11 to.
Rohit, I'm not able to get that. What did you say? If you have thick sections, you can try and modify it, is it?
Yes, yes.
Okay.
So let me go into the controller mode here. Yeah, so I'm going to change the Z-stack setting here so that for like default setting is 11 and 5.5. So let's say I want more, instead of 11, if I do, let's say a very large, I don't know, like 31, for example. So yeah, now it got 31. So both sides it got 15, minus 15 to plus 15. You can see that it is getting very blurred towards the end. But yeah, in case of thick sections, this will be useful. So the 0th layer will always be good. And the important thing to note here is like, I'm not sure how many of you have been able to log in. But when I click on this, even remotely, it takes not more than 2 seconds for the Z-stack to load. So this is very fast. So it almost feels like using a microscope, because see, like on the right-hand side, you have a navigation pad, right? So that's like your scanner view with the 4X. And on the left, I get like a high power view and I get a Z-stack feature. So the beauty of Z-stack is that, if you're using a mouse, then when you move the mouse wheel, the Z-stack changes. So that almost feels like it's like your fine focus knob on your microscope. So it is that fast because all the images are already loaded in your web browser and it is not fetching the images as you scroll. So it is all loaded, preloaded, and hence it becomes very, very fast. So
I'm sorry, Mr. Rohit, can you hear me now?
Yes, I can hear you.
Yeah. Could you please answer the questions in the chat box?
Yes, I'll do that. Okay.
Yes, please.
What's the username? Hold on. Username. Demo and morphology. Okay. Username. Username is demo, and password is morphology digipath. Yeah.
Yeah, there are some other questions as well.
Right. All right. So, Dr. Sadia, did the link open up for you? And was it laggy or did it not open?
The link certainly did open after 5 minutes, but there aren't any images displayed for me to see.
All right.
Could you again repeat the login name, the username?
The username is demo, D-E-M-O.
V.
Demo, D-E-M-O. Yeah. Right.
Invalid username or password?
Password is morphology digipath. You can see it here.
Okay.
And just try refreshing the page, Dr. Sadia. It might start moving now.
Link is taking time to open, Rohit. It's not really. The earlier link was opening, but the second link is kind of, maybe, does it depend on the internet speed, Rohit?
It does depend on the internet speed. Yeah. Also, like try clicking Control-Shift-R, so that will refresh the page. It's a hard refresh. That might work. Okay, for Dr. Mridula, it is working. Good to know.
Well, I still got a white screen.
Yeah, I think, Rohit, there's quite a fair amount of people that are trying to access, hence it's becoming a little bit difficult for.
I think that is the reason, yes.
Yeah,
right.
awful to accept everything.
Trying to get in into the system.
It's all right. It's all right. So we can do one-on-one demos if somebody's interested. But yeah. So the idea here is that you don't need to wait for the whole slide to be scanned, because with a typical whole slide imaging system that we showed you before this, it will take almost like more than 5 minutes, 5 to 10 minutes for the whole full smear of FNAC or a pap smear, conventional pap smear for that matter. But in this case, it just takes 30 seconds to start working, and it's pretty fast. Of course, this live mode is slightly heavy on the internet side, so compared to the earlier one, which is the whole slide image. So that's why I think a lot of people could not access it as seamlessly as before. But we could set up, like, if somebody's interested to try it out, we can have like separate sessions where we can try it out. But yeah, I think so. These are the two very important modalities of whole slide imaging that we offer, and here is the one which is primarily suited for cytology or even hematology for that matter, and the previous one is primarily suited for histopathology. So I think that is all from our end. Would love to understand if you have any questions on this, like either of the systems.
All right, thank you, Mr. Roy.
Yeah.
I think we need to try more, and I'm not sure, but I haven't been able to open the link yet. Okay. Actually, I'm connected from Iran. It might be related to the internet speed problem because we are facing difficulties now these days. But I'm not sure about other friends and colleagues. Yeah. Anyway, any question for Mr. Rohit? Any further questions?
Rohit, regarding calculating mitosis, have you tried anything which will help us to count mitosis? Because that is something that we face on day-to-day basis in pathology.
Right. So we could not demo it unfortunately in the current system, but we have multiple AI software integrations which are baked into our system. So we have one for full breast panel from one of the companies which does like full ERPR, HER2, Cas7 quantification and grading. Then we have one more for the prostate cancer, which does like the full Gleason scoring. And for mitosis, again, like there's one more partner who is building that. We have an early version out there, but yeah. So it's pretty much, we are more like an app store. Like, you have your Android or a, Apple phone, and you have multiple apps. So I think that's where the digital pathology is headed. We are more like a platform creating image, like, enabling you to take images, report online, but all the AI partners are going to come in and, integrate these onto the platform, and it will be, you'll get access to all these softwares through our platform and few more platforms for that matter. So I think that's where we are headed. I hope I answered partially your question, Dr. Sandhya.
Yeah, of course, because if that happens, mitosis will be an easy thing to do.
Right.
Okay, Mr. You can continue if you have anything to explain or to present. We have enough time.
Okay. No, I think
using the Morphle for teaching.
Yeah, Dr. Sandhya ma'am, you can probably talk about Spark program that you do.
So Morphle digital scanner, particularly in this COVID times, has given us a great support for teaching students. So what we do is we every day, as soon as we come across interesting teaching slides, they have 6 things. So the scanning happens pretty quickly. So once the slides are scanned, we are neatly storing them up with different names, depending on the number of the biopsy, etc. And as Rohit said, we are able to use the link and send it to our students. Now, we are not supposed to sit together and study because of all these restrictions. So each one, we are in our rooms and our students are in different places, and they're able to open the link. And as he said, the zoom feature is very good. We are able to zoom in, and the quality of picture is, of course, just like we see under the microscope. But this IHC overlap that he said, that is something that I have to try out. That sounds quite interesting. That is something that we didn't really try it out. But then when we order so many IHCs, it will be interesting to see, to keep all the slides together and look at which are the cells that are positive for, that particular marker. So I think, as you said, the digital age has come. Pathology is going digital. And I think more and more technology, y'all are making it more and more tech savvy. So we also have to become more and more tech savvy to be able to take the technology. But really, it has given us a great support during these past 1.5 years when we are not able to sit together with our students and discuss. So we've been using it extensively for our students. And I think that's how, and of course, my research work, it helped me to really kind of scan slides. But more than that, for our day-to-day, teaching, we are using it. And reporting, of course, we still, as you said, your grading softwares and mitosis counting softwares will probably go a long way in future if we need to put it all together. That will kind of ease out our extensive work that we have on day-to-day basis, I think. So thank you, Professor Ali, for giving us this opportunity to present my paper, as well as, of course, I think Rohit has.
Thank you so much. Thank you so much for joining us today and for the wonderful presentation. And yeah, actually, for me, I was wondering whether we can have access to these services outside India, because physically many of us are based outside India. So we have sales services.
Yes, absolutely.
Outside India, or
yes. So we have shipped to.
So could you please?
We have shipped machines to USA, NIH, Essex, UK, and few other places across the globe. Like we have even shipped to Middle East, Dubai, one place. So I think we have like sales and support operational throughout the world. So
okay,
we are
great.
Call with any of you, whoever might be interested, and discuss further.
Sure.
And the link be accessed, supposing I show my slides and the link can be accessed from somebody in the States or centers. There is no issues with that, right?
Yeah, absolutely. We have a user in Cambodia, and they have one pathologist in France, in Paris.
There is a seamless transition of the slides.
Yeah, yeah. So there is no lag. Humans zoom out seamlessly over the internet.
All right, awesome. Thank you very much.
Thank you so much.
Thanks again for your participation and presentation. Thanks a lot. So for now, I would like to introduce our next speaker, Dr. Ishani Gupta from India. So Dr. Ishani.
Good afternoon, everyone. Thank you for letting me present my paper here. So I'll just share my screen.
Yeah, share your screen and introduce yourself again.
Yeah.
Thank you.
Myself, Dr. Ishani Gupta. I am a senior resident working in Government Medical College, Jammu and Kashmir. Today, I'll be talking about histopathological spectrum of ovarian neoplasms. Before that, I'll just share a basic statistics of ovarian neoplasm. We are seeing around 230,000 women around the world who are diagnosed annually with ovarian cancer. And it is expected that by 2035, 55% increase will be seen in the number of new cases of ovarian cancer diagnosed each year. Plus, there will be 70% increase in the number of deaths that occur due to ovarian cancer. Ovarian cancer is the 5th most common cancer in the world. 1 in 73 female die due to this cancer. It is most deadly of all the cancers that affect women. Like, as for example, like cervix, 50% death mortality rate is seen, but in ovary, it is 64%. So the risk factors that are important for ovarian tumors are nulliparity, family history, childhood gonadal dysgenesis, clomiphene, hereditary HNPCC, BRCA1, BRCA2 mutation, CA125 is seen in 80% of the serous and endometrioid tumors. Cytogenetics, gain of chromosome 12 and 8, loss of chromosome X, 22, 18, 17, 14, 13, 12, and 8. Benign and borderline tumor exhibit trisomy 12. So ovarian tumors are either functional cysts or real ovarian tumors. So ovarian tumors are classified as epithelial, germ cell, sex cord stromal, or metastatic. Surface epithelial tumors, 65 to 70%. It is the most common epithelial tumor. Age group affected is 20 plus years. It is divided into serous, mucinous, endometrioid, clear cell, Brenner, unclassifiable. Germ cell tumor is seen 15 to 20% of the cases, 0 to 25 plus years. Teratoma, dysgerminoma, endodermal sinus tumor, choriocarcinoma are most common of germ cell. Sex cord stromal tumor is 5 to 10% of all the ovarian tumors. It can affect all age groups. Fibroma, granulosa theca cell tumor, Sertoli Leydig cell tumor, they are commonest of all. Metastasis to ovary is around 5% and it is variable. Moving over to the epithelial tumors. The epithelial tumors are serous, mucinous, endometrioid, clear cell, and Brenner. So serous tumor is 1/4 of the all ovarian tumors. They are mostly seen in adult females. 30 to 50% present with bilateral, 60% are benign, 15% borderline, 25% malignant. Papillary formation may be seen. On microscopy, we can see the cuboidal to columnar cells which line the cyst wall. Seminoma bodies are seen in 30% of the cases. They are either benign, borderline, or malignant. Benign cystadenoma, papillary cystadenoma, surface papilloma, adenofibroma, cystadenofibromas. Borderline papillary cystic tumor, surface papillary tumor, cystadenofibromas, and malignant adenocarcinoma, surface papillary carcinoma, and adenocarcinoma. Grossly, there we can see the They present as cystic masses having papery thin. They can be unilocular or multilocular. They are filled with straw-colored clear fluid. So borderline tumors, they present an age group of 20 to 50 years. Bilaterality is seen in 30% of the cases. Prognosis is 100%, 5-year survival. In grossly, we can see there is increased papillary projections within the cyst, which is like, for example, in this, we can see there is no papillary projection. Here we can see the papillary projections, which can be seen on gross. On microscopy, we can see there is increase in the complexity of stromal papillae with stratification, nuclear atypia, but there is no infiltration into the stroma. Epithelial stratification can vary from 2 to 3 layers. There is increased complexity, but no stromal invasion. Serous cyst adenocarcinoma, age group affected is 40 to 70 years. Bilaterality is seen in 66% of the cases. CK7 is positive in most of the cases. Prognosis is 70%, 5-year survival. Grossly, we can see irregular tumor masses. There is increased solid to papillary areas with necrosis and hemorrhage. So papillary cyst adenocarcinoma, there is more, it includes stratification of the low columnar epithelial lining, the inner surface of the cyst, and there is presence of semoma bodies. Here we can see the semoma body. The stroma shows invasion by clusters of anaplastic tumor cells. So differentiating between benign, borderline, and malignant. Benign is lined by a single layer of cell. In borderline, we can see the stratification. There is slight cellular atypia, but there is no infiltration inside the stroma. As in malignant, there are anaplasia of the lining epithelium, and there is stromal invasion. So benign, grossly, in some serous neoplasm, fibroblastic stromal component is unduly prominent. So we can see as grossly as wide nodular foci in an otherwise cystic neoplasm. Benign is most common, and we label it as adenofibroma or cystadenofibroma. And in malignant, we see adenofibrocarcinoma, cystadenofibrocarcinoma. So this is a photomicrograph of ovarian cystadenofibroma. We can see well-differentiated glands. They are embedded in dense fibrous stroma. So some serous neoplasms, they grow exophytically on the surface of ovary with little involvement of the underlying organ. If it is a benign, we call it as surface papilloma. If it is intermediate, it is borderline surface papillary tumors. If it is malignant, it is serous surface papillary tumors. Now, serous surface papillary carcinoma, papillomatosis is seen on the outer surface of the ovary. There is minimal enlargement of the ovary. There is hardly any infiltration. We cannot see any infiltration inside the stroma, mostly bilateral, highly aggressive tumor with peritoneal spread at the time of the surgery. Now, there is another entity that is known as serous Samoa carcinoma. It is a rare form of serous adenocarcinoma. It involves the ovarian surface. Massive semoma body formation is seen, but the cytologic features, they are low grade and abundant semoma bodies in at least 75% of the papillae. Immunohistochemistry, it is cytokeratin 7 positive. It is CK8, 18, 19, EMA, and S100 positive. WT1 stains diffusely in most of the serous carcinomas. Then ovarian implants. Ovarian implants, there is deposit of ovarian tumor on the peritoneal surface. Entire peritoneum may contain tumor nodules, which are usually less than 1 centimeter. They are seen in 1/3 of the patients with serous borderline and malignant tumors, and this affects prognosis. Unencapsulated serous tumors of the ovarian surface, they are more likely to extend to the peritoneal surface. Moving over to the next entity, which is of surface epithelial tumor, that is the mucinous tumors. Mucinous tumors, they are less common as compared to the serous tumors. They constitute around 25% of the cases. Bilaterality is more common in serous tumors, but it is also seen here in 10 to 20% of the cases. 80% of the tumors, they are benign or borderline type. Now, they are divided into benign, borderline, and malignant. Benign, we have cystadenoma, adenofibroma, or cystadenofibroma. In borderline, it can either be intestinal type or endocervical type. In malignant, it can be adenocarcinoma, adenocarcinofibroma. Mucinous cystic tumor with mural nodules can be presented, or mucinous cystic tumor with pseudomyxoma peritonei. So here we can see this is a gross photograph of the mucinous cyst adenoma. The tumor, mostly the cyst is larger than serous. It is multiloculated. The fluid is viscous and mucoid nature. It is mucinous fluid is seen, which is filling up the entire cystic cavity. The mucinous cysts, they are lined by a single layer of tall columnar mucinous epithelium without cilia. Mucinous cyst adenoma, here we can see the cyst wall and the septae, they are lined by single layer of tall columnar cells here with basally placed nuclei and large apical mucinous vacuoles. Borderline tumors, they are of two types, intestinal or endocervical, but most common is intestinal type. It is mostly present in 40 to 70 years of age group. Bilaterality is in 5 to 10% of the cases. They are grossly, it is multiloculated cyst, and there are papillae. Borderline mucinous tumor, the epithelial lining, they have a picket fence appearance. We can see the picket fence appearance. Intestinal type lining, which may be several layers thick. There may be mild to moderate nuclear atypia, but destructive stromal invasion with an associated desmoplastic stromal response is absent in borderline mucinous tumor. There is presence of goblet cells. Intestinal enzymes may be present, lipase or trypsin, but there is no evidence of any hormone access. In endocervical type, it is mostly associated with endometriosis. There is lining of tall columnar, tall non-ciliated cells, basally located nuclei, abundant intracellular mucin. Endocervical line tumors, they are more likely to be bilateral and have associated peritoneal implants. Now coming over to the malignant mucinous tumor. Malignant mucinous tumor is seen in 40 to 70 years of age group. Bilaterality is 5 to 15%. Neoplasm is mostly solid, containing cystic spaces, which is filled with mucoid material. Cyst wall is thickened. There is presence of hemorrhage, necrosis. We can see the cellular atypia. There is increased stratification. The glands, there is complexity of the glands. There is presence of papillae. We can see the stromal invasion. Now, if there is unquestionable stromal invasion, we directly label it as carcinoma. If there is uncertain invasion, if there is atypical epithelium, which is less than 4 cell thick, then we consider it as a borderline mucinous tumor. But if there is atypical epithelium more than 4 cells thick, then it is definitely a carcinoma. Now, mucinous cyst adenoma versus primary ovarian carcinoma versus metastasis. Like primary is unilateral in most of the cases, metastasis is bilateral. The size is more than 10 centimeter. It has a primary, has a smooth external surface, expansile pattern of invasion, complex papillary pattern without discrete nodularity. In metastasis, there is history of extraovarian primary mucinous adenocarcinoma. There are surface implants. There is infiltrative pattern of stromal invasion. There is nodular invasive pattern. Ovarian hilum is also involved. Vascular invasion is seen, and primary sites are 45% are GI, 20% we can see in case of pancreatic carcinomas, which involve the ovaries. Now, pseudomyxoma peritonei, it is a mucinous tumor like serous tumor, and it involves the peritoneal surface with collection of extensive mucinous material resembling cystic contents within the peritoneal cavity. It is usually a rare condition. It is seen with primary, borderline, or malignant neoplasm. The major complication is that there is extensive inter-adherence and adhesion of the viscera, producing a matting together of the abdominal contents and causing intestinal obstruction. Like this is a gross photography. I think this is from a surgery going on for the peritoneal implants. We can see there is extensive adhesion, and it has become all the intestine has clumped together, and it is presenting with obstruction. Here we can see the nuclear atypia in the photomicrograph, and we can see the these are the stromal invasion present here. Now, immunohistochemistry, it is CEA positive, EMA positive if it is malignant, MUC5 AC positive, CK7 is positive, CK20 is positive in 50% of the cases. Intestinal type mucinous tumors, they have immunohistochemically endocrine cells. They contain serotonin, ACTH, gastrin, somatostatin. Now moving over to the third entity, that is the endometrioid tumors. Endometrioid tumors are 10 to 25% of all primary ovarian carcinomas. They are coexistent mostly with endometriosis in 10 to 20% of the cases. Grossly endometrioid carcinomas present as solid to cystic masses. They contains a hemorrhagic and visible papillary formation is absent, unlike serous and mucinous. So mostly it has good prognosis. Endometrioid tumors, they present as villous or papillary structures or tubular glands composed of stratified layer of epithelial cells with smooth luminal borders. Destructive stromal invasion is present and resembles the appearance of endometrial carcinoma with centrally placed nuclei. Immunohistochemically, it is keratin, EMA, vimentin is positive, CEA is usually negative or weak. Now, clear cell tumors, the frequency is less than 5%. Epithelial tumors of the ovary in which most or all of the cells have clear cytoplasm. Most are malignant with rare, benign, and borderline variant. They are associated with endometriosis and endometrial carcinoma. It is predominantly cystic, mixed with solid and cystic masses, often contain mixed nodules. Clear cell carcinomas are always high grade and it has poor prognosis. Clear cell tumor, the growth pattern is tubular or cystic, which present as cystic papillary sheet. They have abundant, here we can see the abundant clear cytoplasm and there is significant nuclear atypia. Clear cell carcinoma of ovary, here we can see showing short papillae with hyalinized pores lined by highly atypical cells. Special stingins, the hyaline globules, they are negative for alpha fetoprotein. Okay, so tumor cells, they are always reactive for keratin, that is cytokeratin 7, 5.6, CAM 5.2. EMA, CEA, CD15, vimentin, BCL2, P53, CA125. Variably reactive for estrogen and progesterone receptor, much greater expression of ER than PR. ER is exclusively of beta rather than alpha type. HER2 positive, alpha fetoprotein, negative for cytokeratin 20, and also reactive for hepatocyte nuclear factor 1 beta. Now moving over to the transitional tumors, benign is Brenner or metaplastic variant, borderline is proliferating variant, malignant is transitional cell carcinoma, transitional cell carcinoma non-Brenner's type, malignant Brenner tumor. Brenner tumor and transitional cell carcinoma resemble those of the transitional cell neoplasms of the urinary tract. It presents as 1 to 2% of all ovarian neoplasms. The average age at presentation is around 50 years. Sometimes signs of hyperestrogenism, such as postmenopausal uterine bleed and endometrial hyperplasia is seen. It has a slow rate of growth and rarely present with the ascites in the patients. Benign is grossly, these tumors, they have a white to tan yellow whorled cut surface and it shows cystic spaces with calcification. Brenner's tumor, the epithelial cells have solid and cystic nests, resemble transitional epithelium surrounded by abundant stroma, cysts with eosinophilic fluid and fibrotic stroma. Tumor cells are oval nuclei, distinct nucleolus and having longitudinal grooves. Now, metaplastic Brenner tumor has unduly prominent cystic formations, florid mucinous changes, papillary fronds and nuclear atypia is absent. The borderline Brenner tumor has a pattern of proliferating Brenner's tumor with greater atypia, which is equivalent to grade 1 or 2 transitional cell carcinoma. Stromal invasion cannot be demonstrated. Now, borderline has papillary fronds. There is nuclear atypia, resemble pattern of low grade 1 or 2 transitional carcinoma of urinary bladder. Here we can see the nuclei are oval, but they are small, having distinct nucleolus, having longitudinal grooves, and the cytoplasm is mostly clear. In malignant Brenner tumor, the stromal invasion is present. It is recognized mainly because of association with a typical benign metaplastic proliferating or borderline component, and there is presence of areas of nuclear atypia. Transitional cell carcinoma of ovary, which is of non-Brenner type. Transitional cell carcinoma of the ovary resemble other epithelial carcinomas with solid and cystic areas. which closely resembles the TCC of the bladder. By definition, no Brenner tumor component is present. Ovarian transitional cell carcinoma is graded using the criteria for transitional cell carcinoma of the urothelial tract. In transitional cell carcinoma, we can see papillary cores which are lined by stratified cytologically atypical epithelium. Special stains, they are immunoreactive for keratin, EMA, CEA. They are also positive also in lumen cyst, may contain glycogen, mucin, or lipid, and steroidogenic enzymes are usually absent. Now, malignant mixed Mullerian tumor, it has the carcinomatous appearance. Component may appear as serous, endometrioid, squamous, or clear cell. Sarcoma-like element may have appearance of chondrosarcoma, osteosarcoma, rhabdomyosarcoma, angiosarcoma. It resembles grossly in every aspect to the other uterine component. Neoplasm is large, having variegated, solid, and cystic with hemorrhagic and necrotic areas. The homologous type have non-specific, we can see the malignant stroma. This is the endometrioid component which is present, and this is the clear cell component which is present in the tumor. Here it is the heterogeneous type. We can see the skeletal muscle and the fibrous elements present in the tumor. In hyaline droplets, they contain alpha-1 antitrypsin in cytoplasm of the tumor cells. It has extremely poor prognosis. Most reliable prognostic criteria is the tumor stage. Most tumors have already extended outside the ovary at the surgery. Now, moving over to the next category of the ovarian tumor, that is the germ cell tumors. Most common are the teratoma, dysgerminoma, endodermal sinus tumor. Germ cell tumors, they originate from the germ cells, the totipotent cells which migrate to the ovary from yolk sac. Frequency is around 15 to 20%. They are present mostly in children and young adults. 95% of the benign. Younger the patient, more chances of malignancy with germ cell tumor. Germ cell tumor or neoplastic transformation can either be mature or embryonal. If it is mature, it can be benign or malignant. In benign, it is mostly mejoristic teratoma, struma ovaroi, and malignant component can be squamous cell carcinoma, carcinoid, thyroid carcinoma. If it is embryonal, if it remains undifferentiated, it can lead to dysgerminoma. If it is primitive, it can lead to embryonal carcinoma, extraembryonic yolk sac carcinoma, trophoblast are seen, choriocarcinoma. If it is somatic, it is immature teratoma. Dysgerminoma is the most common malignant germ cell neoplasm of the ovary and is the counterpart of seminoma, which is seen in males. It is less than 1% of all ovarian tumors. It is around 5% of all malignant ovarian tumors. Usually, it is present in young adults less than 30 years of age, and they arise in abnormal gonads. They can either be pure or mixed gonadal dysgenesis from a gonadoblastoma, or it can be testicular feminization, androgen sensitive insensitivity syndrome. It is more common on right. Bilaterality is seen in 50% of the cases. Metastasis is commonly seen in contralateral ovary, retroperitoneal nodes, peritoneal cavity, exceptionally associated with hypercalcemia and extremely radiosensitive. This germinoma is often large, maybe more than 1,000 grams, encapsulated, smooth, often convoluted surface. Cut surface is solid to gray. Cut surface of ovarian, there is multinodularity where we can see multinodularity solid nodules. There is foci of hemorrhage, and necrosis is not as common and as prominent as seen in other malignant germ cell tumors. This germinoma presents mostly diffuse insular or trabecular pattern. The tumor cells are uniform. The nuclei is centrally large. Nucleoli is one or more prominent nucleoli. Cytoplasm is abundant, clear and contains glycogen, sometimes droplets of fat. Cell membrane is prominent. The fibrous strands are infiltrated by T cell lymphocytes, and there may be focal necrosis, hyaline change in vessels, or germinal centers. Tumor cells are reactive for PLAP or CD117, often sometimes GFAP and desmin. Moving over to the next, yolk sac tumor. It is a malignant germ cell tumor of the ovary developed as a result of differentiation of primitive malignant germ cell element in the direction of yolk sac or vitelline structures. It is present in children and young adults. Median age is 19 years. 25% are prepubertal at diagnosis. Vaginal bleeding is seen in 1% of the cases. Serum AFP level invariably elevated. Chronic gonadotropin levels are normal. It is highly aggressive and associated with other germ cell tumors. The average diameter of yolk sac tumor is around 15 centimeter. External surface is smooth and glistening. On cut section, we can see variegated, partially cystic, and there is large foci of hemorrhage and necrosis. The component of benign cystic teratoma may be seen in around 15% of the cases. Many histologic variants occur in yolk sac tumor, including the reticular, endodermal sinus, polyvesicular vitelline, hepatoid, and glandular pattern. The endodermal sinus tumor is the pattern is the most common pattern after reticular. This pattern features characteristic Schiller dual body, which is a rounded papillae containing a single central vessel lined by columnar tumor cells. Yolk sac tumor has pars positive hyaline droplets, intracytoplasmic and extracellular, nearly always present. High power view of ovarian yolk sac tumor. There are numerous hyaline globules. Here we can see they are present even in the cytoplasm of the tumor cells lining the papillae. Yolk sac tumor shows some differentiation towards hepatoid, intestinal and parietal yolk sac. Here we can see the yolk sac tumor with endometrioid-like features. Yolk sac tumor is positive for pancytokeratin. It is negative for keratin 7 in contrast with endometrioid and clear cell ovarian carcinoma. It stains positive for WT1, T1. Hyaline droplets usually stain for alpha fetoprotein and may also contain alpha-1 antitrypsin. Embryonal carcinoma is rare and the least differentiated of all the ovarian germ cell tumors. It is considered to be homologous to the embryonal carcinoma of adult testes. It is seen in younger age group, 40% prepubertal at diagnosis, 43% of whom present with precocious puberty. Vaginal bleeding is seen in 33% of the cases, amenorrhea in 7%, hirsutism in 7%. Serum alpha fetoprotein is mostly elevated. Chronic gonadotropin levels invariably high. It results in consistently positive pregnancy test. The median diameter of the embryonal carcinoma is 17 centimeters. The external surface is smooth and glistening. The cut surface is predominantly solid and variegated, and extensive areas of necrosis and hemorrhage is present. It is similar in appearance to the embryonal carcinoma of the adult testes. There is solid sheets and nest of large primitive cells, occasionally forming papillae and abortive glandular structures. Frequently, we can see the syncytial trophoblast-like tumor cells scattered among the smaller cells. Special stains, it is immunoreactive for HCG, the syncytial trophoblast-like cells, and it is positive for CD30 and cytokeratin. Choriocarcinoma is the malignant tumor of the ovary with trophoblastic differentiation composed of syncytial trophoblast, cytotrophoblast, and intermediate trophoblast. It is exceedingly rare and may be associated with mature cystic teratoma of the contralateral ovary. There is a mixture of syncytial and cytotrophoblastic elements in a hemorrhagic background. It is immunohistochemically, it is positive for HCG, keratin 7 said to represent a marker of subset of trophoblastic cells, and LK26 is consistently expressed. Now moving over to the teratoma, teratoma can be mature or immature. Mature cystic teratoma, it consists of cystic germ cell tumor composed of multiple mature elements which are derived either from ectoderm, mesoderm, or endoderm. It is present in almost 20% of all ovarian neoplasm are mature cystic teratoma. Most common ovarian tumor of the childhood, 88% are unilateral and usually benign. Symptoms are usually related to mass. Occasionally, patient may present with hemolytic anemia. Virilization may coexist with mucinous cystadenoma, Brenner tumor, and they are usually benign. Multiloculated cystic contents are greasy, composed of sebum, hair, keratin, commonly teeth. It tend to be well-defined nipple-like structure covered with hair. There is Rokitansky, also known as Rokitansky's protuberance. Mature cystic teratoma has cystic cavity lined by mature epidermis. Skin appendages are seen, neural tissue is seen, also seen as cartilage, respiratory tissue, gastrointestinal tissue. Here we can see the gastric mucosa of pyloric type. Immature malignant teratoma, it is a malignant ovarian germinal tumor composed of mixture of immature embryonal and mature adult tissue derived from all three layers. It is usually present in children and adolescents, may be solid throughout, solid with multiple minute cysts, and predominantly cystic. It consists of a mixture of embryonal and adult tissue. Any type of tissue may be present. Main component usually is neuroepithelial. Mesodermal element is also common. Sometimes predominantly composed of endodermal derivatives, including esophagus, liver, and intestinal structure. So this is an immature teratoma containing immature neuroepithelium and or rosette. This is a rosette. Here we can see the rosette forming structures. The grading is for immature teratoma is according to Norris et al. Grade 1, abundance of mature tissue, loose mesenchymal tissue with occasional mitosis, immature cartilage, tooth and grade 2 is pure mature tissue, rare foci of neuroepithelium with common mitosis, not exceedingly 3 low magnification fields in any one slide. Grade 3 is few or no mature tissue, numerous neuroepithelial element merging with a cellular stroma occupying 4 or more lower magnification fields. Special stains, it is GFAP positive. It helps in identification of mature and immature glial tissue, also detectable in chondrocytes. Long chain polycyclic acid moiety of neural cell adhesion molecule, which is another marker for immature and mature neural tissue. Then there is another term which is known as monodermal teratoma. It consists of, it is either thyroid tumor group, struma overi is the benign part, or it can present as malignant. Carcinoid group, it can be insular trabecular mucinous strumal carcinoid. Neuroectodermal tumor group, which is ependymoma, PNET, glioblastoma, medulloblastoma, or it can be carcinoma, melanocytic, sarcoma, sebaceous tumor group. So stroma overi is the ovarian teratoma composed exclusively or predominantly of thyroid tissue. It may show any of the pathologic changes which is seen in normally placed gland, including diffuse or nodular hyperplasia. It may lead to hyperthyroidism, thyroiditis, carcinoma. Thyroid nature fully documented with biologic and immunohistochemical studies for thyroid hormones. Here we can see the dominant thyroid tissue. This is the thyroid follicle cells. Carcinoid tumor, it is a primary well-differentiated neuroendocrine tumor of the ovary. Carcinoid syndrome is most likely the larger tumor, more than 7 centimeter. Sometimes presents with severe constipation patients present with, which is due to the secretion of peptide villi. Carcinoid, there is insular pattern of growth similar to the appendix and small bowel. Trabecular appearance similar to the rectum. Mucinous appearance similar to those seen primarily in the appendix. Now moving over to the next group of classification, that is the sex-cord stromal tumors. They mostly consist of granulosa cell, fibrothecoma, sertoli-Leydig cell. So granulosa stromal cell tumors, the granulosa cell tumor group consists of adult granulosa cell tumor or juvenile granulosa cell tumor, and thecoma fibroma group consists of thecoma, fibroma, cellular fibroma, fibrosarcoma. Sclerosing stromal tumor, signet ring stromal tumor with minor sex-cord elements are unclassified. So granulosa cell tumor group, it differentiation towards follicular granulosa cells that can occur in adults and in younger patients. There are two distinct types, adult and juvenile. Adult usually seen in childbearing age. 75% have hyperestrenism, which may result in isosexual precocious puberty, metorrhagia in adults, including postmenopausal women. We have seen there are elevated serum inhibin and follicle regulating proteins in present in these patients. The tumors are usually large, more than 10 centimeter, and unilateral. The cut surface is soft and yellow tan with cyst and hemorrhage. It is encapsulated. Cut surface is predominantly solid, but cystic component filled with clear straw-colored fluid or mucoid fluid is seen. Sometimes so prominent as to stimulate appearance. It can stimulate the appearance of cystadenoma. So different histologic patterns are seen, including microfollicular, macrofollicular, watered silk, gyriform, diffuse. All are composed of round to oval granulosa cells that have little cytoplasm. round to angular nuclei with longitudinal nuclear grooves, giving it a coffee bean appearance. There is minimal cytologic atypia and mitotic rate is low. So the microfollicular and diffuse variant, they contain the Karl-Exner bodies, which are small collection of eosinophilic material and lined by well-differentiated granulosa cells. Here we can also appreciate the coffee bean appearance of the nuclei. Juvenile granulosa cell tumor is more aggressive than adult. It is more likely to produce distant metastasis. Around 80% of them during the first 2 decades of the life usually present with isosexual precocity and is occasionally associated with chondromatosis and Maffucci syndrome. Morphologically, the typical morphologic features are diffuse or macrofollicular pattern of growth. Eosinophilic, mucin positive intrafollicular secretion is seen. Large tumor cells with extensive luteinization. There is paucity of nuclear grooves. Nuclear atypia is present and there is high mitotic activity. Here we can see the tumor cells lacking the typical coffee bean appearance, which is seen in the adult granulosa cell tumors. Adult granulosa cell is positive for steroid production, immunohistochemically and by both theca and granulosa cell with predominance of estradiol in granulosa cell and progesterone in luteinized theca cells. Then vimentin is positive, desmoprolactin is positive. Follicular regulatory protein CD99 and keratin is here we can see the strong immunoreactivity for inhibin in granulosa cell tumor. Thecoma is mostly seen in postmenopausal women. Symptoms of hyperestrogenism is seen. Mostly are unilateral and can measure up to 10 centimeters in diameter. Immunohistochemically, the tumor is positive for inhibin expression. Oil red O fat stains, they highlight the intracellular lipid. Thecoma is usually unilateral, variable sized, well-defined capsule, firm consistency, cut surface largely or entirely solid and may contain cysts, mostly yellowish in color. In microscopically, we can see fascicles of spindle cells with centrally placed nuclei, moderate amount of pale cytoplasm. Only mild atypia and rare mitosis is seen. Intervening tissue may contain collagen deposition or focal hyaline plaque formation. Degree of cellularity varies considerably. Some in young women are heavily calcified. Here we can see the bland microscopic appearance of the thecoma with the variable cellularity. It is oil red O positive, positive for inhibin, silver stains, estradiol usually limited to small number of tumor cells. Fibroma is the most common type of sex cord stromal tumor developing from specialized ovarian stroma. It is more common. It is unilateral, almost invariably present after puberty. Fibromas are not hormonally functional and their average size is around 5 centimeters in diameter, associated with basal cell nevus. Benign ascites may be present, especially if large, and sometimes with right-sided pleural effusion known as Meek syndrome. So this pleural effusion typically disappears on removal of the tumor. Grossly solid, lobulated, firm, a mass having uniform white appearance, no adhesion, average diameter around 6 centimeters, maybe myxoid change, sometimes resulting in cystic degeneration. Here we can see the white solid growth, which is seen on cut section of the fibroma. There are spindle cells closely packed, arranged in feather-stitched appearance or story-form pattern. There is no atypia, few mitosis, maybe hyaline bands, edema. If present in basal cell nevus syndrome, it is usually calcified, bilateral, often multilobular. Here we can see the tumor is hypercellular with pleomorphism, but pleomorphism and mitotic activity is minimal. These spindle-shaped stromal cells, they are arranged in story-form pattern. Coming over to my study, it was a retrospective study done in the Department of Pathology from January 2020 to December 2020. All the resected specimens received either as solitary specimen or as a part of pan-hysterectomy in the laboratory were included in the study. A total of 56 cases were included in the study and their clinical and radiological details were also taken. Histological slides were retrieved for examination. The slides which were faded or missing, the paraffin blocks were sought and new were made and stained with H&E stain. Ovarian tumors, the results, they were 27 cases were benign. 2 cases were borderline, and malignant were 29 cases. According to the age, we saw that malignant cases were more common around 30 to around the older age group, and the benign cases were seen in the younger age group. Histologically, the more common observation was that the surface epithelial tumors constituted the most common of all, followed by germ cell and sex cord, and around 2% were the metastatic tumors. The ovarian tumor being one of the more major gynecological challenge to the medical fraternity, its accurate diagnosis can be arrived by correlating age, clinical presentation, radiological findings, and morphology, which remains the gold standard. However, benign tumors are more common in the younger age group and malignant tumors in older age group. Hence, early detection of ovarian tumors is very crucial in reducing the morbidity and mortality of the patients. Thank you.
All right. Thank you so much for your participation and wonderful presentation talk on histological spectrum of ovarian neoplasms. Actually, there are a few questions in our chat box.
Yeah, I did see, Dr. Ali, many questions here. If they don't mind, I will read up all the questions and email the answers to them. Actually, I'm running short of time. I have a frozen section in my laboratory and I need to report that.
Okay. Yeah, sure. No problem. Thanks, doctor. Thanks for the presentation.
Welcome. Most welcome.
Thank you. Okay, so for now, I would like to invite our last speaker of the morning, today's morning session, Dr. Robert Heinz Gunther from Germany.
Yeah, thank you.
Dr. Robert. Hello.
Okay. Hello. I can start. Just share my screen then.
Sure. Please share your screen and again introduce yourself. Thank you.
Yes, I'm Dr. Robert Günther from Germany, from the company of Biocartis, and we are providing molecular biology tests for the diagnostic and the cancer part. And I would like to show you some information about the system that you can see directly on the slide here, the first slide. So first summary is that Biocartis is a rather medium-sized company located in Belgium, and with more than 17 countries and over 1,700 systems already installed worldwide. So as you can see on the next slide, we have a lot of customers around the world, from Western European countries, USA, Canada, as well as China. We have distributor contracts in different other regions like South America, the Arabian region, and Russia, for example, or Australia. And we have a lot of pharma collaborations like Merck, for example, MG, AstraZeneca, and so on. So there are a lot of, as you can see here too, a lot of cooperation partnerships with pharmaceutical parts, as well as that we establish new systems or new tests within our systems from other developers that they integrate in our portfolio. To give you a short summary, we have already 105 papers published since until August today. And this year we see already 25 papers in the literature. So there's a lot of interest observable. And I would explain you what is a target now for the system. So the reason is that, for example, in the USA, nearly 80% of the cancer patients do have only a rather late result of their diagnosis, and this has influences on the treatment too. Recently, I saw several papers that describe that there is some impact on the mortality, for example, for a delay of the treatment for 4 weeks, as well as the psychologically impact for the patients themselves. So there's a good reason why we have to increase the speed from the diagnosis until the treatment. The first example I would like to show is for the rapid RGFR testing with significant reduced turnaround times. The study was performed in New York, and before the current testing system, they have 9 days until the result was reported. And changing to the Adilla system, they reduced it to 1 to 3 days, including the gene fusion. There I have to say that we can speed up this already, because since few months we have published our new gene fusion test, that you can do this test with the Adilla system too, and just takes 3 hours until you receive the result. So there's a good reason to use it in the GFR part, that you can reduce from 9 days to 1 to 3 days the diagnosis step. You have a simple workflow, I will tell you a little bit more later. And the platform is very flexible to handle and able to handle for different sample types, like FFPE or liquid biopsy. And one additional advantage is that you have just a minimal use of material that allows further testing with NGS assays wherever available, required. Another nice story is from the KRAS study, which was performed in 20 institutes worldwide, mainly in the USA. And what you can see as a main lesson here is that you have the standard of care measurements in the top table or graph. And the blue parts are those parts for the time within the pathology. If you use Adilla, you can reduce nearly to 0 these blue parts. So in total, you have a reduction from 11 days of standard of care methods to 0.2 to 0.5 days with the Adilla system. So this is a very big advantage. Another story is that the Adilla testing is rapid first line testing, which was performed in the USA with 2 different studies. What you can see here is that you have rather a lot of cytologic samples which were used, and that the concordance was rather high with 96.2% concordance, and improved to 98.7% after incorporation of manual review criteria. In the second study with a lot more samples, with nearly 1,300 samples, we see that there are 98.57% of concordance with the reference method. So again, you can see here that there's a high concordance and very good results in a fast way. Additionally, we have a test in the real life situation for the EGFR again. It was performed last year in September, was published. And to see much more details, you can go here. We have 1,370 samples which were used. And there was a great concordance of 98.4% and a specificity of 99.2%, which means especially for this real world situation with a lot of samples, it's a rather high and unexpected concordance. It shows the robustness of these tests in a very good way. So taking a rough overview, we have a system that enables you rather short hands-on time. I will show you a little bit more later. You have a fast turnaround time between 1.5 hours to 3 hours. 80%, you can recover 80% of samples that failed on NGS systems. The reason is that we have rather small amplicons that will be used in the system. And you have superior performance with more than 95% concordance and lower than 2% of invalids overall. So in some cases, you have much less. For example, MSI is a rather good test where you have only 0.4% of invalids. The technology behind the system is that the system preparates the sample on its own. So you just need the FFPE slide. And in the next steps, you have the qPCR system and the melting curve analysis are available. The melting curve analysis is for the MSI technique. So the solid biopsies as well as cytological samples can be used. Liquid biopsies, for example, plasma in the urine. Pathogens like swabs, viral transport medium for the COVID situation, for example, can be used. And another test is already available is sepsis, which does not is very important here, but it's available too, and shows that we have a broad testing pattern. So the intended use is that you have a system that can test your patient's samples on demand. That means you have a single-use cartridge, you can see here, where you place in the FFPE slide. The next step is that the sample ID from the cartridge is scanned, as well as the patient ID, so available as a barcode or QR code. And then within the system, the sample liquefaction will be performed, the cell lysis, the DNA release, as well as the amplification and detection, and finally the data analysis with the report. So here you can see it again, an easier way. I will skip this. That means that in total, you have less handling steps and less hands-on time compared to other systems. For example, NGS took more than 200 handling steps. PCR system alone, more than 20 handling steps. EDILA, only 1 handling step. This means that you have less steps where you can have contamination or whatever. The average hands-on time is very much lower. Whereas in NGS, you have around about 2 hours of hands-on time. You have in PCR 20 minutes, in EDILA only 2 minutes. And according to this, for sure you have less complicated steps. So whereas in TerraScreen, you have a big protocol with a lot of steps, COBAS, for example. The EDILA system is rather slow, rather low, and much lower than this looks like. According to this, you have for sure less requirements. You need less instruments. Only these 2 are required. 1 console to activate the test, for example, to add the information. 1 system for the tests themselves. Whereas you have in the traditional workflow a lot of other experimental equipment and rooms, for example. Whereas in EDILA, you need only 1 room. You need up to 3 rooms in a traditional workflow. And the good thing is that the result is reported in a rather easy way. Show you right now here. You will have a result where you can see the sample ID, that you can identify the patients themselves, what kind of sample type is used, the cartridge itself, the cartridge ID. So if there is for the request, or if there's a discordant case or a problem, there's opportunity to check exactly this sample again by using the cartridge ID. The test type is located here too, as well as the lot ID number of the production. So if there are any problems, you can check with us if there is a production problem or not. And the timing is mentioned there too. The easy thing is that the result is mentioned in a rather easy way. So for example, the BRAF cartridge. The BRAF cartridge is shown here as a mutation detected in the BRAF codon. The mutation is either K, R, or M mutation. And then you directly see the result easily without any further interpretation of the results required. This shows now then the other tests we have in our portfolio at the moment. For the melanoma, we have BRAF, CT BRAF, NRAS BRAF, colorectal, KRAS, NRAS BRAF, the liquid version of them, and the MSI. Lung, we have EGFR, the liquid version, BRAF, KRAS, gene fusion with a new test, and EGF BRAF plus is still in development, but expected to arrive on the market very soon. We are working on breast cancer parts, immune oncology, and pancreas, punk cancer too. And next steps are thyroid and endometrium. The MSI is used in endometrium at several customer sites already too, but right now we are working on the validation maybe. Then they have the hematology and the brain. So you can see that this system is not only the one state or the current state situation, we will have many additional tests in the futures too. This comes to an overview for the existing tests at the moment. There you can see, for example, the turnaround time, that they are rather low. BRAF is very short with 90 minutes, mainly with 2 hours and 2.5 hours for the KRAS, NRAS, BRAF, MSI, and EGFR versions. And at the end, the gene fusion test with the this ALK-ROS-Z and so on, I will show you later, with 3 hours. The sample requirements are rather small. So you have a tumor content from 10% up to 50%, but these 50% are only for the BRAF situation in melanoma. It is not a big problem there. But compared to the NRAS BRAF, for example, it's still more than 10%. So it's very nice to use. The FFPE input required is usually 5 to 10 micrometer slides. Common slides are required only, so they're not so big. Usually one slide is enough. If you have less amount, you can add up to 3 slides, that's no problem. And to show you some details now for the kind of the cartridge is working, I would like to show the disk layout which is in use. So we have 5 different chambers from A to E, where we have different kinds of mutations which are tested. And in each you have a test part, so a control part. The KRAS total is here in this test for the KRAS test. And this is important to know because if this is not working, the test will be called invalid. So this is a rough overview. All of our tests will look similar. And now we'll give you some details about the different tests, starting with the KRAS test. So the KRAS test is according to CAP, AMP, ASCO guidelines, as well as ESMO, ASCO guideline, and NCCN. And the test is detecting KRAS exons for 2, 3, and 4. And recommends testing at a detection limit of 5% or less are possible with this test. And that means for the more details that we have the G12D, C, and so on mutations, which can be detected for the KRAS. So codon 12, 13, 61, 59, 117, 146 are detected. And this means that the prevalence of around 46% are detected already in a very fast situation. The report for this KRAS test has 3 different possible results, so very easy. One is mutation is detected in the codons I've mentioned already. The second one is that there is a mutation, and the third one is the invalid. Whereas the invalid we've seen very rare, less than 2%, and I think it was much less than. So what is interesting is the performance of these tests, and I would show you some studies which were performed. So we have at the beginning 2 in-house studies with around about 200 samples in use, whereas the first have a concordance of 100%. The second one has a concordance of 99.1%. And external studies was performed there too. So in total, it was around about 600 samples analyzed with corrected overall concordances above 98.9%. Corrected means that there was a discordance at the beginning for some cases, but a check versus a third method like ultra deep sequencing or digital droplet PCR checked that the IDILA result was comparable to the third method. So the overall corrected concordance was rather high. For example, I visit a customer who was using our test indirectly. They have a KRAS result which was checked by NGS. It was negative. Additionally, they sent it to another hospital. They used IDILA system. They said, oh no, this is a positive result. Additional check with the Sanger method was negative at all. And then we in-house used digital droplet PCR to check this original result again. And we find out that the prevalence, not the prevalence, the portion of the mutation was rather low, below than 1%. So the sensitivity of this test was really, really high. So usually we announce that each test or each mutation except G12R will be detected with an LOD of 5%. The G12R is detected already with 1%. So this is that fits the requirements from the guidelines. Additionally, we have results from the AstraZeneca study where they compared 12 different KRAS mutation detecting technologies, but they used it in lung. I have to say that in lung, this test is not validated, but for sure it can be used after an internal validation too. And the results was rather nice. I will show you here. So you see the KRAS mutation analyzed in the IDILA system. We have 5 mutations that were detected, and only IDILA as well as OncoMind-Focus Assay was able to detect all of these KRAS mutations in the different concentrations available. And this shows that the test is not only fast, it can be compared with even the best performing NGS technology as well. If we can check then the ease of use and turnaround times for the EDILA test comparing to other methods, we can see that in every cases the handling steps are reduced. The level of expertise is very, very low. So in EDILA, you just need to place a slide into a cartridge and have to type in some the patient code or the patient name, whatever you use. And the hands-on time is so very, very low. 0.30 minutes, 0 to 30 minutes is rather high explained here. It just me have to say it's 0 to let's say 5 minutes. It's sufficient enough. The turnaround time they write down for 2 to 4 hours. It's a little bit more than I would say because the longest time is the running time of 2.5 hours for the most tests and 3 hours for the longest test, gene fusion. So the summary of the KRAS test is that it fits the current guidelines like ESMO, NCCN, CAP, AMP, and ESCO. It detects 21 different mutations in exon 2, 3, and 4. And it's the fastest available test. It is highly sensitive, and it can be formed directly on FFPE tissue sections. And I have to say that there are some papers that announce that even in wet tissue preps, you can use this test. This is not validated by us, but right now we are supporting a study, for example, in a melanoma study, where a customer suggested to use this too. And they already tried it with wet tissue, and I don't have results, but they told me that it looks very fine. So even if it's not validated, it's not only working on FPE tissues, so it can be used for very urgent cases directly on the wet tissue after you validated the test on your own. The next test is the NRAS-BRAF mutation test. As again, it fits or matches the guidelines. I don't repeat it anymore. The NRAS, the mutations were detected in the same exons 2, 3, and 4, and the BRAF codon 600 is tests. That means 8 mutations of NRAS mutations in the exon 2, 6 in exon 3, 4 in exon 4 are detected, and 5 BRAF mutations in exon 15 codon 600. This means the E, D, K, and R, and E2 are detected. This is important or very nice to see because 8 to 15% of the colorectal cancer tumors are BRAF mutant and can be directly tested with this cartridge too, within one step. The tumor BRAF mutation status should be assessed alongside the assessment of tumor RAS mutational status for prognostic assessments too. So data on the predicted value of BRAF for the anti-EGFR antibodies remain controversial, and there's a relevance to the Lynch syndrome. The result looks similar to the KRAS result before. So you see the genotype for the NRAS. If there's a mutation, it is mentioned here in that line. You have some additional information, and the BRAF genotype is shown as additional aspect here. The CQ value of the NRAS control shows you then a hint if you have used enough material, for example, how good your preparation is, if your material is stable enough, and so on. Again, you have 3 possible results: no mutation detected, plus the CQ value for the NRAS control. A mutation is detected, again, plus the CQ value as an NRAS control, and an invalid. An invalid means that the control was not possible. Again, I will tell you something about the performance of this method. We have here a summary of 2 in-house studies and 2 external studies. We have much more, but this was the early ones. And again, we have rather high concordance. For the in-house, we have 93 for NRAS, 93.7% for NRAS, 99% for BRAF. In the second one, with more than 200 patients or samples, we have 98 and 100%. And then for the external ones, we have really around about 100%, which is very nice because both of them are more than 500 samples in total. now I will tell you something about our newest test, the gene fusion assay. It's available as a research use only version at the moment. That means we will have two different versions. The IVD version, which is still in development, contains the ALK, ROS, and RET fusion transcript as direct expression test. Then we have the MET exon 14 skipping transcript and the indication of the presence of ALK, RET, ROS1 based on the expression imbalance. I will show you in the next slide much more. The research use version only is available already, and it has additionally the NTRK 1, 2, 3 expression imbalance. All the other tests mentioned before are part of this cartridge too. How does it work? Both parts. So the specific fusion detection is rather easy. We have the partner gene, which is known, and we have the kinase gene, which is known for sure too. And we will have a PCR for the fusion, for the known fusion, which looks like this. And this fits to 93% of ALK, 97% of ROS, and 85% of all RET fusion transcripts. For the fusion detection of by expression imbalance, there we have the ability to check or to test unknown fusion partners. So those which are left here can be detected by this one and much more. This is the same for the NTRK part 2. So we have an unknown fusion gene partner, and we have the known kinase gene. What we do is we do a 5' qPCR and compare this with this 3' qPCR and take a look if there are differences in the level. And this is an indication that there might be a fusion, and we emphasize that you should do then a second check if there really is a fusion or not, and maybe if you can check if there which kind of fusion is available. So the report here is a little bit different. What you can see is on the more left side here that we have the specific fusions for ALK, ROS, and RET, which are individually detected or not detected, and you will see that there will be a CQ value for each test. Next, we'll see then the MET exon 14 skipping result. So if the exon 14 is skipped or not. And for the NTRK 1 to 3, we will have the imbalance expression. Again, we will have CQ controls, which are more important here, because these are RNA as well as DNA controls. And that means that you can see if the RNA is degraded, then you will still have a DNA which should fit in the normal with the normal value, but the RNA will have too high value, and then you have to take a look for a new sample or something like that. So this is for the gene fusion, which is very interesting. So we have the valid test, we have an invalid test, and we have an invalid test due to RNA degradation as a possible result. Next, I will show you the BRAF mutation test. The BRAF mutation test is 90 minutes of turnaround time. Usually one 5 micrometer FFPE tissue section of 50 micrometers, 15 square millimeters is sufficient enough. And the neoplastic cell content should be 50%. The hands-on time is always around about 2 minutes. So I won't mention it before. 7 mutations can be detected within exon 600, codon 600. The EGFR test is one of our biggest one. It's 150 minutes. Again, one slice should be sufficient if you have more than 10% of neoplastic cell content. Maybe you can use, if you have too less material, you can use more than one slide, or I see tissue is too thin, you can use more. We have grouped this in several groups, 7 in total altogether. And this number just fits for the liquid version. There we have only 49 EGFR mutations, which are important for the liquid analysis. For the solid tissue, we have 51 mutations detected. Then next, the MSI test is different to the other test. So at first, I would tell you how it works. It is not a mutational analysis for sure. There we have melting analysis. We have a probe, which is binding to the DNA. And next we have the analysis with one peak in the fluorescence part. And this means then the wild type occurred. If you have mutations, you will have a change in the mating curve analysis, and you will have 2 peaks here. This is the internal way it works like. The external value that will be shown to you is much more easier. And at first I will show you that it's using 7 novel biomarkers. And the advantage is that these biomarkers are stable via different ethnies, different gender, as well as independent of age and so on. So they're really, really stable. The results available in 150 minutes again, for sure, 2 minutes of hands-on time only. Again, you can directly work on FFPE tissues, and there's no need for a comparison tissue. So for all our tests, you don't need any control anymore because the controls are always internal. So MSI we are using stable markers, which can be used in multiple cancer types. So there's no need for match normal samples. I have to say that we have validated only for colorectal cancer at the moment, but there are several papers available in the literature which shows it's not only available for colorectal cancers. For example, endometrial cancers are in use. You can get the slides later as a PDF, and you can have directly access via the links here to the PubMed results. In gastric part, it's in use already. Some of my customers are validating it already and are using it in routine or start to use it in routine. It's stable across different ethnies, I've mentioned already. And the short PCR amplicons again show a rather low invalid rate. For example, there was one very interesting paper. I think it is mentioned on the next slide. It should be the Miller paper. No, it's not here. But there we have 0.5% of invalid MSI tests compared to around about 4% IHC as a standard of care method. So we have a reduced quality or invalid rate. Yeah, this was my last slide for our test here. So right now I'm available for any of your questions. If you have some, please let me know.
All right, thank you very much, Dr. Gunther, for this wonderful presentation on new fully automated method of different mutation testing by Edila. So any questions from the audience and participants? All right, if not, I would like to thanks again for joining us, Dr. Gunther, and we would like to move on to our actually last speaker. We have one more topic for presentation. It was planned to be presented by Ms. Hatice from Turkey, but she has got some emergency work to do. And Dr. Eda, her colleague from Turkey, will be presenting on behalf of her. So Dr. Eda, please. Please share your screen and introduce yourself again.
We cannot hear you.
Yeah, we cannot hear you, Dr. Eda.
Presentation plan.
We cannot.
Who is a microscope technician? What does a microscope technician work?
Hello, Dr. Eda, can you hear us? Your voice is not clear. I think we're having problem. Is anybody able to hear clearly? Or perhaps it's my problem, I don't know.
Well, I don't hear anything either.
Okay.
Hello. Hello. Do you have problem?
Yeah, there's echo.
Slight problem.
Yeah, there's echo. Hello, Dr. Eda.
Do you have volume? Do you have volume?
Dr. Eda, can you speak clearly? I don't know. There might be some problem with your connection.
Can you hear me?
Yes,
yeah,
now we can hear you.
Yes, like
yeah, now much better. Can you just start from the beginning?
Start. Okay.
You share your
Just
from
a
the
minute.
first slide and introduce yourself.
Better?
Yes, from the first slide and introduce yourself. Still, we cannot hear you. Could you please share it again?
Okay.
Yeah, perhaps there's some technical problems related to maybe your connection, internet connection.
Okay.
Share your presentation again and start from the beginning. And introduce yourself, please.
Hello to everyone.
We cannot hear you yet.
Yes, now I am with my to everyone. Since I have emergent cerebral institution, I had to present the presentation to you in the form of a video record beforehand. Thank you for your understanding. Yes, now I am with my presentation. Thank you. The place and invitation.
Yep.
I'm listening.
Yes, please. Yes, please, go on. We can hear you now. There's some noise in the background, but yeah, we can see your PowerPoints and hear your voice.
Okay. I'm start.
Who is a microscopy technician?
Okay.
Are the students of the microscope technician. Where does a microscope technician work? Microscope technician training, the place and importation of microscope technician pathologist, collaboration in the pathology laboratory where I work. What is microscope technician? They are assistant personnel who help pathologists, physical or pathology assistants in anatomical pathology laboratory in microscopy sampling of circular specimen and autopsy and prepare the necessary equipment and tools for microscopy sampling. What are the duties of the microscope technician? Performance procedure related to the acceptance of the microscopic specimen, controls the occurrence of patient and specimen information according to the standard protocol prepared by the departments. It reports the data related to the patient to which the specimen belongs to the required paper if available by entering in the online laboratory information system or polling it form in information sites before microscopic sampling chain and the web numbers of the specimen for each patient and returns them one the tissue cassettes. Is overall possible from West and possible errors during microscopic sampling when faced with an error or problems. It tries to find and certain solution by informing the relevant pathology assistants or pathology specialists. Performance microscopy examination of samples approved for sampling according to the standard protocols as taught by the responsible pathologist or assistant. The microscopic description of the specimen, microscopic sampling of the specimen, parts the tissue section made microscopic sampling into labeled cassettes and sent them to the routine laboratory under operative condition. Performance festival procedure under the supervision of the responsible pathologist or assistant during the imperative consultation. It assistant the microscopic sampling and tampering process during the sample of bone tissue. It performs the coating process with the cell under the supervision of the relevant pathology specified or assistant and according with the drawings. In cases where the radiology of specimen needs to be taken, such as breast biopsy, lumpectomy, the autopsy in organization department organization completes the radiology imaging of the specimen and delivers the X-ray to the relevant pathology It carries out the operation related to the storage of the sample specimen, store the sample specimen in storing contents in the specimen's oxidative liquid before archiving it. Check on whether the biopsy numbers on the specimen's drug contents are correct. Archive the sampling specimen in order according to their label numbers in stroking contents so that they can be also found by themselves or others whenever necessary. Discourse this reported specimen by scores them in two medical waste bags in accordance with the standard protocols and according with the standards in the laboratory scientific with the providence and maintenance the tools and equipment in microscopy laboratory performance routine operative and prevent checks on tools and equipment in the microscopy laboratory every day before the laboratory work starts and replacing the definitions example for the technical follow-up akin of the ones used in the microscopy laboratory, the text and corrects there is malfunctions when it times necessary. It informs the laboratory manager and call the technical them to fix those malfunction. After the microscope sampling, it cleans the tools used. Next part in autopsy. Reduce the corpse to autopsy doctor with the concept form of family, the autopsy request form, and patient clinic anamnesis form, which the corpse prepares the necessary equipment for autopsy, assisting the autopsy special in pathology assistant during autopsy procedure. After the autopsy is over, the doll covers the corpse and saw it, delivers the autopsy to relevant branch, the personnel to be written to the hospital morgue. After the autopsy over, he cleans the autopsy or and tools. Where does a microscope technician work? Hospitals that provide academic education, university hospital, education and research hospital, student hospital, private laboratories, forensic laboratories and morgues, as an educator in instituting preventive education in their fields. Microscope technician training in USA. This education is given in universities as a 2 years second degree program, and the fourth second degree program in medicine studies programs opened by Duke University. American second of pathology assistance was available in the case of America. American Association of Pathologist Assistants, the only institute defined girls and a second degree program with a certification field and grading degree with a low degree from graduating, grade test and grade test with a longer degree. In our country, this training technique is under the influence of the special psychology with one works, and there is no specific standard according to material spectrum of the institute they work with. The place in the operation of the microscope technician in study measure the usefulness of microscope technician in the practical of pathology, the number of labs and number of new fragments extract in the breast collector specimen when taken and retired in the study. In the study, microscope technician more lab noticed than specific students. It was determined that there was no statistical difference in terms of the number of positive nodes. When we look at the part, it's observed that the new part was significantly less in the specimen sampled by microscope technician as beginning compared to the specific students. The use of the number in new parts taken as a measurement can be constant or subjective finding because a part from the sample algorithm is the most important factor in now part submission in pathologist satisfaction with the sampling of the case. Do we need a microscope technician training program certification? It is needed because it is necessary to develop a standard for a situation that is current in practice to in the opposite view, the sample for good pathology practice must be done in pathology, so this program should to be front of it. The technician pathologist collaboration and the pathology laboratory work. In the laboratory, we work microscopy sewing is work by a microscopy technician, a pathologist, and technical our team. And therefore, technical should be specific in the fault and imperator themselves. thank you for listening.
Okay, thank you so much, Dr. Eda, for presenting the recorded speech of Ms. Hatice. I think now we are going to close the session, morning session. So, so let us resume the session of sharing and learning after lunch break, which will be at 1:50 UK time. So the afternoon session will be chaired by Dr. Andreas Lubke. So thank you, everybody. It was a pleasant morning session. Those who have missed the session will receive the recorded presentation on August 15 onwards. Thank you, everybody, and we'll see you at 1:50 today for the afternoon session. Enjoy your lunch. Thank you.
Hello, am I audible? Hello.
Hello, yes, you are audible. Thank you. Am I?
So hello, we will start in about 1 or 2 minutes.
Thank you. Can you hear me okay now?
Yeah, perfect. Okay, now it's 14:50 sharp here in Germany, so it's 13:50 sharp UK time, and we will continue with the evening, with the afternoon session. So, and I welcome Dr. Joanne Martin, who will be the first speaker. And she will be speaking about developing a digital future for pathology. And Dr. Martin, the stage is yours.
Thank you very much indeed. And thank you very much to the organizers. You've had a very interesting program today. And I'm going to be talking about digital pathology and the future. I'm going to share my screen with you. And here we go. We are going to be sharing screen. And can you see that fine? I'm going to assume that you can see that.
Yes, perfect.
Thank you. So I come from one of the biggest healthcare organisations in the UK, which is Barts Health NHS Trust, and I work for Queen Mary University of London. And I've seen lots of amazing different digital developments over the last few years. I'm passionate about digital pathology, passionate about the opportunities we've had in this area. I'm going to share some of that with you. I'm going to talk about what is digital pathology, what's going on now, and some of the new digital systems developments that we've got going on at the Royal College of Pathologists, just as a taster for you. So when we talk about digital pathology, basically most of us in histopathology are basically, we hack wax. So we take wax slides, wax sections, very thin wax sections, so we can transilluminate them and we put them onto glass slides. The steps in terms of traditional, I'm talking about traditional as in the past 10 years, digital pathology, is to then scan those slides. And this is where it gets interesting because of the capabilities of this technology. We know that it means that you can sit at a desk any way you like, you can sit at home and look at sections. We know also that in not having to walk around the lab and go and get slides from the files, we can achieve an efficiency gain. And that efficiency gain is really important in the context of our global work shortages in cell path. So we know that in the UK, as in many countries, there's about a 25% shortage of consultant histopathologists. We're training more and we're doing more, but actually being able to share the work, being able to work more efficiently and more flexibly is really important. We all have colleagues who perhaps break a leg. And previously, without digital pathology, they wouldn't be able to continue working because they couldn't get into work. But now you can actually work from home. Now, I'm not suggesting that you should work while you're sick or ill, but it gives you more flexibility to do that. We know that several colleagues are prepared to stay in the workforce rather than retire early because of the flexibility that the digital capability gives us. So it's helping stabilize our workforce at the moment, but we know that probably 5%, probably single figures, maybe even less than that, of departments have access to digital pathology in this classic form. There are some pathologists, though, who have really embraced this. And there's particularly the IDEX network, where you've got 87 pathologists globally linked with 28 scanners. And they'll be reporting 24/7, 365 days a week from all over the world. The interesting thing, though, this is a network of veterinary pathologists who have completely embraced the networking potential of digital pathology. And this, I think, is a real lesson to us as human pathologists in what can be achieved. When we talk about digital pathology, though, we're also talking about other forms of digitization of images. So for some while now, we've been digitizing electrophoresis gels, northern blots, western blots. We've also been digitizing fish and using image analysis on that to help us highlight chromosomal issues. We've also started to digitize our tracking systems, barcoding of blood tests. And given that we do, certainly across England, we're probably doing 1.7 million, using 1.7 million blood tubes a week, an enormous volume of data that's flying around the system within our digital pathology environment. The other massive amounts of data that are coming into our digital environment as pathologists is genetic data, both single SNP type data, but also increasingly whole genome sequencing. And that whole genome sequencing data is coming in droves. We've got databases at the back end of that, so that you can actually interpret a single patient's genetic changes in the context of a global, increasingly global database. So this digital reach of pathology is increasing day by day. The other thing that we're benefiting from as pathologists is we don't have this anymore in many centres. Now, some centres do, but medical records, I was responsible for those once across a large trust as we were trying to change from paper to digital, and paper archives can be fine in certain circumstances, but when you have a problem, then that's particularly troublesome. And as we move to digitising our electronic records and having electronic patient records, this is not a real patient, this is a test one, and this is a sort of basic view of the sort of summary data that you can get. You can get pictures of a summary of problems, you can go into it further, and you can get laboratory results at the same time. In our own electronic patient record at Barts, when you go into it, there's a little hyperlink button that I use when I'm looking at patients, and it can take me to the imaging as well. And as we develop our future in digital pathology, we'll have little hyperlinks where it can probably take us to the pathology imaging, hopefully, depending on the structure of our databases and the way we implement our digital pathology. So that's all coming on apace. But from all this amount of digital data, what's really important is the information, the connectivity, the way we use that data, and then coming on to what we're learning from it and how we can start replacing some of the routine jobs that we do as pathologists with automated solutions. So I've already talked about the digital connectivity and used perhaps the example of the veterinary pathologists, but I'm going to come on a little bit further onto that shortly. So information. Once you start to visualize some of this data, once you start to make the data open, you can start to gain insights about our practice from the data. And this is a publication from a few years ago using CA125 testing, and it mapped it over England. You'll notice that Wales is missing from this. It's because it's an English database, and London is put out as a separate image there. And it looks at the rates of CA125 testing, and that's done by primary care trusts. So that's essentially by primary care regions. And you can see huge variation. So that information from this digital network of data is giving us information about patterns of testing and insights into differences in access for patients to these tests by region. And this sort of information is really important, not only in demand management. So, why are some areas testing quite as high as they are doing, and why are some areas not doing any CA125 testing at all? So their patients are probably missing out. Other areas, their patients may be being over-tested. Now, the truth lies probably somewhere in the turquoise region in the middle, but the data that we get needs to provide us with information that we use. If you look at an example of it closer to home for pathologists, so cervical screening, this is data taken from the Cancer Research UK databases, which are available publicly, so you can look at insight from national screening programs and national mortality related to cancer. You can see on the left, there's the rates of cervical screening. So the percentage uptake of cervical screening in eligible women. And you can see that there's a 4-point difference between Cumbria and Central Lancashire, and that Cumbria's has a higher than average rate of cervical screening coverage. If on the right, you then look at their cervical mortality, you'll see that Cumbria has a lower than average rate of cervical mortality. Now, obviously, it's tempting to have a causal link between the two, but this is just data giving you insights. But this sort of using data, using the full digital capacity of our pathology systems, is where we can provide better value, better fairness, and better insight for our patients in the types of care that we give. I mentioned digital connectivity and what the vets have done, veterinary pathologists have done in the IDEX network, but cloud solutions are becoming cheaper. Cloud storage is becoming cheaper, relatively. Obviously, if there are any suppliers on, it's far too expensive and we'll need it much cheaper. But it is coming down in cost, and there are some big suppliers who are finding very innovative ways of bringing down that cost of storage, which then enables us to share images, to share our data between different environments. It also is coming onto the stage where we'll be able to share directly with patients as well as with colleagues, exactly that type of data. We'll be able to show patients images, we'll be able to give patients their reports, and that will in itself give us challenges. So the NHS has committed to making test results available to patients. I think if I think about my reports, and I'm sure if you think about your reports, I'm not sure many people would be able to understand fully the content of those reports. So we've been in the situation, particularly from my point of view, I met with a family who had had a copy of a report from a different pathologist in a different sector, and I've been asked to speak to them because they were upset. And they were upset because they hadn't been investigated for histiocytosis. And when I started to talk to them, it was very clear that it was a lymph node, and the lymph node had said it had sinus histiocytosis. And they'd gone to Google, looked it up and said, well, why aren't we being investigated for histiocytosis? And so some of the terms we use, particularly when you don't read those, you don't know about them, can be very confusing for patients. So it's a challenge to us as a profession as we develop digital pathology, as we develop digital solutions, to make our wares, to make our reports more user-friendly. Now I'm going to have trouble with that with mine, I know, and I'll have to think hard about how I present that. But it's going to be an interesting time. The other element, and we've got some very good talks on this coming up throughout the conference, is automatic. So AI, automated recognition. So a development of the machine learning that we're familiar with into a more sophisticated form of AI. Now, we're used to using this every time we go through an airport. So we put our passports into the machine readers and they check our data, it checks our picture against our visual recognition, against our passport photo and says yes or no. So we're using this side of technology as part of everyday life. Customs officers look at your bags and there's a circle for high risk particular areas. But if we think about the jobs that we do, there's lots of things that the digital landscape of the future in pathology will let us do much more easily. I really don't want to spend 45 minutes looking for a single acid alcohol fast bacillus, a mycobacterium on a Zell-Nielsen. If I can have any suspicious areas on a ZN highlighted for me quickly, that's going to save me some time. I only need to see one decent TB organism to say I've seen a mycobacterium, and that sort of technology will make my work easier. And similarly, automated image analysis, mitotic rates, all that sort of recognition is coming our way in our digital future. The one area I think people have concentrated on less and we've paid less attention to is actually education in the era of digital pathology. There's a very influential report from Eric Topol that was commissioned by Health Education England and the Secretary of State. And that report was basically saying that we've got this amazing informatics, bioinformatics, digital community of practice. We've got this amazing technology coming on, and we've got a whole workforce that is not that well prepared for it. So how do we move pathology forward in the era of digital? There are some really interesting innovations. So learning has got more immediacy. So Twitter's been a tremendous tool for helping educate. I follow Volcano Labs. It's very good with renal pathology. And, you know, people like Gerard Gardner, colleagues, Sanjay Mukherjee, all of those have got real insight. So it's a way that experts can share learning items with the community really, really quickly. So you can learn in the moment, so this bite-sized learning. There's other tools. So some of you may be aware of Duolingo. So Duolingo's got nothing to do with pathology, but it's helping to teach me Spanish very slowly and very badly. But I can learn, I can do 5 minutes a day. I very confidently tell a restaurant now that I don't eat turtles. Other than that, we've developed, just from Barts and Queen Mary, we've developed the ECPD app, where you can get free, quick learning modules on your phone. And that's not designed for immersive a learning experience. It's not for a deep and interactive experience. It's quick. It brings you bits of information that are really useful to know, and it brings them quickly. So it's very easy to put modules up. You can put a module up in 3 minutes, and it's very easy to do, and it's free. So these sorts of learning approaches are coming our way as well. Some are already here. Leeds has shown the way. Leeds is one of several virtual pathology sites where you can learn pathology. Very, very good coverage of slide libraries and mixed slide sets, and open access as well. So you can look at various slides, whole slide images on this site, and that's a real benefit to the community. So some of these virtual learning sites are really, really helpful. What there isn't though, we came to realize that there was not much that was progressive. So there are lots of slide collections, a bit like stamp albums, when you used to collect stamps when you were little, from all over the world, and we put them in the book, and then you find a new one and put that in the book. And a lot of these slide collections, the equivalent to my old teaching set, I used to have a teaching set, are not really aligned to the curriculum, and it doesn't mirror the way that we train. It's been very interesting that we train machines in a graded way, but we train pathologists in a slightly ad hoc way because it's much more experiential. And we know that some people working in particular sites have less access to certain types of material than others. And often the material is not graded. It doesn't start you off easy. Often on your first day, you'll be faced with a bone marrow trephine or something, and you just don't understand what any of the cells are. You learn, and you learn very quickly. But supporting progressive learning is not something that's really been addressed to date. And the Royal College of Pathologists, in association with Health Education England, are about to launch the new online learning platform here. And this platform is to align digital material to training programs. So progressive, stages 1 to 5 as you go up through training, or 5+ once you're an established practitioner. So being able to refresh, I would find very valuable on inflammatory bowel disease or areas within my practice. Or again, if any of us make a mistake, it's nice just to go back and have a resource that you can check up on yourself sometimes, and just reassure yourself that you're learning well on that. It's graded learning, equal access, and an ability to demonstrate competence. So it will have tests that you can pass, and you can print out a certificate that can help with your assessment of your training at a particular level. We'll be able to do workshops and courses on it, and you'll be able to do dip in, dip out learning at any stage during your training, but also post-qualification. When we think about a typical learning flow, you have a clinical case, you create it as a learning module. So here we create it as a virtual slide tray. An initial question, particularly when you have a virtual slide tray, it might be not what is this entity if it's a complicated one. The answer might be, actually, I don't know, I would ask my colleague. And that will be the right answer for a level 1, for an established consultant. Actually, it might still be the right answer. So if I get something unexpected or something different or something difficult, I will go and show a colleague, and that's safe practice. So when we are as we develop this platform, it will be to mimic training, the natural flow of training, much more closely than just having collections of slides that you can go and see. It'll be perhaps a tray of normal appendixes spiked with one that might have a diverticulum in, one that might have a carcinoid in. And the trick when you start is not being able to diagnose those necessarily, but it will be able to spot that they're different and that they need separate attention. And then as you progress up, you would be expected to get that diagnosis. So this adaptive and conditional learning will be built in, is being built into this portal. We'll be able to combine not only the histopathology and some of the digital stuff, but with images, both clinical and X-ray images, and also data, in just the same way as we would do for a single integrated hematopathology diagnosis. We'll be able to bring a range of data to mimic normal practice. These are some images from the the beta site, and everyone on this call, will be able to contribute cases. You can put the pathology of megarectum up here. So we've just published an extremely big paper on this, I say so myself, the pathology of megarectum. And then you can ask questions. You can put so this particular module has a link to the review paper, and then it has questions with pictures. So it says, what are these particular structures seen in the muscle layer of the colon? And then it would give you this is a single best answer question. So as a test, I put inclusion bodies here, and it will give you a response saying it's a good answer, but there's a better one. And if you do the better answer, it's polyglucosan bodies. These are actually polyglucosan bodies within the wall of the longitudinal muscle of the rectum. And then the feedback here is option 4 is the best answer. And then you can put additional pictures in, you can put videos, you can have a talking head. So when you've got a case that may be a bit controversial, you can put into that case, you can put into that question a discussion as to why it's difficult or what different people might do. We all know that we use different approaches sometimes, and having that feedback to the trainee, it mimics the training environment much more closely. So you can add in that little bit of human contact. I think that's the other thing that we need to be careful of where we're doing in the digital environment. We love our colleagues. We like to talk. We're social creatures, and also all of you are role models. You're role models to your trainees, you're role models to your students, and to each other. And actually seeing colleagues as, even if it's just talking heads in flesh and blood, is a lovely way of making sure that we retain that human element. And as pathologists, I've always said, to know us is to love us. And so the more we can bring that within this learning portal, the human element of the digital learning, I think that's going to be very, very appealing. One thing is this portal is not just for CellPath. This is for a range, all our range of 17 different disciplines. So the CellPath includes cytopathology, neuropath, oromaxillofacial, neuropathology, pediatric and perinatal. So this will be all covered by the portal, and that will add to the richness. So with microbiology, their microbiology insight into particular cases will feed into our autopsy pathology. It may feed into our skin pathology. If you've got a case of ORF, it's useful to know a little bit about the microbiology or the virology of ORF, so that you can make a better informed differential when you get some odd viral condition of the skin on biopsy. So that's where we're getting to with the online learning platform. We've had lots of fun doing this, and you are welcome to join. You can join in. As we get to the future of our digital offer, it's tremendous to see this sort of stage where we're moving from somewhat antiquated laboratory information systems and digital systems into the digital future. We're not quite at the stage where we're doing minority report type hand-waving control of our digital systems, but we're not far off. So on that note, I'd like to say thank you, and I'm going to stop sharing and return to you for any questions or comments.
Well, thank you, Dr. Martin, for this very comprehensive overview of digital pathology applications, future options, and the present, especially in the UK. I think this is very helpful and very interesting. Any spontaneous and direct questions from the audience?
I have a question, please. This is Lubab. I'm from New Jersey, United States. My question is, should I open the video? Okay, I'll open the video. All right. Yeah, my question is are you now using digital pathology for primary diagnosis, for example, mainly breast cancer?
Okay, so in the UK, 5% at the moment are using primary diagnosis, and that will increase. We're expecting to see by probably the end of the year about 15%, and then it will increase rapidly. Most of our regions in the UK are going out to tender for digital pathology solutions at the moment. There are very few that are not actually implementing digital pathology. You mentioned breast cancer. Yes, there are some people doing primary diagnosis on it, but we've got some interesting regulatory issues around breast screening. So yeah, so in the UK we have the National Screening Committee, which regulates, which puts rules around reporting and quality standards. And some of those quality standards include that you can't use digital pathology for primary diagnosis in screening cases. You can for symptomatic, but you can't for screening. You can do your EQA, your quality, your quality, if you like, tests on digital, but you can't actually do the reporting. So we're working nationally to adapt that. The reason for that is because the national screening program in the UK is all evidence-based, and unless there's a controlled trial demonstrating that it's equal or better, then we don't implement it. So, and the speed of technology has sort of outstripped has outstripped the regulatory environment. I mean, we found that with COVID too. As COVID has gone out, everywhere is having to, you know, in the US, you've had derogations from the FDA for drugs and tests and all sorts of things.
Yeah, the same thing actually.
Yeah, it's where you've got rapid rollout. That's exactly what happens. You get behind. Are you using it for primary diagnosis?
No, actually, it's not FDA approved yet. So yeah, that's why I asked you the same question. Thank you.
It is. Right, pleasure. I think we've got some. I don't know whether we've got some more questions in the chat box. So in the chat box, hi Sadia. So digital pathology and our own cell path. So that digital is coming out, and the digital teaching will come up in September the 6th. I think we're looking to launch the portal on that. So we've got, I think, £3 million to put the digital pathology system into our own department. Obviously, that's going to take a few months to roll out, but then the Path portal will be available for initially ST1s, but there'll be material on that relevant to all specialties. I think there'll be a whole set of neuropath very, very quickly as well on that. Somebody asked about, are we all going to be replaced? Is AI going to replace us all? Get asked that quite a lot. So no, I think we're going to be, it's going to be diagnostic support. I think it's going to be information for us. I think there are some jobs that we may well delegate to AI. I think if you're a hematologist or a hematologist looking for malarial parasites or babesiosis, then actually, exactly as I said, highlighting areas of abnormality within a blood slide is actually much more efficient. So it depends a little bit on what you're looking for. So if you're looking for malignant cells or if you're looking for odd abnormalities, but if you're looking in a patient with a patient returning from abroad with a fever and you're looking at a blood film, actually the ability to pick up a parasite quickly is actually very helpful, and there's some very good initial packages on that. Other people are also looking at, we know that some of the firms have been looking at picking up H. pylori from an H&E rather than using a crucifast violet. We know that also picking up areas of dysplasia in colonic or gastric biopsies are tools that many places are looking at. The other thing that AI can be used, not necessarily as primary diagnosis, but as QA. So if you had essentially a machine learning system just saying, hang on a minute, are you sure about this one? I think that can be quite helpful. If you think if the AI oversight picks up an area that doesn't match with what your diagnosis was, then it's always worth a second look. So that quality control, I think many of us have struggled with the time and the effort it takes to audit cases, particularly under a heavy workload. So having automated systems that might be able to review at least some of that workload may be helpful. I don't see we're ever going to be out of a job. Not even our trainees, not even our medical students or scientific students are going to be out of a job in pathology. There's always going to be a job. We might be going to the more difficult end of the market, so looking at the much more difficult cases, but it will be a tool rather than a replacement. I don't know whether there are any other questions there. There are tremendous, there's some really interesting big national programs around. So in the UK, I think the UKRI supported two big pathology-based programs, the NPIC, National Pathology Information Collaborative, and PathLake, and they're both big, multi-center, multi-tens of millions of pounds invested in looking at pathology developments around AI. So we've got some real centers of expertise in and around the nation in this, and I know that's the same in Germany and elsewhere. I've seen some fantastic stuff from the Dutch as well, looking at combining mass spec with image analysis, where you can actually locate proteins. So I'm looking forward to the stage where we replace our immunohistochemistry with a mass spec overlay, so that you can actually not bother with immuno anymore. You can just put the data file up and say, I'd like an epithelial data file. Are these epithelial proteins present in this particular area of the slide? So that one, I'm hoping I'm still alive for, to see that one in practice, but we'll see.
Thank you so much. Thank you so much for this very interesting discussion and good interaction. It's always good to have some questions and answers, because it reflects the speaker's efforts to teach something and to forward some information. So I hope this session will be as interesting as that. So then we would go further on to our next speaker, and I welcome Ms. Aditi Srinivasakini, and we're happy to listen to your presentation with the title "Feasibility of Tele-rehabilitation of Swallow and Other Communication Functions." The stage is yours.
Thank you so much. All right. So I'm very happy to be here. Good evening, everybody. Well, in India, it is evening, so I'd like to wish everybody good evening. My name is Aditi Kini. I am currently a student pursuing my bachelor's degree in audiology and speech-language pathology at the All India Institute in Speech and Hearing, Mysore. So I'll start sharing my screen. Just give me a moment here. I hope my slides are visible.
Yeah,
all right.
Perfect.
Thank you. All right. So the topic of my presentation today is feasibility of tele-rehabilitation of swallow and other communication functions. So my co-authors and study were Mrs. Preeti Shetty Akunje, who is currently a speech-language pathologist at the National Institute of Mental Health and Neurosciences, Bangalore, India, and my mentor, Mr. Prasanna Suresh Hegde at the HCG Cancer Hospital, Bangalore, India. So, moving on with the introduction. So, the internet defines tele-rehabilitation, or e-rehabilitation as it can be called, as the delivery of rehabilitation services over telecommunication networks and the internet. So tele-rehabilitation has been around here for quite a while. It is not a new trend which has suddenly sprung up from absolute oblivion. It has always been there, inconspicuously coexisting with the other aspects or the other disciplines of telemedicine. And there are a host of different therapies and rehabilitation treatments, such as motor training exercises, use of virtual rehabilitation exercises by using VR headgear for balance retraining. And then we have robotic training and robotic therapies, group therapies, and of course, my domain, speech and language therapies, which have been utilized and practiced by a host of different professionals, a lot of different professionals, such as physical therapists, occupational therapists, speech and language therapists like myself, audiologists, and psychologists or psychotherapists all across the world for about 2 decades now. So telerehabilitation is believed to have begun or initiated in the year 1998 when the NIDRR, or the National Institute on Disability Rehabilitation and Research, funded the first RERC, or the Rehabilitation Engineering Research Center program on telerehabilitation. So recently, we have seen that the world has faced a very deadly pandemic, or the novel coronavirus pandemic, which has reinstituted or the rehabilitation via telemode has been brought back into the limelight. It has been resurrected, as I'd like to say, ever since the advent of the social distancing norms, which have been brought in place so as to help control the spread of the COVID-19 pandemic. So a lot of professionals like speech and language therapists, speech language pathologists, audiologists have now resorted to using telemode or tele-rehabilitation or telemedicine as a way of speaking to their patients, consulting with their patients, and providing therapies and treatments with their patients. So there is a lot of new like as we're seeing a lot of new ventures, like I'd like to say, there are a lot of new ventures coming up, a lot of new ideas with regards to telerehabilitation, which have been brought up by a lot of these professionals, even physiotherapists, occupational therapists who have now started using telerehabilitation, have brought up a lot of new ideas and new ventures with regards to teletherapy. So during these extended periods of lockdown, it was not just physicians, but allied healthcare professionals like myself and practitioners of rehabilitation medicine and therapies have resorted to using different teleconferencing platforms. The most commonly known ones are Zoom calls, Google Meet, and Microsoft Teams to conduct, like I said, teleconsulting and teletreatment or rehabilitation sessions with patients. So this was one of the reasons why we felt that we had to look into this new mode of treatment, relatively new mode of treatment, more closely, analyze it, and to derive efficacy figures by speaking to professionals who have been using it for quite a while now, as opposed to offline therapy. And another reason why we decided to conduct the study was because there is a lack or there is very limited literary evidence which supports telerehabilitation, especially with regards to speech and language therapy, with regards to its efficacy and practicality. And the studies which are there have rather arguable or undefined results, which do not answer many of the questions that we have. So in our study, we aim to assess and quantify the effectiveness of telerehabilitation with an emphasis on disorders of swallowing and other communication functions, and with regards to the patient population, which is primarily dealt with by speech language pathologists in India. So the methods and materials that we used. So we developed an online questionnaire which was circulated amongst about 100 speech language pathologists scattered all across India. So we developed a Google form which was very familiar with most of the speech language pathologists. So they were quite comfortable in filling up a Google form as opposed to any other platform, which is why my mentor and I decided to go with a Google form. So we circulated this Google form via email amongst 100 speech language pathologists practicing in India, all across India. So it was not just limited to one state, it was limited to all the states of India. And the experience of these participant SLPs ranged from 0 years of practice. So we had freshers who had just cleared their degrees, who had just been licensed as speech language pathologists. And we also had speech language pathologists who'd been practicing for about a decade now, and who had seen a lot of different patients and who had probably been using teletherapy to some extent before the lockdown happened. So when we analyzed our study and when we came to the results, we saw that our results were quite interesting, and we divided our results into 3 subdivisions. So we divided them on the basis of function, disorders, and the challenges that we face during telerehabilitation. So I'm going to go over each of these subdivisions one by one, starting off with functions. So when we assessed the functions and the efficacy of speech language pathology, telerehabilitation, with regards to the different functions that speech language pathologists looked into, we found that phonological processes, language, articulation, reading and writing were most effectively dealt with via teletherapy by speech and language pathologists. And then we had cognitive linguistic skills, which was also effectively dealt with, but probably not as effectively dealt with as opposed to phonological processes or language and articulation and so on. And then third, we had oromotor functions. So with regards to weakness in the oromotor structures, then we had oroperipheral motor examinations, which were conducted via teletherapy. And we also had oromotor exercises and oral placement therapies, which were conducted via teletherapy, which this practicing speech language pathologists had been doing via teletherapy, which were not as effectively dealt with as opposed to cognitive linguistic skills, but nonetheless, they were quite effectively handled. And then we had feeding and sensory integration. And lastly, we had swallowing, which was felt by most speech language pathologists to be least effectively dealt with. Now, this is because when we deal with swallowing disorders such as dysphagia or aphasia, there are a lot of maneuvers that we would prescribe to the patient to be used, a lot of maneuvers, a lot of therapy techniques. And as with me deal with a very vulnerable population of patients, such as in a head and neck cancer setting, the patients are quite vulnerable to swallowing, probably aspirating, choking, penetration, and it is always advised that they have a physician and a allied health professional such as the speech and language pathologist by their side when they are practicing these swallowing maneuvers, so that we can deal with it effectively if in case there is any hazard or any mishap which occurs when they are practicing these swallowing maneuvers. So many speech language pathologists were rightly of the opinion that swallowing disorders were probably not as effectively dealt with as opposed to all the other functions that we looked into during our study. Next, with regards to the disorders that we looked into. So the most effectively dealt with disorder, as felt rightly by all speech language pathologists, was fluency disorders or stuttering. And now this is because a lot of patients who do present to us with fluency disorders or stuttering and who do take up teletherapy or who are willing to take up teletherapy are adults. And it is very easy to take therapy. It is quite effective to take therapy for patients who are adults and who have fluency disorders with no other comorbid conditions, as opposed to handling children or pediatric patients over teletherapy who may have some level of language delay or some other speech language disorder or probably motor or cognitive impairment. So associated with stuttering, that is. So a lot of speech language pathologists did feel that fluency was most effectively dealt with and it was the most easy to handle, and the results were also very promising even when handled via teletherapy. Next, we had motor speech disorders such as dysarthria, apraxia, and adult language disorders such as aphasia, which were most effectively dealt with after fluency disorders or stuttering. And then we had maxillofacial anomalies, which were the third most effectively dealt with disorder on via teletherapy. And with regards to maxillofacial anomalies, it is with respect to their swallowing, with respect to their articulation, with regards to their speech and overall quality of communication and all of that. And that was also effectively dealt with, but probably not as effectively dealt with as fluency or motor speech disorders per se. And then we had cognitive linguistic skills and AAC or augmentative and alternative communication. Now, cognitive linguistic skills are something that is very difficult to handle via telemode, and that's because majority of patients who present to us with cognitive linguistic difficulties are below the ages of 10 or 8, and they're very young, they're children, and it is very difficult to get children to sit for anything, even online. Even for nowadays, kids are having classes online, they're attending school online, and it's quite a challenge to get young kids to sit in front of a screen for so long. And considering that most of our teletherapy sessions, or any therapy session for that matter, is most effective when it lasts for a minimum of 20 to 25 minutes. So when we try to get children to sit in front of a laptop or a tablet computer for beyond 5 minutes, it's probably going to be quite a bit of a challenge there. And that's why cognitive linguistic skills were not as effectively handled by speech language pathologists, and the prognostic indicators were not as promising via teletherapy as opposed to the other disorders that I'd mentioned earlier. Same goes for alternative and augmentative communication, AAC, which was also most effective when dealt with offline. Then we have swallowing disorders or dysphagia and behavioral issues that also, like I said earlier, it is always advisable to have a physician or a speech language pathologist by the side of a patient who is practicing swallow maneuvers, or anybody who can monitor the patient, basically, because we want to avoid any mishaps. We want to avoid any cause for choking or aspiration which the patient may face. So probably, and rightfully so, the speech language pathologists who participated in our study felt that swallowing was not as effectively dealt with via telemode. And lastly, we had auditory verbal therapy or auditory training. And now there are three reasons for this. The first reason being that, once again, patients who do come to us for teletherapy or auditory verbal therapy, AVT as it's called, or auditory training, are mostly pediatric patients with hearing impairment who've been fitted with a hearing aid or a cochlear implant. And like I said earlier, it is very difficult to get them to sit in front of a laptop screen for so long and to actually focus and to pay attention and to coordinate with us when we're taking therapy. So that's one of the challenges there. And the second challenge is that in AVT, one of the core principles of AVT is that the patient should be seated in front of the clinician or the therapist, and the therapist should be speaking right into the microphone of the BTE hearing aid or the cochlear implant, or next to the microprocessor. So it is important that the child or the patient is able to hear. There is no barrier or there is no hindrance to the speech of the clinician or the speech language pathologist and the microphone or the speech processor of the cochlear implant which the child is wearing. And the third thing is that obviously any hearing which has been restored artificially via use of a machine like the hearing aid or a cochlear implant is going to sound somewhat mechanical and somewhat distorted. It's not going to be as clear and as perfect as we normal hearing individuals would be exposed to or would experience with our normal ears. So there is going to be some level of distortion in the first place, and adding on, we have added distortion coming in from speaking on a laptop or speaking via telemode or via teleconferencing or phone call even. And in parts of India, especially rural parts of India, where a lot of my patients are from, internet connectivity is not always good. In fact, we barely get 4G network in all parts of India. So it's going to be quite a challenge there. There are going to be a lot of breaks and there are going to be a lot of distortions and a lot of disturbances in teletherapy, and that's going to ruin the overall experience of teletherapy altogether. And obviously we're not going to get very good results from teletherapy, especially for hearing impaired children who reside in rural parts of India with a poor internet connection. So those three are the reasons why many speech language pathologists felt that AVT was not as effective when dealt with via telemode. And finally, we assess the challenges faced by the clinicians during tele-rehabilitation. And as we can see from this pie chart, the biggest challenge that the speech language pathologists faced was with regards to the standard operating procedures or the SOPs and the material for intervention as well. And actually, I think material for intervention was the biggest challenge here, and all the other issues were also quite challenging, but not as much as material for intervention. And that's because most speech language pathologists are accustomed to taking teletherapy, are accustomed to taking therapy via offline mode. And teletherapy is something which isn't new, but it's not very commonly used here due to a lot of different reasons. And that's why we don't have a lot of material which have been developed specifically for tele-intervention or tele-rehabilitation per se. And we've had to resort to using materials which were actually developed originally meant to be used during offline or in-person evaluations and in-person clinic visits. So that was one of the biggest challenges that speech language pathologists and all clinicians actually that who we did assess in our study faced with regards to telerehabilitation. And then we also had challenges with regards to taking feedback from the patients, setups at home of the patient, which I have mentioned again. Many of our patients are from rural backgrounds, so for them to be able to afford high-speed internet connectivity and a wonderful laptop with great graphics and great speakers would be a big challenge actually. And documentation was also an issue for quite a few speech language pathologists. With regards to a clinical setup which specifically caters to speech and language tele-rehabilitation was also an issue, because most of our clinical setups are meant to be used or are designed to cater to offline therapy. And once again, standard operating procedures were also an issue that speech language pathologists faced during telerehabilitation. So, what did we conclude from these results? Point number one is that most speech language pathologists who participated in the study were of the opinion that telepractice or telerehab was more effective when used for as a screening tool rather than a diagnostic or an assessment tool or for any sort of therapy or treatment intervention. The second point is that tele-rehabilitation of exclusive speech, language, or voice disorders. And by that, I mean patients who only have a specific speech disorder like stuttering or fluency, or a specific language disorder such as aphasia, or a specific voice disorder like only dysphonia. So they don't have any other comorbid conditions, were most effectively dealt with. It was more feasible to handle these sole conditions only than those speech language disorders which were also associated with other comorbid conditions such as disorders of behavior, cognition, hearing, the autism spectrum disorder, other sensation issues or dysphagia or swallowing issues. The third point is, once again, like we came across in the results, stuttering or disorders of fluency were observed to be most effectively handled via tele-rehab as opposed to other disorders of speech or language. And I have mentioned the reasons earlier as to why disorders of fluency were most effectively dealt with as opposed to all the other speech and language disorders. And finally, we also concluded that auditory training or AVT via telerehabilitation or virtual mode was the least effective and showed the least positive prognostic indicators amongst all other intervention approaches. So that brings me to the end of my presentation. I'll stop sharing my screen. All right. Any questions?
First of all, thank you, Ms. Kini, for this wonderful description of the speech language pathology. Unfortunately, I'm anything but no expert in speech pathology. So, however, are there any comments or questions from the audience?
Is the question for me?
No, I just encourage the audience to ask questions if there are any. As I said, unfortunately, I'm no expert in speech language pathology.
Yeah, I added a question in the chat box. Please check your chat box.
All right. How did COVID affect kids with speech language, and how did they accept the idea of virtual teaching?
Yeah, I just want to explain that you explained the challenges from your point of view as a therapist, but you didn't explain it from the kids or the children point of view, right? I think it's very challenging, but please go ahead.
Okay, the way COVID has affected children with speech and language disorders is quite extreme, as I'd like to say. A lot of children had a lot of setbacks with regards to their speech and language development. So before coronavirus struck, they were actually on track. So they were actually progressing. A lot of our children that we see at our clinic were actually progressing very well with regards to their speech and language development. But because of the pandemic, there was a very, very long lockdown here in India. And because of that, a lot of children had to put their tele-rehabilitation, they had to put their rehabilitation on hold. And that caused quite a bit of a setback with regards to their speech and language progress. So there was probably a huge gap with regards to their, we'd like to mark our progress with regards to the receptive language and the expressive language of the children. So there was a huge gap with regards to their chronological age and the receptive age for language and expressive age. So there was a huge gap that was formed. There was already a gap before the coronavirus hit, and after the pandemic, after the lockdown, there was a even bigger gap. So it was very, very challenging for them and for us to bridge that gap. And I would say, with regards to an Indian context, out of maybe 10 patients, only 5 or 6 patients, or maybe even lesser, actually showed up for teletherapy. And like I've said, there's a lot of issues here with regards to being able to afford a very high speed internet connection, or a laptop or a tablet, or even their phone. And even if they were able to afford all of that, network interruptions were quite common. So a lot of parents also felt that telerehabilitation wasn't going to be as effective for these kids, and they dropped out. However, we did have a couple of patients, we did have a couple of parents who did feel that telerehabilitation is quite promising. So they did join us for teletherapy, and it wasn't as effective as offline therapy, but nonetheless, we were able to bridge the gap by a couple of months. So maybe 1 or 2 months tops, we were able to bridge the gap between the chronological age and their RLA and ELA, or the receptive language age and the expressive language age of the kids. So this is how COVID has affected children here in an Indian context with regards to their speech and language development. And answering the second half of your question, that is how they accepted the idea of virtual therapy, I'd say about 50 to 60% of these patients were quite accepting, but not always. And they weren't very regular with regards to attending therapy as well. So they had a lot of issues back in their hometowns with regards to their internet connection and the stability of the networks. So yeah, I hope that answers your question, ma'am.
Yeah.
Thank you.
Okay. Any more questions from the audience? No? If no, then thank you, Ms. Kinney, for this very contributing and talk about speech-language pathology. And unfortunately, our next speaker, Dr. Raduta, is not present. However, we've got a digital version of her presentation. I will just try to share my screen so we can play this one. So this is a presentation of Dr. Diana Alexandra Raduta from Covina Clinical Hospital, obviously from Romania. And this is about primary non-Hodgkin lymphoma of the colon, the natural evolution. Let's see if it works. Unfortunately, I cannot hear any voice? Okay, and you cannot see it. Okay, again. So I start over again. Well, I cannot hear any voice, but I just downloaded it. Oh, very well then. So unfortunately, there's no tone. But I give you 1 or 2 seconds to have a look at the presentation. So, but then we will continue with our next speaker. Just a second. So I'm sorry about that, but this was quite a brief swapping in presentation mode. So I would like to call on our next speaker, Dr. Simran Sharma. Are you there?
Yes, so I'm here.
Oh.
Am I audible?
Yes, I hear you, but I cannot see your screen.
Actually, the device I'm using, it does not allow for the video option.
Okay. So just try to share your screen. Your voice is good.
Okay. Is my screen visible, sir?
Yes, perfect. So if you'd like to start, the stage is yours.
Okay. Greetings to everyone. I am Dr. Simran Sharma, a PG first year resident from University College of Medical Sciences, New Delhi, India. My mentor is Dr. Richa Gupta, ma'am. I'll be talking about a case report in dermatopathology that we have worked on from the past 1 month. So this patient came to us in the OPD, in the derma OPD, and we worked it up in the histopathology section. The topic is verruciform xanthoma in a middle-aged Indian patient, a rare clinical pathological entity. Verruciform xanthoma is an uncommon mucocutaneous, asymptomatic, benign lesion, mostly on the oral mucosa in middle-aged individuals, accounting for 0.025 to 0.095% of cases with an unknown etiopathology and no sex predilection. Predominantly, it is a warty growth resembling a viral HPV-induced papilloma. Histopathologically, it is diagnosed by presence of lipid-laden foam cells in the papillary region of connective tissues. The foam cells on ultrastructural studies have been concluded to be fat-laden macrophages. Histologically, the verruciform xanthoma is distinguished from other lesions by the presence of large number of foam cells in and essentially limited to the connective tissue papillae. The foam cells on ultrastructural studies have been concluded to be fat-laden macrophages. Other cell types, which include Langerhans cells, intraepithelial neutrophilic infiltrates, and even fibroblasts, have been reported. A variable degree of parakeratosis, that is retention of the nuclei in stratum corneum, is observed, which is present in the crypts between papillae, which are of variable length and thickness, often extending close to the surface. The retipegs are extremely elongated and uniform. Almost every verruciform xanthoma case is diagnosed on histological examination, as the clinical appearance is not very diagnostic. Differentiation from other verrucous lesions with foamy or granular cells is not difficult, as the verruciform xanthoma is the only lesion to have these cells confined to the dermal papillae. The differential diagnosis includes erythroplasia of Currat, which is also known as Bowen disease of the glans penis, seborrheic keratosis, verrucous carcinoma, verruca simplex, condyloma acuminatum. The treatment of verruciform xanthoma lesion involves a local surgical excision, which is almost always curative, and recurrence is rare in this entity. So my case report is the following. A 45-year-old male presented with a painless, small, solitary, insidious ulceroproliferative growth on the right lateral border of the tongue, with a history of smoking for 5 years and being non-alcoholic. This is the verrucous lesion that was noticed externally. On clinical examination, a yellowish white, soft, cauliflower-shaped exophytic lesion measuring 1 centimeter into 0.5 and 0.3 centimeter was observed on inspection, and it was non-tender on palpation. A provisional diagnosis of a papilloma was made. Further, an excisional biopsy was taken to rule out a malignancy. Histopathological examination revealed surface parakeratosis and accumulation of foamy macrophages in the connective tissue papillae among the uniformly elongated epithelial ridges. However, neither the coilocytes nor any dysplasia was evident. Hence, an HPV infection could be ruled out. Upon immunohistochemical staining, neutrophilic infiltrate of the epidermis with CD68 positivity, PAS positive and diastase resistant xanthoma cells confined to the papillary dermis were observed with an awaited P16 report. Our center is still indenting the P16, hence the report is awaited. This is the histopathology image of the verruciform xanthoma microscopically in various magnifications, 4x, 10x, 20x. I'll be explaining it in the next slide. Here, there is a superficial hyperkeratinized stratified squamous epithelium with a verrucous surface, which can be clearly appreciated. Also, there is subepithelial plasma lymphocytic infiltration that can be seen, and this is a 40x power view. In this image, we can see that there are xanthoma cells within the connective tissue papillae. The next slide is about the immunohistochemistry images, the study and the special stain. This xanthoma cells, which showed CD68 positivity, has been depicted. We can clearly see how clear the CD68 has been coming as positive in these cells. The xanthoma cells were PAS positive and diastase resistant. As we can see, there is a PAS positivity which is being depicted. Interestingly, several concomitant oral and skin lesions have been described in patients with verruciform xanthoma, which are oral discoid lupus erythematosus, lichen planus, dystrophic epidermolysis bullosa, epidermal nevi, leukoplakia, focal acantholytic dyskeratosis, pemphigus vulgaris, and chronic graft versus host disease. It's It's noteworthy that most of them are closely associated with a basal membrane destruction and a damage to the epithelial cells. Therefore, the presence of a concomitant verruciform xanthomatous lesion in such patients may be explained hypothetically by a secondary or a dystrophic phenomenon. Moreover, the xanthoma cells have been reported even in case of injury patients, like in case of scars, post-scarring or bites, even burns, and in areas of chronic inflammation such as atopic dermatitis, which can be related to allergy, and contact dermatitis, irrespective to the patient lipid profile. The clinical differential diagnosis may be challenging. However, the histopathological features are diagnostic and well-defined. It is noteworthy that in a small and superficial biopsy, the xanthoma cells may be scanty and their presence can be missed. Histopathological examination of the biopsies to distinguish it from other verrucous lesion becomes imperative due to difference in the prognosis and management. The treatment of choice is surgical excision, effective, and there is almost no chances of recurrence. Thank you all. It was a short presentation. Happy conferencing. I'll be welcoming any questions from anyone. Sir, you are not audible, so I'm not able to hear you, sir. Still not audible.
Please, in the meantime, check your chat box. There are like 3 questions for you.
Yes, I can see there are 2 questions. First is hyperlipidemia a risk factor for verruciform xanthoma, and what are the other risk factors? So yes, am I audible, ma'am? Hello?
Yes, you are.
Hello?
We can hear you, doctor.
Okay. So yes, the other risk factors, which include trauma and even surgical excision, it can develop post that, and infections, burns, and other hyperlipidemic states. And hyperlipidemia, primarily, yes, it is a risk factor for verruciform xanthoma. Talking about the second question, that is recurrence after excision, as per papers which I have read globally, there are, I think I found only two or three papers which talked about the recurrence rate in case of a verruciform xanthoma post an excision biopsy which is done. And one paper talked about the development for carcinoma and carcinoma.
Ich bin gerade in einem Online-Meeting und ich bin Chair. Ich habe aber diese...
I'm not able to hear. I'm sorry, I'm not able to hear. Can you please type in the chat box?
So now I should be audible again. Test, test, hello. Can you hear me?
Yes, sir, we can.
Thank you. Okay, so I hope all something went wrong with my headset, so maybe the battery is low or something else. Anyway, have you all the people who put questions in the chat box, are your questions have they been answered?
I just asked like if we performed HPV by in situ hybridization on this case.
Any comments on that? So if not, well, we move to the next speaker, which is
Yes, question I can see in the chat box that is there any relation or predilection with age? So yes, most of the papers and most of the studies, they say that the middle age between 20 to 45 years are affected, although there's no sex predilection that is associated with these warty verrucous lesions. And yes. Any more questions?
Yeah, I just wanted to know if you performed the HPV by in situ hybridization on this case, please.
So I can listen to you partly, ma'am. I think I've been asked about HPV hybridization. That's what I can make out. So yes, since our center does not have a facility for hybridization studies in the micro or the pathology department, but yes, even if we perform the in situ hybridization technique, since it is definitely a verruciform xanthoma lesion and it was negative for HPV, hence I think the in situ hybridization wouldn't really help much in this case. We could have performed it if we were having the facility for it.
Thank you.
Thank you, ma'am.
Okay, so if there aren't any more questions, are there some more questions? If no, well, thank you again for answering all those many questions. And I call up the next speaker, which is Dr. Mahia Janahanan, and she will talk about adenoid ameloblastoma, a less known variant of ameloblastoma. So the stage is yours. Please go ahead.
Thank you, sir. Am I audible to all of you?
Yes, you are.
Yeah. Can I share the screen now?
Yes.
Good evening, one and all. At the outset, I would like to thank the organizers of 8th Emirates Pathology and Digital Pathology Conference for organizing such a wonderful conference and bringing pathologists from across the world together on a single platform today. And I'm extremely happy to be a part of this conference. And this paper comes to you from Amrita School of Dentistry, which is affiliated to the University Amrita Vishwavidya Bedam, which is located in the beautiful town of Kochi, Kerala, India. And I'm Dr. Mahija Janardhanan, professor in Department of Oral Pathology and Microbiology. And my presentation is titled Adenoid Ameloblastoma with Dendritic Formation. And in this presentation, I'll be introducing to you a less known variant of ameloblastoma. Odontogenic tumors, they are rare heterogeneous group of tumors which occur in the jawbones, but sometimes you can rarely see them in the mucosa also. And they arise from the odontogenic apparatus, which is commonly known as a tooth germ, which is a complex structure composed of enamel organ, which is of oral ectodermal origin, and the ectomesenchymal components like dental follicle and dental papilla. So depending upon which component gives rise to a particular tumor, you have a wide variety of tumors with varied histopathological features. And WHO had classified these tumors based on their origin as purely epithelial tumors, mixed tumors, and ectomesenchymal tumors. Diagnosing odontogenic tumor is often not a big issue because the histopathological features are well defined. And it's easy to fit in the diagnosis with the histopathological features often. But in our practice, in pathology practice, we often come across some cases which do not fit exactly into a particular tumor which has been already described. It happens even with odontogenic cyst. So adenoid ameloblastoma is one such case. We had a problem with diagnosis when the patient came to us initially and when we saw the slide. Adenoid ameloblastoma is a type of ameloblastoma, which is recently recognized as a variant of ameloblastoma, which is characterized by the presence of ductal structures associated with amyloblastomatous neoplastic proliferation. This entity was first described in 1959 by Waldron, who in one of his cases, he observed adenoid component associated with amyloblastomatous component, and he had a doubt whether it's an odontogenic tumor or a salivary gland tumor. Later, much later in 1994, Brannan introduced the term adenoid ameloblastoma in his report, which was looking very similar to the case which was described by Waldron. In spite of the fact that around 40 cases are reported in the literature, in English language literature, it is still not recognized officially as a distinct entity, and it's less known among the clinicians and the pathologists, and hence the clinical features, diagnostic characteristic, biological behavior, and prognosis still remains less understood. Now, let me take you to the case which we had in our department a few years back. A 60-year-old gentleman came to our clinic with the complaint of a diffuse swelling on the right side of the lower jaw of 3 months duration. There was associated a pain which was intermittent in nature, and it was a throbbing sort of pain he had, for which he consulted a dentist where he got a root canal treatment done for 2 of his anterior teeth. When the patient came to us, he presented with mild facial asymmetry due to a swelling which was present in the lower jaw, the anterior part of the lower jaw. And on intraoral examination, we could see a swelling which was measuring around 4 into 3 centimeters in size in the anterior mandible, extending from the right mandibular canine to the left mandibular central incisor. On palpation, it was bony hard in consistency, and there was a buccal cortical expansion, and there was areas, fluctuant areas on the buccal cortex, which was suggestive of a perforation. It was pretty obvious that the lesion was intraosseous, so we advised imaging, we advised radiographic evaluation, and OPG was taken, and the OPG showed, orthopedagogram showed a well-defined unilocular lesion in the anterior mandible with specks of ossification towards the bottom line. And what was more interesting here was that entire teeth in the region showed a resorption of the root. You can see the resorbed root in all the teeth here, and 2 of his anterior teeth were root canal filled. The cone beam tomography was also advised since we wanted to know the extent of the lesion, and we found that there was a huge lesion in the anterior mandible. The buccal cortical plate was completely gone. The lingual cortical plate was thinned out, and there was area of perforation on the lingual cortex. So this is a 3D reconstruction image showing the position of lesion. You can make out that the buccal cortical plate is gone, and there is lingual perforation also here. So with this clinical picture and radiographic presentation, we considered the following differential diagnosis. Radicular cyst was considered in this case because the patient had pain in the teeth and 2 of his anterior teeth were root canal filled. So radicular cyst is an inflammatory cyst, or inflammatory odontogenic cyst, which is often related to the non-vital tooth. Here, the tooth was non-vital, and we are seeing the lesion in the periapical region. That was considered, hence that was considered as a diagnostic possibility here. But usually radicular cyst doesn't grow to such a large size, and it doesn't cause destruction of the bone. And the resorption also was not very common with radicular cyst. Hence, we thought about other odontogenic, developmental odontogenic cyst, like calcifying odontogenic cyst and glandular odontogenic cyst. Calcifying odontogenic cyst is a lesion, odontogenic lesion, which is an aggressive lesion, which occur in the anterior part of the mandible and maxilla. Unlike most of the odontogenic lesion, this is commonly seen in the anterior part of the jaw, whereas odontogenic keratosis, ameloblastoma, unicystic ameloblastoma, etc., commonly seen in the posterior part of the jaw. Now, coming to glandular odontogenic cyst, this is again an extensive aggressive lesion, which commonly occur in the anterior part of the mandible. So that was also considered. Here, odontogenic keratosis, ameloblastoma, unicystic ameloblastoma, they commonly occur in the posterior part of the mandible, but they are aggressive lesion. Here in this case, there was a perforation of the buccal and lingual cortical plate, and there was a resorption of the bone that was suggestive of an aggressive lesion. So we thought of a distant possibility of these 2 lesions too. But in the case of odontogenic keratosis, usually odontogenic keratosis grows in an anteroposterior direction and doesn't cause much of bicortical expansion in its early stage. But this lesion was not very extensive, but there was buccal cortical perforation and expansion and buccal cortical perforation. Apart from this odontogenic lesion, we also considered lesions like simple bone cyst and aneurysmal bone cyst, which are common bone cysts which occur in the bone. Now, with this preliminary evaluation, these surgeons went ahead with incisional biopsy. They were in fact planning to do an incisional biopsy, but when they opened the area, they found a cystic lesion in the mandible, and hence they enucleated the entire lesion, and we received a cystic specimen in our lab. This cystic lesion was measuring around 2.5 into 1.5 into 1 centimeters, and the luminal side was irregular, and there was neural thickening also, whereas the outer surface appeared to be very smooth. So from this specimen, we took representative bits and we gave for processing. And when the slides came, as with the clinical presentation and with the gross finding, we felt that this could be a cyst only because there was a epithelial lining here. And this epithelial lining was stratified squamous epithelium, and there was no keratin layer over there. It was not keratinized. And if you look at the epithelium, they are consisting of the squamous cells, and the basal layers were either flattened or cuboidal. But focally, in some areas, we were able to see tall columnar cells with reversal of polarity resembling ameloblast, which was suggestive of odontogenic lesion. Then again, in the connective tissue stroma, it was not purely a cystic lesion. It was not purely a cystic lesion. In the connective tissue capsule, we were able to make out the neoplastic component also, which was odontogenic. So here in the slide, you can appreciate the formation of dentinoid, the hard tissue formation, which is suggestive of some inductive changes which is going on between the epithelial tumor component and the connective tissue stroma, which form the capsule. So the tumor proper, the neoplastic area, was giving the typical presentation of an ameloblastoma. You can make out the basal tall columnar cells with showing reversal of polarity, and the superficial layer, which was consisting of the stellate reticulum-like areas. But within the tumor parenchyma, we were able to see cells which were arranged in nodules. You can make out multiple nodules, similar nodules you get in adenomatoid odontogenic tumor. But usually we do not see such nodules in ameloblastoma. And here also we can make out this inductive changes. So in this slide, the tall columnar cells, which resembles amyloblast, showing reversal of polarity and subnuclear vacuolization, is very evident here. And you can also see the epithelial nodules and some duct-like spaces. Okay? These duct-like spaces were lined by a single or multiple layered cuboidal or columnar cells. Here you can see the epithelial nodules or whorls, and these whorls were consisting of either the polyhedral cells with clear cytoplasm, or in some areas we could make out the spindle cells which were forming the whorls. And closely associated with these whorls, you can also make out the small ductal spaces. And in some areas, the inductive changes were obvious in the within the duct also. So these are the ductal spaces which are evident. You can see small and large ductal spaces, and these ductal spaces didn't seem to be a true duct. Even if some secretory material was seen, you can make out clearly that there were blood vessels. Okay? Blood vessels lined by endothelial cells were seen. So these were the pseudo ducts, not true ducts. And in this image, it's very clear. You can see a ductal space and lined by columnar cells, many layers of columnar cells. And you can see that there's an endothelial lined blood vessel here and RBC within. So what we're looking at were not true ducts, they were pseudo ducts. And in some areas, we could make out some focal collection of cells which can be termed as ghost cells. These are altered epithelial cells. You can make out the eosinophilic cytoplasm and the faint outline of the nuclei. In some areas, these ghost cells were undergoing calcification too. So here in this picture, you can make out the epithelial lining. This is a cystic lining, the tumor component, and at the junction between the epithelium and connective tissue, inductive changes were evident. You can see hard tissue formation, and these hard tissues seem to be dendrinoid material. In this image, you can also see the collection of those cells. And this inductive changes were evident throughout the entire length of the cystic lining, and it was seen as a ring surrounding this epithelial component. And these areas, this dendrinoid material was irregular towards the epithelial component, and you can see cells lining the dendrinoid matrix. And towards the capsule, this was almost smooth. And you can also see the cells, the tumor cells, which are entrapped within the dendrinoid matrix. So here the clear cells which are entrapped within the dendrinoid matrix is very clear. This is a tumor component, the tumor epithelial component, the tumor parenchyma as such, and this is the connective tissue. And this is the dendrinoid matrix, which is formed at the junction of the epithelial component and the connective tissue stroma. And in one area, we could make out the dendrinoid matrix, which is undergoing different levels of mineralization and maturation. This was the cystic side, the cystic epithelial side, where you can see the epithelial tumor cells. Dendrinoid matrix is very evident here. And you can see that here, you can see a mineralized zone. The dendrinoid matrix was undergoing mineralization. And what you're seeing here is a proper dentin with dentinal tubules. So with this microscopic features, we were thinking in terms of amyloblastoma, solid or unicystic, calcifying autoantogenic cyst or dentinogenic ghost cell tumor. But amyloblastoma, usually it shows the typical stellate reticulum pattern and the tall columnar basal cell. Rest of the features are not seen in amyloblastoma. And the conventional amyloblastoma I'm talking about. And calcifying autoantogenic cyst also, we see a proper cystic cavity with lined by tall columnar cells and stellate reticulum above it, and ghost cells will be seen within the stellate reticulum. Dentinogenic ghost cell tumor is another possibility here, because of all the components which had been described can be seen in dentinogenic ghost cell tumor also, but the ghost cells were only focally seen in this particular case. So putting together all these features, the amyloblastomatous component, then the ductal spaces, the nodules, epithelial nodules, ghost cells, the clear cells, and dentinoid matrix along with tubular dentin formation. The final diagnosis of adenoid ameloblastoma with dentinoid formation was given. Now coming to the discussion part of it, adenoid ameloblastoma is a rare aggressive variant of odontogenic tumor actually, and recently has been termed as a variant of ameloblastoma. It shows unique clinical and histopathological characteristic. Apart from the ameloblastomatous presentation, the ductal areas, the adenoid component, the epithelial walls, core cells, clear cells, and dentinoid has been described as a characteristic feature of this particular tumor. And in our case, we are able to make out all these features in the histologic sections. We did an extensive, following this diagnosis, we did an extensive literature review, and we could identify only 38 cases which matched with the histological description of this particular entity. And out of this case, most of the cases were reported as a variant of unicystic ameloblastoma or variant of COC or variant of AOT, sometimes hybrid tumor, and few cases were reported as adenoid ameloblastoma. And this particular lesion showed a wide age range, and it was the youngest patient was 4 years old and the oldest 82 years. And the common site of involvement was mandible, and the ratio mandible maxilla ratio was 2:1. And the common complaint of the patient was swelling, and sometimes pain and paresthesia has also been observed. Imaging study in most of the cases showed unilocular radiolucency, but a few cases had presented with multilocular radiolucency, and one case specifically manifested as a fibrosis lesion showing mixed radiopaque radiolucent presentation. Gross finding in most of the cases appeared as a cystic lesion. Out of 38 cases, only 21 cases we could get the gross nature of the tumor, and around 17 cases presented as a cystic lesion, and 4 cases presented as a solid lesion. Now coming to the treatment and prognosis, there's no definite guidelines for the management because this entity as such is not very well known among the clinicians and the pathologists. So most of the time when the incisional biopsy is done, it's diagnosed as a unicystic ameloblastoma or AOT, so or ameloblastoma, conventional ameloblastoma, and depending on that, the treatment which has been done also was varied. Most of the treatment modality adopted ranged from simple enucleation to the surgical resection, and recurrence was observed in around 1/4 of the cases reported. Histologically, cellular atypia and high Ki-67 expression had been noted in a few cases, not many cases, less than 4 cases. They have mentioned about the cellular atypia and high Ki-7 expression, and based on which it was suggested to be an aggressive cyst, more aggressive than an ameloblastoma. But in spite of the reported aggressiveness, healing in our case, the present case, was uneventful, and there was no evidence of recurrence during a 3-year follow-up period. This was a classic case of adenoid ameloblastoma with dentinoid formation, which showed all the features of which had been described for adenoid ameloblastoma. And our case presented as a cystic lesion, which involved the anterior mandible, and it was 6th case to be reported at this site. And it's very important that both clinicians and pathologists are aware of this lesion. Otherwise, it might go unrecognized and might be reported as a unicystic ameloblastoma or AOT or variant of any other odontogenic tumor. And documentation of more cases is also required for us to know about the behavior and prognosis of this tumor. Let me conclude by thanking the organizers once again for giving me this wonderful platform. And these are my references. And I also would like to thank my colleagues, Dr. Rakesh, Dr. Vindya, Dr. Tara, Dr. Mridula, and my postgraduate student who had been supporting system throughout the presentation, through the preparation of this presentation. And thank you, everyone, for your patient listening. Thank you. Can I stop?
Oh, thank you, Dr. Mahia, for this very interesting presentation. Are there any questions from the audience? Yes, there's one. Does the WHO head and neck book list adenoid ameloblastoma as a variant?
No, WHO has actually not. We are just waiting for the next WHO revision for this to be added. So far, it's not been added. That's why it's not even if it has been reported, around 30 cases have been reported in literature. In literature, it has been discussed in length. It's not yet recognized officially.
Okay, perfect. Thank you so much for that. Thank you.
Is there any other questions?
So far not, but I can underline that the micro photographs were very beautiful. So
thank you,
very well done. It's always important that the photographs that are presented have a high resolution and are technically perfect. So this is very convenient for every pathologist attending.
Thank you, sir.
Well,
So I think that's a question now. How to differentiate from ghost cell carcinoma? Here, in this particular case, we didn't have any features of atypia. That was one point. And in ghost cell carcinoma, autologous carcinoma, we need to see quite a lot of ghost cells. Here, it was seen only focally. And apart from that, we are able to see other features like the epithelial walls and the ductal pattern. And I believe from the literature, what I understand is that if you see a lot of ductal pattern, you can include it as adenoid ameloblastoma. So have I answered your question? Thank you. Thank you.
Okay, very well then. So if there aren't any more questions, thank you again. And we will continue with the next speaker. This will be Dr. Mevish Makil-Siddiqui. I hope the pronunciation is right. And please, Dr. Mevish, the stage is yours.
Oh, thank you so much. It's an honor to present my research here at this esteemed convention. I'll start by talking a little bit about myself. Can you see me and share my presentation? Is it okay?
Yes, perfect.
Okay. So my name is Mehmet Siddiqui. I did my bachelor's in dental surgery and master's in dental sciences with specialization in oral pathology from Dow University of Health Sciences, Karachi, Pakistan. I'm an oral pathologist with over 9 years experience in healthcare. In Canada, I did my postgraduate training from internationally trained doctors and dentists, which was funded by the government of Canada. In Canada, I applied my research skills in renowned research centers like the Urban Healthcare. Here, I had the opportunity to work with Dr. Flora Matheson and Dr. Andrew Pinto on topics relating to violence and traumatic brain injury. These are my peer-reviewed publications on cancer. The topic I'm presenting today is cell proliferation at tumor tissue interface by the expression of PCNA, Ki67, Vimentin, and Desmin in oral squamous cell carcinoma. This study was conducted in Pakistan. Disclaimer, the views presented are not biased due to funding or related financial affiliations or conflict of interest to disclose. According to Glupacan, the highest incidence of oral malignancies occur in Southeast Asia. The Cancer Registry of Pakistan reports of all the malignancies diagnosed, 9.8% are oral malignancies. Men were afflicted more than women. This is due to the intake of butyl quid, different forms of tobacco, alcohol, and poor diet intake. Oral squamous cell carcinoma ranks 6th in frequency worldwide. The 5-year survival rate of all oral cancer is 62% when diagnosed at an early stage. Lip and oral cavity cancer ranks at number 2, according to the Cancer Registry of Shaukat Khanum Cancer Hospital. In this study, this study focuses on the tumor tissue interface of oral squamous cell carcinoma. Tumor tissue interface represents the front where the neoplastic cells proliferate and replace the normal surrounding tissue. Its significance to surgical point is high as it interprets adequacy. Most active proliferative cells are present at this interface region. In this study, 2 proliferative markers were used. PCNA is the first. This is a protein, significant function in DNA synthesis, repair, and cell proliferation. The cell cycle specific marker is identified in the G1 and S phases of the cell cycle. You can have a look at the high staining of PCNA, which is taken from my study, the slide. Ki67 is detected in the nucleus in all the cell cycles except for the G0. This cellular marker is strictly associated with the cell proliferation present at the invasive front of the tumors. It is absent in non-proliferating cells. In this study, Vimentin and Desmin were used to study the invasive and progression of malignant cells of oral squamous cell carcinoma. Vimentin is classified as a type 3 intermediate filament, which is normally expressed in mesenchymal cells. Vimentin expression is associated with the epithelial mesenchymal transition and loss of cell-to-cell adhesions that take place during cancer invasion. Desmin is also a type 3 intermediate filament. This protein occurs exclusively in muscle. Its presentation in squamous cell indicates that it is acquiring invasive properties. The rationale of the study was to generate a baseline data of tumor invasiveness and progression for comparison with conventional grading system to determine and evaluate the effectiveness by recently developed immunohistochemistry techniques, especially at the tumor tissue interface. The objective of the study was to evaluate proliferation and invasive potential of oral squamous cell carcinoma at the tumor tissue interface with immunohistochemical markers PCNA, Ki67, Vimentin, and Desmin, and to correlate the tumor grade with the expression of markers at the tumor tissue interface for prognosis. The null hypothesis of the study was that there is no association of activity of Ki67, PCNA, Vimentin, and Desmin with higher proliferation of tumor tissue interface in oral squamous cell carcinoma. Methodology. This was a cross-sectional study. Convenient sampling was used. Samples were collected from Dr. Ishrat Alibad Khan Institute of Oral Health Sciences and Civil Hospital ENT Department. The samples were processed and studied at the Dow Diagnostic Research Reference Laboratory. The duration of the study was 1.5 years. Sample selection criteria. Only oral squamous cell carcinoma cases of excisional biopsy with tumor-free resection margin were selected. All the grades of oral squamous cell carcinoma were considered to study. Punched biopsy or incision biopsy for oral squamous cell carcinoma cases were not included in this study. Cases observed with an area of extensive necrosis or non-preserved morphological structures observed on the microscopy were excluded from this research. Lesions other than oral squamous cell carcinoma were also excluded. Sample size estimation. A total of 80 diagnosed cases of oral squamous cell carcinoma in the study was studied with 20 normal oral tissue for comparison. The Ethical Review Board of Dow University of Health Sciences approved this study without any amendments, and a grant of 100,000 rupees was funded to complete the project. Sample processing. Oral squamous cell carcinoma was surgically removed and transported to the laboratory, fixed in 10% buffered formalin. All the specimens were processed according to the laboratory's standard protocol. The slides were prepared following the methods of routine laboratory procedure for H&E staining and for the 4 immunomarker. After preparation of the slides, they were studied under the Olympus microscope, first according to the WHO grading 1, 2, 3. Then the slides were studied again with the Brine's invasive tumor front grading with pattern 1, pattern 2, pattern 3, and pattern 4. The slides were studied once more according to the specific scoring as mentioned here for the immunostains. Statistical analysis of the study was done. Results. Okay, now I'll discuss the results. Distribution of oral squamous cell carcinoma according to WHO grading. There were 34 cases in well-differentiated cases, 36 in moderately differentiated, 10 in poorly differentiated. Distribution of oral squamous cell carcinoma according to the Brine's grading. There were 20 cases in the pattern 1, 24 in pattern 2, 21 in pattern 3, 15 in pattern 4. The highest number of cases occurred between the age group of 41 to 60, which were 36 cases. Males were affected more, especially at the site of the buccal region. The highest number of cases occurred at the buccal mucosa, followed by tongue, floor of the mouth, lips, and alveolus was the least. PCN expression at the tumor tissue interface according to WHO and Bryan's grading. PCN expression was significant with both the grades. Ki67 expression at the tumor tissue interface according to the WHO and Bryan's grading was also significant with a p-value of 0.001. Vimentin expression at tumor tissue interface according to WHO and Bryan's grading was significant with a p-value of 0.001. Desmin expression at the tumor tissue interface according to WHO and Bryan's grading. Desmin expression was also positively correlated with both the grades. Spearman correlation between the markers and grades, PCNA, Ki67, Vimentin, and Desmin were all positively correlated with both the gradings. Spearman correlation with markers, PCNA, showed positive correlation with Ki67, Vimentin, and Desmin. Ki67 showed positive association with Vimentin and Desmin. Vimentin was also positively associated with Desmin. These are photomicrographs taken from my study. The first histological slide, you can observe it as a grade 1. You can observe the keratin pearls clearly. In grade 2, you can see the cancer forming, the dissociation of cells, keratinization decreasing. And in grade 3, you can see it is all tumors. There's no normal tissue. These are slides graded according to the Bryan's grading in my study. So you can observe and appreciate the broad pushing border here in grade 1. In grade 2, you can appreciate the inflating cords, the thick inflating cords in the cancer. In grade 3, you can observe that the cords are thinning. There is increased cellular dissociation. And grade 4 is similar to grade 1 of WHO, which is totally cancerous. This is the control slide for PCNA. You can observe the low staining at the keratin borders and the high staining at the tumor tissue interface here. This is the control slide from my study for immunostain Ki67. You can observe the high and low staining of Ki67 in these slides. This is the control slide for Vimentin. You can observe the staining of Vimentin at the interface region. This is the control slide for Desmin. You can observe the brown staining of Desmin in both the slides. Okay, now the discussion of the study, gender dominance. As discussed in the results, the male was dominant, as described here in other studies. Age, the mean age in the study was 50 years, which was comparable to studies by Liver-Filler. But the study by Rodus et al., their mean age was 62 years, which is slightly advanced in age when compared to this study. Affected oral regions. Current study, the affected sites were buccal region, tongue, and floor of the mouth as discussed in the results. And it is similar to other reports as mentioned here. However, reports by Rodus, the highest affected region was tongue, followed by floor of the mouth. Tumor tissue interface with Bryan and WHO grading. The study revealed that poorly differentiated oral squamous cell carcinoma had Bryan's pattern 3 and 4. Moderately differentiated depicted not only pattern 2, but 3 of the Bryan's grading. And well-differentiated oral squamous cell also resulted with pattern 2 and 1 of the Bryan. Results of the study are agreement with studies by Chang, Doshi, and Serivardi, Dina et al. PCNA, immunoexpression profile of PCNA results in this study as a potential marker to be used to quantify tumor growth objectively. Significant higher nuclear staining observed in oral squamous cell carcinoma with PCNA when compared with normal tissue. Studies by Nabi, Reddy, and Lee et al. Had similar results of higher expression of PCNA in oral squamous cell carcinoma than the normal mucosa. This study expressed more PCNA in oral squamous cell carcinoma as both the gradient increased, similar to studies by Ketu et al. Ki67 is another proliferative immunomarker used in the studies, which stained oral squamous cell carcinoma proliferative cells. In this study, normal oral mucosa showed less intense positivity of Ki-67 when compared with oral squamous cell carcinoma tissue, comparable to studies of Want-to-Be and Ready. This study, the cases of oral squamous cell carcinoma stained with molecules of Ki-67 has the grade increase, which is similar to studies by Tulmuri, Dragomir, and Feratis et al. This study also revealed the staining of Ki-67 PCNA did not stain the nest, but around the edges. Both the proliferative molecules showed significant linear relationship with both the grading systems as assessed in the study, and as the grades increased, the staining intensity of the proportion of the tumor increased, which is the results were consistent with the studies by Daniel and Reddy et al. In this study, the immunoexpression of PCN and Ki-67 were found from moderately differentiated to poorly differentiated oral squamous cell carcinoma in the grade 3 and 4, deep in the stroma at the tumor tissue interface. As these molecules were found infiltrating, suggesting more metastasis potential, like studies by Chong and Shah et al. Vimentin in this study, staining was not observed in the grade 1 or pattern 1 and 2 of oral squamous cell carcinoma. Moderately to poorly differentiated pattern of 3 and 4 oral squamous cell carcinoma indicated staining of Vimentin, which supports it being a culprit in tumor progression and is supported by literature as mentioned. Desmin, previously few studies have been done on expression of Desmin in oral squamous cell carcinoma. This study resulted with Desmin positivity in high grades of cancer. Normal oral comparison mucosa tissues in the study were all Desmin negative. The results are similar to study by Tasai et al. Desmin molecules like Vimentin in the study showed staining in higher grades and patterns of oral squamous cell carcinoma as seen in previous research by Tasai et al. Now I'll discuss the summary. Both the grading system showed statistically significant correlation with PCNA Ki-67 and Vimentin and Desmin in the study. Association of the 4 markers, PCNA Ki-67 had correlation which was positive. Vimentin and Desmin immunostains indicated a strong relation with each other. Ki-67, Vimentin and Desmin showed a significant positive relation in this research. In this study, as the grades and patterns increased, the staining of the markers increased as well. All the 4 markers are easily available in any standard pathology facility and display staining on routine paraffin embedded tissue, requiring no special technique for immunohistochemistry. However, the markers did not confirm any positive statistical correlation with the gender, age, and location of oral squamous cell carcinoma. The strength, the foremost strength of this study was to provide additional current scientific information. A baseline data has been gathered for aggressive potential of oral squamous cell carcinoma in the Pakistani population. Immunohistochemical technique was used to evaluation of proliferative antigens PCNA Ki-67 and invasive proteins Vimentin and Desmin for the future, and in addition for scientific proof. The study of tumor tissue interface of oral squamous cell carcinoma was investigated by a combination of 2 gradings, conventional and with Bryan's tumor front grading. Limitation, due to the time and funding limitation of the study, follow-up of the patient was not possible, and survival of patients could not be recorded for correlation. Detailed history of habits was not incorporated due to prime target on tumor tissue interface. Quantitative analysis was not possible as grid or image analysis was not available at the present setup. Conclusion, I would conclude that immunomarkers, Bryan's grading system along with conventional WHO grading was a convincing approach and reproducible method of interpretation at the tumor tissue interface. Recommendation, all the markers, especially the proliferative markers PCNA, Ki-67 depict the proliferative potential of oral squamous cell carcinoma. Vimentin and Desmin can be used to assess the aggressive potential of the squamous epithelial cells. Additional studies will have to be conducted to validate the utility of these markers in clinical use as prognostic markers or in establishing its use as a diagnostic panel of biomarkers for oral squamous cell carcinoma. Acknowledgement, I would like to thank my university and professors for the support to complete the project. These are the references which were used in the study. And that's it. Thank you.
Well, thank you so much for this enlightening study, very comprehensively presented, and thank you for the nice and pretty histological images.
Thank you so much. Welcome, most welcome.
Are there any questions from the audience? Spontaneous questions. Do you any other predictive markers used routinely for the squamous cell cancer, for example, like PD-L1 in your institution?
Depending on the cancer type, so routinely whatever they use.
Yes, especially in squamous cell cancer, oral squamous cell cancer.
I'm trying to recall, but yeah. Yeah, I don't remember. Yeah, I don't remember at the moment.
Anyway, I'm just asking because sometimes we are using PD-L1 as a predictive marker in selected cases, but we haven't. We are not doing this for a very long time now.
Yeah.
So just for the matter of interest. So maybe any more questions from the audience, but I'm sure if there are additional questions that come to mind, it's always possible to put this in the chat box, and we have some time at the end of the session to answer additional questions just for the just if they come up to mind and are not that spontaneous. So anyway, thank you for your more comprehensive and interesting presentation.
Thank you.
And now we will move on to our next speaker, which will be Dr. Milan Buie from the United States. And she will talk about embracing digital pathology and artificial intelligence, the pathologist's perspective. Welcome, Dr. Buie, and the stage is yours. So we do not hear you. You're something like muted.
Go. All right.
That's good. Thank you.
Hello, everyone. It's truly a pleasure to be sharing information with you today. And my talk is going to be on embracing digital pathology and artificial intelligence from a practicing pathologist perspective. As you know that I'm a professor and a senior member of pathology at Moffitt Cancer Center in Tampa, Florida, in United States of America. I've been practicing pathology for 16 years. I use digital pathology in teaching, research, and also I'm very active in the digital pathology community, such as Digital Pathology Association, and also College of American Pathologists has a digital and computational pathology committee. And also I'm an academic pathologist, so I do 4 things. Number 1 is patient care. So my clinical expertise is bone soft tissue cytopathology. And the second, we teach residence fellows. And also we do research and publication to create new knowledge. And in our spare time, we volunteer to our pathology communities to practice organized medicine to advocate for our profession to benefit patient care. So this is a summary of the things I do, but at the end, my number 1 mission is to leverage everything I do, research, education, and service to provide the best possible patient care. So today we're going to review the potential impact of digital pathology and AI on precision medicine. Maybe we should move this to a different area. Is that better now? And we will discuss the 3 pillars of quality AI. And we highlight some examples of good practice and useful resource, and advocate for collaborative community to advance digital pathology and AI to benefit patient care. A patient's medical journey begins with their diagnosis. As a pathologist, we provide a forecast of diagnosis, prognosis, and therapeutic selection. So in this sense, pathologists are doctor's doctor in a multidisciplinary care team, where the most important doctor that our patients do not typically meet. And this positions us as the natural leader in precision medicine. As you know, pathology is undergoing the third revolution. Our profession was born when microscope was born. So using HE slides, we were able to look under the microscope to examine the tissue at the cellular level to render diagnosis. And our first revolution was immunohistochemistry. With those brown stains, we're able to see the cells at the protein level to study the tissue origin and also a lot of other biomarkers. Our second revolution was based on molecular pathology. On mutation analysis, next-gen sequencing is widely used. So our understanding of disease is at the DNA level. So we provide better and actionable information to our clinicians. Currently, we're experiencing the third revolution, that's digital pathology and AI. So this is marked by the milestone in 2017. The first digital scanner is cleared for primary diagnosis by FDA at US. And in 2018, the artificial intelligence in pathology solution was released. So digital pathology has been in development for many years, but those thumb of approval indicate the general acceptance of this technology. So digital pathology is the foundation of artificial intelligence, or digital pathology gives birth to artificial intelligence. I mean this by the first step of digital pathology is to convert the analog information of the HE slides into a digital form. This digital form can be easily viewed on the computer monitor and shared, managed through the electronic health record, the internet, and whenever there is this connection of digital health. So digital pathology is the most promising field of digital medicine, because not only it's easier for us to share information, now we can finally analyze this data much better. So I borrowed this slide from Dr. Michael Bisich from UPMC. So we all agree that computational pathology using computer algorithms is going to enable digital pathology and the genomics and provide powerful information to science, to our clinical teams to better manage the patients. And I will give you some examples categorically how digital pathology and AI can help and enable us to do better in precision medicine. The first use case is detection. Digital pathology and AI enables looking for rare events, cancer events, metastatic, things like that. The second category is quantification. For example, for Ki67 is a stain used to classify neuroendocrine tumors. Sometimes the cutoff will determine if a tumor is well differentiated or a poorly differentiated, and the treatment and clinical outcome is totally different. Many institutions still use manual scoring of KI, but many studies have shown that quantitative quantification of KI using lockdown algorithm or AI is far superior. other biomarkers like ER, PR, and HER2, they are not just another brown stains. They are predicted and the prognostic markers. So the reliable quantification of the HER2 and ER/PR scores is very important. And we can use AI or algorithms to do the stain counting, which works much better than the manual scoring. And also the third category is tumor classification. So we all know that for many tumors, for example, breast cancer, prostate cancer, there are different types of classifications. As a pathologist, we're really good in classify well-differentiated tumor or poorly differentiated tumor. But for things in the middle, and depend on who you're asking or which day or what mood the pathologist is in, there is variability. But for computer or algorithm, once they're trained, they're going to follow the same algorithm. So there is a lot more reproducibility and accuracy. So those are relatively lower hanging fruit on the spectrum of application. The higher level ones are prognosis and prediction. Because in the era of precision medicine, when we look at a patient, we could compare the patient profile with a population profile to predict with the same type of information how the tumor will prognose and how do we select patient for certain targeted therapy so the patient can do better. So this is a lot of information for pathologists to analyze, use our naked eye. So this is where that AI will really make a big impact. So at the end, DP and AI will improve quality and efficiency of pathology to optimize patient care. So this is the end goal, and we're all going to work together to get there. So here are some published examples of how AI can reduce reduction errors in breast pathology. So this report comes from the National Artificial Intelligence Research and Development Strategic Plan. So this report is showing that the best human will make mistake probably 3.5%. The AI algorithm will be 7.5%. But when you combine them together, the error rate reduced to 0.5%. So this shows the AI can drive the development of a precision in patient care. So that makes pathologists more accurate. So this is an example showing classification and the mutation prediction from non-small cell lung cancer using histology and deep learning. So this application is in classification. Just by non-small cell cancer histology and deep learning, and the algorithm can already predict classification. So this is very powerful. So this is another example using histology and the genomics to predict the cancer outcome. So this is what we talked about, the higher level of uses. So this approach revolves or exceeds the accuracy of highly trained human expert in predicting survival. So this is also powerful. So this is one example from my own institution. I'm a study pathologist for this project. My collaborators, Dr. Gillies and his group, are in radiology. So in this study, we studied the deep learning and the MR images to target hypoxia habits with certain drugs in the preclinical model of sarcoma. So in this study, we concluded that the artificial intelligence analysis of pre-therapeutic MRI images can predict hypoxia and the subsequent response to and this hepatitis. So this approach can be used to monitor therapy response and adapt schedules to forecast the emergency of resistance. So this is a very comprehensive and elegant illustration how digital pathology and the computational image analysis in nephropathology. So this study has 3 steps. The first step is to digitalize all the kidney biopsy images and put them into this discovery of like an arena where the pathomic information is all being incorporated with machine learning. And the end product is the knowledge will be transferred into meaningful output using AI and the visual assessment. And this knowledge will convert into clinically actionable knowledge for patient care. And at this point, the pathomic knowledge will be integrated with the radiomic and the other omic information to provide patient care. So I highly suggest, please review this article published by Dr. Yu Bliss and from University of Michigan. And this one is really showing us an excellent example. How can we combine everything to provide a coordinated patient care? So with this said, what are the valuable AI tools that the pathologists can use? Say, when you come to in the office, don't you wish you already have the AI algorithm running at the background when you were driving to work or when you were sleeping or when you were having dinner with your family? The AI tools already work out things like finding the cancers, counting the mitosis, and pre-screen the slides and tell you which slides you should work up first and to order the immunostate so you can beat the cutoff and increase the turnaround time, or it tells you and then the information are not complete and you need to do certain triage. So when you come to the office, your work list is already organized and you can benefit from all those AI tools. For example, this bug finders, this is showing AI can do those tedious work that we usually don't like to do. For example, find the mycobacteria. And when you come to the office, the AI already find it for you and then make your life much easier. So those are just some of the examples. So this is all sound really wonderful. Then why digital pathology and AI is not taking off as much as what we wish for? So there are certain barriers for AI development implementation. I categorize them into these 4 categories: the regulatory, and financial, technical, and the culture. So for the regulatory barrier removal requires the collaboration of all of us. And the Digital Pathology Association is working on it. For the financial barrier, digital pathology and AI is an upfront investment. So the organization and the pathologists have to realize the benefit from it and willing to invest. The good news is with the advance of technology, now things like internet bandwidth, the computer hardware, software is becoming less expensive. So the financial barrier is going to become less. And also technical barrier. So today we're going to talk about the slide and image quality, and the second is data set quality. And also we're going to talk about the culture. So our pathologists are willing to adopt because some pathologists are still feel a little bit threatened by the technology. So this, we need to really collaborate with pathologists so pathologists can understand AI is coming in as our extender, as our enabler, as our partners. And the AI is not going to replace us. And if we get involved, and we can make sure the AI does what it's intended to do at the end, make our job easier and benefit patient care. So let's talk about the 3 pillars of quality AI: quality slides, images, quality data sets, and the quality pathologist partnership. As a pathologist, we all know the tissue and slide journey is a very long one with many, many steps. So there will be a lot of pre-analytical factor affects the quality of those glass slides. For example, if it's HE stain and we have from the tissue collection into formalin fixation to embedding section and the mounting, there are many steps are involved for the HE slides. And if you need IHC slides, there are even more steps, including more chemicals. So there are a lot of variability can be introduced in this process. So the pre-analytical sources of slide quality is controlled by pathologists and our partner, histotechnologists. So we have to be mindful that if we want to do digital pathology and AI, we cannot just continue our current practice for HE and IHC, and there are some special requirements to make sure the slides to be scanned are of high quality, so AI can actually use this information. This is an example of pre-analytics affects H&E. As you can see, the thickness affects it. So this is a thin one, and this is a thick one. When it is too thick, you can no longer see nuclear features. So that's going to fail the AI algorithm. As pathologists, we all know when we diagnose tissue, we look at multiple things, but the most important is the nuclear features. We want to see the chromatin pattern. We want to see the nuclear membrane. We want to see the nuclear size, right? The second thing is we want to see what's the stroma, what's the cells are producing. So a good HE should have the nuclears are crisp and the purplish, you can see nucleoli. And for the, that's for the hematoxylin stain. And for the HE stain, you want to see 3 tones. The red blood cells is bright red. And you can see fibrin and the collagens, they are showing different color and shape. So this is another pre-analytics affects IHC by thickness. The stain can come from very, very weak positivity to reasonably positive. If this is a prognostic predictive marker, then we'll be in trouble because the cutoff for patient to be put on a very expensive drug or not, probably it's just depend on those slides. So this, we have to really control it so we can have reproducible and reliable reports. So how do we do quality control? Pathologists are very good in doing internal quality control. And another method for us to do this is external quality assessment. This is to measure a laboratory performance comparing to the peers. And this is important for lab quality improvement. And also it's important for your laboratory to be certified by CLIA or the regulatory agency to continue to practice and provide quality care. So the type of EQA, including proficiency testing, rechecking testing, and on-site evaluation, or this is sometimes called inspection. For proficiency testing, and can give a good objective measures of laboratory performance, and can be organized to address most kind of laboratory testing. It's cost effective, can therefore be used very frequently. So I'm sure all the labs are participating in some sort of proficiency testing. And later on, we're going to discuss some of the tests provided by the College of American Pathologists. The retesting, rechecking is also useful. Say if antibody doesn't work as expected, so you want to troubleshoot, you can send that same sample to outside the reference lab. If the reference lab worked, then you can figure out what's wrong with the test in your own laboratory. But it is expensive and should be used considerable staff time because you may have to rework out the antibody and all that. But it's a very important way of doing EQA. So on-site evaluation is the most elaborate. We'll give you a true picture of the laboratory overall performance and offer real-time guidance for improvement as needed. So for CAP, we have every 2 years, there's this CAP on-site inspection, and people come over, look at how the laboratory is functioning, look at all your records, and then talk to the people performing the test. And it's very costly. Basically, the laboratory supervisors and the people working there have to spend time with the people who come for inspection, and the inspectors have to take off from their daily work. So it's very important. At the same time, it's also costly. And the external quality assessment cannot replace the ongoing laboratory quality assurance, quality control programs. So we're going to talk about the College of American Pathologists Quality Improvement Program. This is the HistoQuip program. It has been going on for many years. The laboratory will submit their HE and IHC slides, and there is a group of experts will be reviewing them under the microscope as a centralized location, and then report back to the laboratory, let them know and they're doing a good job or not, and how can they improve their HE and IHC slides quality. So now there is a new arm of this quality improvement, that is the whole slide imaging quality improvement. As a member of the CAP Digital and Computational Pathology Committee, we're involved in developing this program, and then also served as a judge to reading those slides to help the laboratory across the country to improve this. So for this program, we will score the slides, the digital slides, on the histologic preparation and the scanning. So the lab will send their glass slides and the whole slide images to us. So currently we have like 3 people reading one set of slides. One person is using the glass slides microscope as needed. One person is using the computer monitor to reviewing it, looking for things that we can comment on, the laboratory can improve on. And there's another person can help us to visualize and put down the score. If we have discrepancy, can be the arbiter. So it's a collaborative process, but eventually we're going to migrate into AI programs. That's the goal. We're not doing it now, but that is the goal. So we can save a lot of manpower and provide consistent results. So here are the scores. 2 is the full score if there's no deficiency. 1 has some kind of deficiency, but the pathologist can still make diagnosis. 0 is completely failed. Pathologists cannot make diagnosis. Also, there's one that is not showing on this slide. What is the number 1 medical error? That is the clerical error. You label the patients wrong, label the size wrong. So for this, if the laboratory did not submit the correct slides, or they label the slides completely wrong, they will receive a 0 score. They will not get a score. So this process really reflects how the laboratory practice. So these are the score report showing some specifics in whole slide imaging. For example, if there is a excessive problem with gain setting, white balance, and all that. So I'm going to show you some of the examples. So this is not in focus. You can see this tissue has folds, and over here, and the tissue either has a bubble or folds. So this is not in focus. So if you do, so this will affect a pathologist diagnosis. So this is due to histology. And in this case, at low power, it seems like the image is not really, seems to be focused, but if you go to higher magnification, and that the image is not focused. So not focusing is the issue. Incomplete scanning is a big deal. So in this case, the whole slide imaging showing 3 pieces, but if you go to the thumb file of the slides, it's missing a piece. So this is really significant. And in this case, the laboratory will receive 0 score. Just as you can imagine, if the diagnostic tissue is in that little piece, and then pathologists will totally be blindsided. So that's not acceptable because we want to translate the analog data in its completion to the digital data so that they can reproduce the information we're reading from the glass slides. And here, and this is also incomplete scanning, you can see the slides is cut off on the edge. 30 slides. So this slide has lint on the slide. And if it's a human, we can overcome this by focus up and down. But if it's a digital slide, the computer algorithm will get confused. Image artifact, stitching strips, uneven illumination are illustrated here. So for this program, we started in 2019. And so far, there's an increasing number of participating laboratories. We can see the improvement of whole slide imaging is improving comparing at the beginning. And also, we're able to provide feedbacks in a lot more meaningful in the interactive fashion. For example, before the laboratory just receive a report with bubbles, the bubble will correlate with a score. The score will correlate with a big document, explain what that means. For the current methodology, we can annotate what we have and explain. So this is a lot more specific. And also, this gave us the potential to expand to the international laboratories where their country do not allow them to send biological information outside their country. So let's talk about this digital and computational pathology committee that I'm part of it. So this committee is charged to advance the adoption and the digital pathology within the College of American Pathologists, to serve as a respected resource for information and education for pathologists, patients, and the public on practice and science of digital pathology. So our committee has been very busy, and we develop publication materials. For example, the digital pathology resource guide, and there's an individual microscopic resource guide. So those are all free for CAP members. If you log on the website, they're all there available. We also contribute to the review and the recommended changes to the CAP Laboratory Improvement Program checklist. We also contribute to whole slide imaging improvement quality programs, and we also contribute to a lot of educational programs during the CAP. For example, in September is the CAP annual meeting. In the House of Delegates section, the members are very interested in digital pathology and AI. So I will moderate a panel that discuss how practicing pathologists using DPAI in their practice today. So this is hosted by the House of Delegates, and the members of our committee is contributing to the panelists and the discussion. So we're talking about the external quality assurance program. So the CAP conduct those programs. So this is what I said, very comprehensive on-site inspection. So this is the cycle of the program. So you start with sign up, and then you communicate with CAP, and every 2 years there's this inspection. So at the end, this inspection will meet the required standards for CLIA, FDA, or OSHA to ensure that all the participating organizations will exceed the standards to enhance the patient care and safety. So in addition to the external qualification program, the CAP also has a quality center, publish guidelines on different type of practices. For digital pathology, there are 2 relevant guidelines. We talk about ER/PR HER2 are not just the regular IHCs, they are prognostic predictive markers, so subject to higher standards for patient care. And currently, a lot of labs are still using manual scoring for ER/PR HER2. So in order to help the laboratories to use quantitative image analysis to analyze ER/PR and HER2, and the Quality Cancer Center developed this particular guideline. We started from HER2. So I chair that committee, and this guideline already published in 2019. So please take your time to review the guidelines. And if your laboratory is doing HER2 quantitatively, and please find out, and if you're practicing some of the recommended good practices the pathologists are using. So those guidelines are developed by making PubMed search on this topic to find evidence to support certain recommendations. So a group of experts get together to evaluate those references and formulate those recommendations. Then we will ask for general public comments, and then we come back and revise it. So it becomes a collaborative guideline for pathologists. And those guidelines are evolving whenever there's a new evidence and there is new need, those guidelines will be revised. So this is true for another guideline paper, that's the CAP whole slide imaging validation update. So there was a 2013 version published. Now this new version is just published recently. So comparing for the other version, the methodology changed a little bit, and also, but the guideline statements are generally still true. So this is also available on Google PubMed and for general pathologists to use for their practice. As you know that when you purchase a whole slide image system, and it's not intended just to plug and start using, and you have to do this validation to make sure the system as a whole is practiced as it's intended. So this just make sure the pathologist is controlling the process, because at the end, when you sign out digitally, the pathologist is responsible for the quality measurements of all the work that we do. So now we're going to show you how image analysis solution can be used for like a quality control. So Lee Chipata is a histotechnologist. As we mentioned before, histotechnologists are great partners for our pathologists because the quality slides are important. This is an example that I want to give Liz and her group a shout out. They use image analysis as a solution to improve and determine the immunohistochemistry staining reproducibility in their cohort. So we talk about quality slides, quality images. Now we're going to talk about quality data set. For the vendors are trying to validate their AI algorithm, they really need to test it on good data set. So where are the sources of those data sets? The first place to go to is this public data set. For example, the Cancer Genome Atlas is a collaboration between the National Cancer Institute and the National Human Genome Research Institute. So this is a free public data set with a comprehensive multidimensional maps of key genomic changes in 33 types of cancers. And the genomic information is intended to help cancer research community to improve the prevention, diagnosis, and treatment of cancer. So this is an article published. How can we use this public information to do digital pathology and AI? So they're showing multiple examples. For example, you can do multiplex whole slide image analysis, and then you can do image analysis algorithms, for example, to score nuclear stains. It could be Ki67 ERPR, or you can score the IHCs with membrane staining. In this case, it could be HER2. Or you can extract the features, the morphological features, and feed them into algorithm for machine learning. And then you can also use them for prognostics. So there are a lot of applications, and they're showing, to give us an example, how can we combine computational pathologists with the genomic data and the morphological data to provide powerful information. So the second source of data set are the private data set. I'm sure a lot of institutions are curating those information, and especially many of the AI companies are really collaborating with big power academic institutions, because that's where the high quality image, high quality pathologist collaboration are hosted to help them to develop really reliable product. So the private data set, this is an example. So you have probably all heard of a chameleon competition. This is automatic classification of patients with metastatic breast cancer in lymph nodes. Whoever participate this competition will download this data set created by the organizer, and then they can let them their algorithm to run. And this competition proved that the AI is equal or sometimes better than pathologists to detect the metastatic breast cancer. The bottom line is pathologists are very good in what they're doing. If they have unlimited time and go through the tissue, they can be really accurate. But as you know, we have a short of pathologists, we have increased volume of work. So during the 8-hour day, we have to get the work done. So sometimes, and we may not be able to detect a small areas of metastasis. But for the computer algorithm, they don't get tired, right? You send them to the task, They will be just very robustly look for those. And in this case, and AI found this small metastasis and bring this to attention to the study pathologist. The study pathologist, which is a very good one, agreed that it was overlooked. So the collaboration between AI and the pathologist can be really valuable. So this is the third data set. I call it the dream data set. It's come from Europe. So I'm just giving them a shout out because I'm not a speak person for them, but as a Digital Pathology Association, as one of the contributor and the partner for this collaboration, we're very pleased that this big project is taking off. And we're looking forward to hear more about what they're going to do, because many organizations and many countries are thinking about this big database. But I salute to our European colleagues, they get organized, and then this project is taking off. So congratulations, and I'm really looking forward to hear more about this big picture project. The fourth type of data set, it's exemplified by my friend and colleague, Dr. Andrew Brukowski. He is a practicing pathologist like me with interest in AI. So what he did, and he just used his home computer and the commercially available machine learning softwares online and developed this free online data set and use that to do works, for example, classify metastatic adenocarcinoma. So please check out Dr. Brokowski's work. This just shows if you have the interest and you have the determination, you will find a way. You do not have to wait for those fancy algorithms and a huge investment to start to use AI to benefit your own practice. So we talk about the three pillars, has the slides, image, has the data set. But the most important pillar are the pathologists' partnership in the AI development. So what we can do is we are in the front of tissue procurement. In the pre-analytical part, if we don't address all the quality issues, the downstream HE slides, IHC slides are not going to be good for quality patient care. And also as far as data gathering, information generation, and the knowledge creation. So we are all highly trained professionals, and we're able to extract information from the morphological images. Now we have the ability to combine what we know with the digital information, molecular information, and the other informations. So now this is the time that we are going to be enabled to do more than we have ever imagined. So this is very important that we really step up so we can make the pathology data become clinically actionable knowledge. So how are we going to get there? So I joined the Digital Pathology Association around 2010 because I became the scientific director of Analytic Microscopy Core, where digital pathology image analysis is one important tool we provide for the researchers. So I wanted to learn from the peers in this new field and to really grow professionally. So now this organization is 10 years old, but I'm so impressed by this group, has so many talented, dedicated, dynamic, and collaborative members, including the pathologists, the scientists, and also the industry members. So this is the best place that if you want idea to be commercialized, you can connect it with people. And if you have a commercial product, you want to validate it, and you know the pathology members will help you there. So currently, we have more than 2,000 members, and we're here to share the best practices and promote the use of technology among colleagues in order to demonstrate efficiency, and we share knowledge, and at the end, we want to benefit patient care. So once you join the organization, and we welcome you to participate in all the committee activities. And we have many educational activities. The one big one is the annual meeting. So this year is October 17 to 19 in Las Vegas, Nevada. So please join us there. And I also want to give a shout out to another educational program. It's called Digital Anatomic Pathology Academy. So Dr. Raj Singh and we collaborate on this. So this is a web-based whole slide image teaching platform for pathology residents and fellows. So this is DPA's gift to our next generation pathologists, because we realize that when they go to medical school, they learn histology and pathology using whole slide image. When they graduate, they go to American Board of Pathologists to take the board exam, especially during the COVID-19 pandemic. Their glass slides are gone. They're using whole slide imaging to take exams. But during their training, depend on where they're at, many of them do not have exposure of whole slide image. So we want to level the playing field. We want them to be able to read the whole slide image no matter where they're at. So we developed this set, has a different organ systems, and they are whole slide images. The experienced pathologists are the teaching faculty. So here is a demo. Let's see. Let's play. Here we go. So you see it's in different organ system. Each section has a section editor. Those are whole slide imaging system. Whole slide image. This is breast cancer. You have case information, case history. When you click on the features, it will take you to exactly where, almost like there is a teacher right in front of you. And if you want to study some reference, and the reference is linked, and it's also linked to some gross images, radiological images. Also, importantly, if you want to do some differential diagnosis, you can put them side by side. One is a microglandular adenosis on the right, it's completely benign. But here, this tumor, it's a invasive carcinoma. So if you're residents of fellow or medical students, you can join DPA for free, and then you can have access to this wonderful teaching set. And also DPA has a lot of other educational products. For example, we work together to publish concept papers. As you can see, we already published Dissecting the Business Case for Adoption and the Implementation of Digital Pathology. We have quantitative image analysis in soft tissue biomarker use. We have computational pathology definitions, best practices, and recommendations for regulatory guidance. Introduction to digital image analysis in whole slide imaging, and also a practical guide to whole slide imaging. And there are other white papers are in production, and please look out for those very helpful resources for practicing pathologists. I also like to give a shout out to this master class in pathology presented by past presenter. Dr. Raj Singh is a DPA member, and is also a friend who is the inventor of this platform. So this class is starting in August 13 to 15, and you can log on to this website and the registration is completely free. And you can see there are 45 experts from all over the world coming from different backgrounds, presenting lectures on different topics. And my topic is bone tumor pathology. So really welcome you to take advantage of this platform. My understanding is even the lecture is scheduled during this day. After that, you can still access those information. So please join us. All right. So in the past 50 some minutes, we talk about the digital pathology and artificial intelligence are here to stay and will continuously transform the delivery of precision medicine. DPAI will impact on improving the quality and the efficiency of patient care in pathology. Applications include, but not limited to, identification, quantification, classification, prognosis, and prediction. We also discussed the 3 pillars of quantitative DP and AI, include the quality of slide, images, data set, and pathologist involvement. The external quality assessment measures the laboratory performance and is important for quality improvement in pathology. DP and AI too can be useful to enhance EQA to standardize laboratory improvement. We also talk about there are various data sets, including the public, the private, the free online, and the very exciting, the big picture project. The quality of the data determines the quality of the AI development. The quality check for research data set should also be standardized. And we also talk about pathologists are critical partners in AI development and implementation. Collaboration of scientists, pathologists, and industry are the best strategy to advance this field. Digital Pathology Association and the College of American Pathologists are leaders in education, quality improvement, and the professional development of pathologists and AI. But most importantly, each one of us can choose to make a difference. We can choose to be the catalyst for change. We can choose to be the facilitator for collaboration. So with that said, I'm going to acknowledge my home institution, Moffitt Cancer Center, especially the manager of Analytic Microscopy Core, Joe Johnson, who is a scientist and a partner in digital pathology. And I want to thank my community in DPAI, which is Digital Pathology Association, College of American Pathologists, Digital and Computational Pathologists Committee. And one of the person who is a CAP staff is Kevin. Give Kevin a shout out. And I also want to thank Leeds, who is a member of the CAP National Society for Histology, Histotechnology Committee. Some of those beautiful pictures of whole slide imaging artifacts or defects are taken by Leeds. And also I'd like to thank the Association of Pathology Informatics and the Journal of Pathology Informatics. And also there are some industry teams. I'm their scientific advisor. So this way I'm able to try out some of the really cool tools and also give my insight and on some of the development. And also I like to thank Dr. Eric Glassy and Mark Lloyd and help me with some of the slides animation. So with that said, thank you very much for your attention, and I'm open to questions. And also at your leisure, please check out some of those books that I published, especially this Healing Art of Pathologists. So this book by itself is going to be another 1 hour conversation. There are a lot of information on this. Maybe some other time I will tell you about it. So the bottom line is the patient's courage to overcome their disease is inspiring me every single day. I'm very privileged to be able to do the job, and I'm very privileged now digital pathology is going to help me to do a better job. And then also I thank you to give me the opportunity to share this information with you, and especially to celebrate my birthday today. Thank you.
So, well, Dr. Buie, thank you so much for this very comprehensive and state-of-the-art lecture about artificial intelligence and digital pathology. And of course, happy birthday from us all. So I think there will be a couple of questions. So you may are able to read the chat box, and I think we go through the questions one after another.
Okay, so let's go to the very beginning. All right, let's see, from Professor Tariq Ali. Sorry, doctor of the doctors in clinical medicine. His nomination first given many years ago to be role of intern, being the master and the diagnostic way challenge. Note that. Okay, it's a comment. Professor Tariq, understanding the genetic basis of the disease in every individual case is mandatory in proper diagnosis, and tailor the proper management as being pathological oriented rather than symptom oriented, expecting that how will the role of digital pathology communicate with the clinicians in this issue. Well, how can pathologists? Well, there are two folds. One is used to be our communication is by email, or now we have Zoom. But with the digital pathology, with the Zoom, you can actually share what you see and correlate with data, right? Before you explain to them, this is stain, that data doesn't make sense, but now you can make it visual. So most of the clinicians will appreciate that. And also before there are certain analyses are manually, you can tell people this is your score, but when you move the slides off the microscope, all that information is gone. But now you can show quantitative image analysis data, and it's very impressive. Where's the cells and what's the percentage? So that's a lot more accurate, and it's more data-based information. And also, additionally, digital pathology, when you use computational pathology, when you combine all the other data, we can see information beyond a human eye will be able to recognize. For example, when you look at certain tumor, and you can only say this is a high-grade tumor, but when you analyze that data with all the other information that is available, and there will be a predictive and prognostic data. And this is not a dream, this is a reality. I recently communicated with a company who is doing just that, to provide actionable information to the clinicians, where the pathologists can really explain to them, this tumor will dictate this patient has that outcome. So I hope that answers the question. And this is from Professor Tariq again. In what field the discipline of clinical medicine, digital pathology, help the practicing clinician in everyday practice? Well, for example, for pathology, we talk about the image a lot, but most of our information is related by report. So the natural language search is always challenging, because the clinician have hard time to go through our report to understand what is really going on. So in our institution, our AI officer employed this project to use AI to sort out the report, to accurately label the report, have certain features in it, has really, really high accuracy. And also we have this project called sepsis sniffing project. That means using the clinical information, the patient temperature, medicine history, and their image data to sniff out the patient who are predisposed that is going to develop sepsis in the near future. As you say, patient sepsis is one of the main reasons for them to be hospitalized, and then they will die. So now if you can predict who is susceptible to sepsis and prevent it, that save lives. And there are a lot of other examples like that. And also if you have pathology, say there's some really infectious issues. For pathologists, we have those reportable events, right? If you have a colon biopsy, just say a bladder biopsy, but then you see colonic material indicating the perforation of the bladder, what are you going to do? That's a medical emergency. You're going to pick up the phone and call the clinician. But the biopsy was done 3 p.m. in the afternoon. After the processor, it's stained in the evening. If you have an AI algorithm, discover that, alert you, and then you can talk to the clinician, so that will save lives. So now we can see the image of a professor. So then I hope I answered that question. So thank you so much.
Happy birthday, Dr. Marilyn. Happy birthday
Thank
to you.
you.
First of all,
thank you.
And thank you so much for your comprehensive presentation. It was very fantastic and useful. And
thank you.
My appreciation to you. I wanted just to, in short, I wanted to ask you about how can the pathologist, I'm a clinician, not a pathologist. I'm a professor of internal medicine and metabolic and endocrine disease. How can the clinician, as we are sitting in the clinic, and I want to fill the gap between the laboratory and the clinic, between research and real world practice. My question lies in this gap. I want to fill the gap between us. And I always focus on the important communication, the importance of communication and coordination between the different medical disciplines, between the internist, for example, or the endocrinologist, or whatever, the clinician sitting in his room, and the other specialists, the pathologist, the clinical pathologist, etc., etc., etc. So how can we quickly catch up in this issue so that you can help me in my clinical decision, which I should take the proper clinical decision in the proper time in order to give the patient the best medical care and the best management, especially that we all know that in, for example, in cancer, I asked about in which disciplines of medicine we apply digital medicine and artificial intelligence. A very broad, I know it's a very broad, difficult and complicated question. But what I want to say, for example, in malignancy or in cancer patients, we all know that by what we call the biologic behavior of the tumor and the natural history, it is too much different between the different categories. And I had a lecture last year about the neuroendocrine tumors and paraneoplastic syndromes. Although it is a rare medical issue, but it is one of the most complicated that shows that what we don't know is much more than what we know.
Right.
How can we feel this thing and we expect and take the proper decision in the proper time? How can the pathologist in the modern era help in this issue?
Right. So step number one is we get out of our office, we get up behind, because pathologists in most people's mind, we're behind our microscope, we're behind our closed doors. So digital pathology allow us to get out of it. For example, in Moffitt Cancer Center, we have this multidisciplinary team. For example, when I'm a bone soft tissue pathologist, even I report to my chair in pathology, I am also a member of the sarcoma team. So we work collaboratively. Say every week, there is a multidisciplinary tumor board. So in that tumor board, I will show them, say, there is this tumor, and I will say margin is positive. They will say, show me. So I can show them the digital images, and then they know, oh, we're cutting through the tumor. And in the other case, they're sitting on some deep tissue, there's no place to go. So they can really gauge what that is. And in some other tumor, and I will tell them, this, for example, in your neuroendocrine, so that will be just say patient has cancer, and the papillary carcinoma is straightforward, but there are a lot of those flaws or this and that. Then we can discuss what's the histology, because after you look at the histology many times, and you have a sense of one is going to be challenging. Pathologists really don't know exactly morphologically. So we rely on the ancillary testing and how do you interpret certain testing, because some of them is rule in and rule out malignancy. Some of them is an arbiter of it is or it is not. So this technology allow us to be on the same page to discuss it. And also by collaborating, because for us, we're not just a hospital, we have a large research institute. As a PhD, I'm also collaborate with some of the researchers. When they find things in the laboratory and they want to validate on tissue, where I will come in and I will tell them, this one makes sense, this one doesn't make sense. There's this one example they showed me something. They said, oh, we're hitting a wall. The experiment totally failed. I look at it from a pathologist perspective. I said, no, this is an interesting finding. I didn't even remember I said that, but they followed that lead, eventually become a really high impact factor publication and novel finding. So when they discover that, then that information will go to our clinical team. The clinical team said, let's design clinical trials and then work to measure if the patient is benefited from this. And then it come back to pathologists again, because I'm going to evaluate the tissue to see if there's responses. So pathologists, it's in the information communication, we're actually in the center. Everything is filtered through us. And because pathologists by nature, we process a lot of information and data, and then we can feed you what you need, almost like your co-pilot. We give you the morphological information, we give you the biomedical information, and then when you have clinical information you want us to make sense of it, we can help you that too. So that's the type of collaboration that the patient can really benefit, and digital pathology can enable that. Because now everything we have is no longer a black box. I can show you on my scope right behind me by this digital communication exactly what's going on with the patient. Thank you
so much, Dr. Malik. Thank you so much. But this might be applicable to the United States, but in our region, for example, in the MENA region, the Middle East and North Africa, it is rather difficult because to apply the issue of multidisciplinary communication and coordination among the concept of clinical management in a busy environment, in a busy clinic, it needs a lot of work actually to do it and to make it into practice, to put it into practice rather than being just words by the research.
I suggest to start small as a collaborative group. When people get benefit from it, it will organically grow. For example, I have a small group of pathologists. Every week we meet via Zoom to discuss our challenging cases. And people from all over the country, some people from other country, they found out the information, they also join. There's one person, when we meet at 5 o'clock in the afternoon, it's her time, 5 o'clock in the morning. She gets up at 4:30 every week just to join, because whenever people benefit from it, and they will organically amplify this. So start, and also maybe we can communicate and find you people that share the same interest. And so this where if it's a face-to-face meeting, and I probably will recognize who are in my communication network, who are in yours, and what's the overlapping, and then we all become friends, we can start. So this digital format does certain things serve as introduction, but for fostering collaboration, we really need to meet face to face.
Yeah, thank you so much. Dr.
Thank you.
Maile. Thank you.
Okay. All right. So I hope I'm not taking the time from the next speaker.
Oh, well, I think no worries. We are quite well in time. So thank you again, Dr. Buell, for this very comprehensive and fantastic presentation and the lively interactive discussion. So now I will call to our next virtually speaker, because unfortunately Dr. McKee is not here in person, but we have a recording of his presentation, and I will share my screen right now. So this is it. And now I'm gonna start this. It gives me great pleasure. So again, so this is Dr. Philip McKee, and he will talk about the enigmatic Spitz nevus.
Emirates Pathology and Digital Pathology Conference. I'm just going to put it into there we are. My topic is the enigmatic Spitz nevus, and Spitz nevi have always seemed to have been a problem ever since Sophie Spitz described them in 1948. And one of the things I've noticed over the years in the literature is almost all papers start with this statement: Spitz lesions are a source of great diagnostic difficulty, which to me is an almost self-fulfilling prophecy. It means that a less experienced dermatopathologist, when faced with a spitzoid lesion, will automatically think, oh gosh, this is going to be difficult. And of course, that's not bodies. Now, I've subtitled my talk The Good, the Bad, and the Ugly, and that refers to the malignant dens, and I'll come back to them later. I just want to acknowledge that this presentation wouldn't have been possible had it not been for the help of so many friends. And I just wanted to give you my financial disclosure of royalties from Elsevier and Walter's Kluwer. Now, this slide, I think, helps to encapsulate the problems we face with Spitz lesions. The first point we need to remember is that the term Spitz tumor includes a variety of different entities, including Spitz nevus, atypical Spitz nevus, Spitz melanoma, and spitzoid melanoma, and I'll come back to those later as we progress. And one of the things that I've learned over the years, I used to believe firmly that morphology was the be-all and end-all, but when it comes to Spitz nevi, when you make a diagnosis based purely on morphology, you can get into trouble, and I'll come back to that. And of course, the more experience you have, the better you will get, but even then, there can be problems. And lastly, the concept of the atypical Spitz nevus or the atypical Spitz tumor, this arose as a direct consequence on morphology-based diagnoses. I think one of the biggest problems in the Spitz nevus story is the atypical Spitz nevus. So one of the things that I had to change my mind about is the importance of immunohistochemistry. It really is very, very useful in any tumors where there's diagnostic difficulty. That's not to say that every Spitz nevus needs immunohistochemistry, but sometimes they do. And as I'm dealing with an international audience, if you don't have this available at a local level, I would suggest perhaps you can get a regional laboratory to sort this problem out. And the same thing applies to FISH, ACGH, and next generation sequencing. In the really difficult cases, you may well need these tests. And that can probably be set up on a regional basis, or sometimes even a consultation will do it for you free. One of the most interesting aspects of the Spitz-Nevis story is the fact that Spitz-Nevi may be associated with sentinel node positivity, and this may not mean anything very much. So the old idea that if a Spitz-Nevis spread to the local lymph node meant it was a melanoma with all the grave consequences of that is in fact not true. And lastly, even with the best of technologies, immunohistochemistry and other molecular techniques, the tumors don't always do what they're supposed to do. So homozygous deletion or loss of 9p21 can sometimes be associated with a good rather than a bad prognosis. So this is just to remind you again, Spitz tumor includes Spitz-Nevis, atypical Spitz-Nevis, and both Spitz melanoma and Spitzoid melanoma. And I'll come back to the difference between these two later. This is a bit of a reality check. It's just to remind you that Spitz-Nevi are very rare. In 1977, David Whedon did a study and it showed there were 1.4 cases per 100,000 person years. And so that means that for an average dermatopathologist not working in a consultation practice, it's unlikely that he's going to see more than 4 or 5 a year. And of those 4 or 5, most years they're all going to be utterly benign and non-problematical. It's a disease it's a tumor, a lesion that we see mostly in children, but it in fact can present at many ages, going right up to the 50s and 60s, which is something that I never used to believe. And sometimes you get multiple lesions, either grouped or they can even be eruptive. And this perfect clinical, which is a typical Spitz-Nevis, was shared with me by Antonina Kalmakova. And histologically, Spitz-Nevi, they mostly can be recognized as scanning magnification. And this is a perfect example here. And you look down at this at low power and you can see the lesion is circumscribed, you can see it's symmetrical, you can see its wedge-shaped morphology. And so when you start, and this is say from a young person, this is a Spitz-Nevis, unless you really prove beyond all reasonable doubt that it's a melanoma. So with children in particular, start off with the concept that the lesion is benign and only call it melanoma after you've fulfilled many criteria. And I brought this list on the left, which you can find in any textbook, and I'm not going to spend much time on it, other than to say, none of these are absolutes. So communobodies may be present or they may not be present. Maturation with depth is generally present, but sometimes it's not so good. It's not so obvious. So it's the sum total of all of these features that make it a lesion of Spitz-Nevis rather than any one particular one. And this is a lovely case. It's actually an alcoma that Antonina shared with me. And it's showing perfect symmetry. It's also showing maturation with depth. If you fold the left over to the right, they match perfectly. The other way of looking at it is by drawing horizontal lines and comparing the size of the nests and the cells on the left with the right. And as you work down, you can see that they are mirror images. And this also is a good way of assessing maturation, where you can see smaller nests and single cells at the base. So when you look at that low power magnification of that particular lesion, you can say that's a Spitz-Nevis without looking at it any further. And here's another Spitz-Nevis, and this is an example of an epithelioid Spitz. And when we look at it a bit closer, you can see the epithelioid cells with large vesicular nuclei, prominent nuclei, and there's a mitosis, which is a common feature, particularly in children. And that's the basic lesion. If you compare the cell size at the top and the bottom, you can see this clear maturation. And in this field, it's heavy pigmented, because sometimes spitz nevi are very pigmented. And this is an example of a spindle cell spitz nevus, again shared by Antonina. And in this example, most of the nests are composed of spindle cells. And this example shows very nicely the retraction artifact and discohesive cell population that we expect to see in a spitz nevus. And I put this one in. This is a reed nevus, and Ehar from Moscow kindly shared it with me. And I think this overlaps a lot with pigmented spitz nevi, and I don't really distinguish them particularly. It doesn't really serve any great purpose. Now, as I mentioned, most spitz nevi you can recognize on H&E, and you can be pretty confident about it. But sometimes we do have problems. And so we do have a battery of immunohistochemistry that we can use in the spitz tumors. And you'll all be familiar with these ones. I've included BAP1 largely because in the literature, papilloma is included often in publications on spitz tumors, even though it doesn't really belong there at all. And I've also mentioned MAP kinase immunohistochemistry, which I'll get back to. And this is a lovely example of a spitz nevus showing preservation of P16 as you would expect in a spitz nevus. And this is a lovely picture. This is in the old days, I used to use S100 very frequently because it outlines the cell nest size. And so you can see the nest getting smaller as you go down towards the bottom, and it shows you the single cells. And it's often easier to appreciate with S100. And this is another case where I'm going to show you some immunohistochemistry. This is just a regular spitz nevus. You can see that on low power magnification. It doesn't really show any features of concern. There's the top of the lesion. Just to remind you, you can get transepidermal elimination of nests in spitz nevi, and it doesn't mean anything. But there's the top. And there's the bottom, and you can see there's clear maturation with depth. So on H&E, it's a spitz nevus. But Antonina kindly did the immunohistochemistry, and there's P16 at low power examination, and there's P16 at high power magnification, showing that it's present from the top to the bottom, which is what we expect to see in a benign lesion. HMB45 is not expressed by the nevus at all, and Key67, there are 1 or 2 nuclei, but that's the height of it. Now, we've progressed enormously over the last couple of decades with a much better understanding of the molecular basis of spitz nevus and other spitz tumors. And all spitz lesions are characterized by MAP kinase activating mutations in about 50% of cases. 40% of cases, the mutations are unknown, and the rest are a mixture of this, that, and the other. But very often with the spitz nevus, if you look for a particular MAP kinase mutation, you will pick up perhaps BRAF, perhaps MAP3K8, and then the receptor tyrosine kinase, including ALK, ROS, RET, and so on. And I'll show you examples of all of these as we go along. And this is this slide. I put this in just really to show you how beautiful Antonina's ALComa is, that this is ALK1 expression, and it's very pretty, and it shows the typical growth pattern. Serine threonine kinases account for 5% of Spitz nevi, and of the receptor kinase fusions, ROS, ALK, and NTRK1 account for the most frequently encountered variants. So I'm going to spend a little time looking at some of these receptor tyrosine kinase tumors, and this is typical ALK rearranged Spitzoid tumor, but actually this could easily just be a Spitz nevus. It's important to remember that you may see this in the Spitz nevus, you will see it in the atypical Spitz nevus, and you will see it in Spitz melanoma. So it's not giving you an idea of the biological behavior. And ALComas may be seen in a wide age range, and they typically present as dome-shaped nodules on an extremity, and they're composed of fusiform nests which extend from the top, gradually getting smaller as you go down towards the base of the lesion. And they typically show this plexiform growth pattern. Most ALK rearranged Spitzoid tumors look pretty bland, but occasionally they can be pleomorphic. And a significant number will show sentinel node involvement, which is not going to tell you anything. And in fact, I think sentinel node lymph node biopsy is not really a great idea for Spitz lesions. And this is the ALComa that Antonina shared with me. And you can see the particular growth pattern. You can see maturation with depth in the middle. And if you look a bit closer, you can see some junctional activity at the top. And there's, in that intermediate magnification, you can see the nest size is getting smaller. And at the base of the lesion, you can see single cells. So everything on that histology says it's benign. But, you know, you should expect to see mitoses in Spitz nevi, particularly in young patients. And so finding a mitosis or two doesn't necessarily change the diagnosis. And obviously, you may well see a little bit of pleomorphism. Not very marked, but you expect to see it. And again, it doesn't change the diagnosis. And there's the ALK again in that tumor. NTRK1 Spitz tumor, this is something I haven't seen so many of, and this example was kindly shared with me by Matthias Bobos from Thessaloniki in Greece. And they're described as showing a filigree-like ridges with elongation, thinning, and branching. And I don't think that fits very well, but that's just an example that I do have. And they are spindled, and I think, to be honest with you, they're not that dissimilar from the ALComa. And there's another view there showing you the extent of the lesion. Here you can see the spindle cell population. And then if we look at the next one, you can see the spindle cells at the top. And there's the base of the lesion there. And you may well find mitoses. The ALComa and NTRK1 lesions remind me of the malignant Spitz nevus that Kathleen Smith described in 1986. And there you see, there's a mitosis there. And I think there were several mitoses in the tumor. And this is NTRK1 expression. Now, ROS fusion, I included this case from Thomas Weisner's paper. And if you haven't read this, I recommend it all to you. It's a super paper and really gets you up to speed on the receptor tyrosine kinase story in Spitz tumors. And ROS1 fusion lesions show typical Spitz morphology, as you see in this example. And here's another one that Professor Nina Ardakani from Australia shared with me. And again, it's a spindle cell Spitz. There's nothing very problematical about it. Now, where the trouble starts, to my mind, is when we got the atypical Spitz tumor introduced, because it's not that I think that every Spitz lesion can be categorized easily every time into nevus versus melanoma. I think that at least 95% of cases you can, but then you do have cases where there's a little bit of uncertainty, and I suppose this is where the atypical Spitz tumor comes in. But the problem is it doesn't have a precise definition. The Spitz nevus overlaps with the atypical Spitz tumor, and as you'll see, the atypical Spitz nevus overlaps with Spitz melanoma. So there are no strict definitions which enable you to say, this is Spitz, atypical Spitz, except perhaps at a molecular level and with immunohistochemistry. If you see a lot of Ki67 expression, that's reasonable good grounds to shove you into this category. And similarly, if you see 9p21 mutations, that's probably a good reason to go into this category. But as for the rest, it's very, very variable. And you know, for example, symmetry, Spitz nevus symmetrical, atypical Spitz may be symmetrical or it may be asymmetrical, and so on and so forth. Nothing's terribly clear. And this is a lesion that was diagnosed as an atypical Spitz tumor. And I can't tell you for definite what it is. Personally, I would have called it a Spitz melanoma, but it is a matter of opinion, I suppose. This is a big lesion. It's 9 millimeters and it's ulcerated. So the size of the ulceration to me are telling me, gosh, this is melanoma. And when you look at this lesion, you can see that it's a really dense infiltrate that doesn't, you know, the cell size doesn't seem to be diminishing with depth. Everything down here looks the same as everything up there. So I'm not very madly keen on maturation. But then when we look at it at higher power, you can see the top where it's got nice retraction artifact, disc cohesion. So it's very Spitz looking. And this field gives you a suggestion, maybe there's certainly diminution in nest size when you go towards the base. And, it looks as if there may be some diminution in cell size. So maybe the higher power images favor that there is maturation. But then when we look at it at high power, this is the base of the lesion, and there's a mitosis right at the, well, virtually at the base. This is the middle of the lesion with a mitosis. There's another one in the middle of the lesion. There's another one in the middle of the lesion. So ulceration, very large, superficial and deep mitoses, mitosis out there almost at the base. And then we look at the immunohistochemistry. P16 is preserved. Ki67, well, I haven't estimated, but it is pretty strikingly positive. HMB45 is retained throughout. And PHH3, about which I have little experience, doesn't seem to be showing up very much. I personally think this is melanoma, but it was diagnosed as an atypical Spitz tumor. And I suppose at the end of the day, even a Spitz melanoma is unlikely to do the patient any great harm in the overwhelming majority of cases. So to some extent, it's a bit academic. And here's a case that Matthias shared with me. It's a lovely case. This is an alcoma, and it shows a fairly large 0.7 centimeter diameter lesion, but it looks somewhat symmetrical and circumscribed, and there's the base of the lesion there. So at low power, it's suggesting benign, and at higher magnifications, it's still, to my mind, suggesting benign. It looks as if it's maturing. There's the discohesive population, there's the retraction artifact. There are the Camino bodies shown in higher power. So at the moment, if you're thinking, great, this looks like a benign Spitz nevus, we look at it a bit more closely. There's the base of the lesion. And here we see a mitotic figure there. And we're beginning to pick up something that's very concerning, extensive lymphovascular invasion. I don't really think I can call lymphovascular invasion a Spitz nevus. To my mind, I put this into the Spitz melanoma category. But then we look at P16, it's preserved, and here's ALK showing strong expression throughout. And there's the intravascular component there showing expression. This patient had a sentinel node biopsy, and there's quite extensive involvement both within the body of the lymph node and in the subcapsular region. So I'd be inclined to regard that as a Spitz melanoma. And there's Mark 1 with key 67. And then we get to Spitz and Spitzoid melanoma. Now, in a moment, I'll discuss the difference between these two. And I'm not going to spend time on this. It's in the books. You can all read it for yourselves. The only thing I would say is that here the molecular studies can be very useful because they can push you towards melanoma to my mind, in a much more confident sense than with the histology. Except, and again, immunohistochemistry, key 67 is very useful. If there's a lot of key 67, greater than 20%, well, then you better start getting worried. I rather like this is the sort of diagnosis that I like to come up with. A Spitz or Spitzoid melanoma is a melanoma that you called a Spitz and wish you hadn't because it metastasized and you know, there are terrible consequences for the patient. And it can be divided on histology into a melanoma which shows vague Spitzoid features but is clearly malignant, or it can be a Spitzoid lesion with additional features that suggest melanoma, but it still looks like more like a Spitz nevus. And I got this image here from Antonina showing you a Spitz melanoma with, there were 17 mitoses in that one section. Now we do need a reality check. Melanoma in children, and this is from the 2017 article, melanoma in children, 1.1 per million in the 1 to 4 year old age group, and 10.4 per million in the 15 to 19 year age group. So it's extremely rare, and that's I couldn't stress that more strongly. It's an extremely rare tumor in children. And those that do occur, some of these will represent melanoma arising in the giant congenital nevus in patients with, say, xeroderma pigmentosum or some other inherited predisposition syndrome. And some of them will be actually will be misdiagnosed proliferative nodules. And here we're going to get to the good, the bad, and the ugly that I mentioned in my starting slide. And this is summarized from a wonderful paper by Raghavan et al. And most of the melanoma authorities were co-authors on this paper. And if you haven't read this one, you jolly well ought to. And basically, the thesis of the paper is that you can divide malignant Spitz lesions into 3 categories. The first one is the good lesion. It's a Spitz melanoma with MAP kinase activating mutations, but low TERP promoter mutations, few pathogenetic mutations. So this is a lesion that looks like a Spitz nevus. Its immunohistochemistry looks like a Spitz nevus, but it histologically shows features that you can't avoid, and so it becomes a Spitz melanoma. And then the second category, these are the bad lesions. And these are Spitzoid melanomas with non-Spitzoid MAP kinase activating mutations. So it's the exact opposite of type 1. And these tend to occur in older patients with high cumulative sun damage and lots of somatic mutations, and the prognosis is bad. And then we have the third category, the ugly category. And these are tumors which look histologically ugly, but they don't show MAP kinase mutations. They occur in younger people. Again, they have low TERP promoter mutations and few pathogenic mutations. So in an ideal world where you have all the molecular technology to hand, you can perform all of these studies and you can classify the malignant Spitz lesion into type 1, the good, type 2, the bad, or type 3, the ugly. And I'll show you a few. And this is a case that Ari very kindly shared with me. This is an NTRK1 Spitz melanoma. And on the right with the histology, you can see, you sort of get the sense that there may be some maturation, but still the bottom of the lesion, the nests are pretty big, and it's clearly ulcerated along an extensive part. So it's not starting off very well. And when we look at it at higher magnification, there's the top of the lesion with the ulceration. This is the bottom. There, and here we're coming down to the bottom, and there's a mitosis there. So there's a mitosis right deep down. And there is some nuclear pleomorphism, more so than you'd really want to see in a Spitz nevus. And when we look closely, there are multiple mitoses, including atypical forms. There's 1, there's 2, there's 3, and I think, and there's a 4th one there I forgot to arrow. So that's one high power field with 4 mitotic figures and significant nuclear pleomorphism, enough to call this a melanoma. And this is Antonina's patient, and this child developed lymph node metastases sometime after the diagnosis of Spitz melanoma was made. And again, it's an ulcerated lesion. And at the top, we can see some residual junctional nests. And there's the surface epithelium there. And here we can see 3 of those mitoses as one works one's way down the tumor. And there's the base of the lesion, you see, and there are large nests coming down towards, there's a large nest there. So although you might think, oh, it's splitting up into cells at the base, that's really a sort of a false impression, because there are 2 big nests there. So it's not really maturing. And there are all the mitoses. And there's a close-up view just showing you the mitoses to better advantage. And this is P16, which was entirely lost throughout the tumor. So that was a a P16 or 9p21 homozygous deletion that resulted in lymph node metastases. I don't have any follow-up information. And then we've got this case, which is another 9p21 homozygous deletion, very kindly shared by John Ho from the University of Pittsburgh. And this is the low power view. And again, when you look at the middle of it, you sort of get the feeling that it looks as if it is maturing. The cell nests and cell size, you might think they're getting smaller. But here we are, this is sort of the middle of the lesion. And I would caution you, when you're looking at a spitzoid lesion and you get nests like these are expansile nests, and they're pressing against each other. Always view that with great concern. I really don't like expansile nests. And there's some other views, and they're showing you, just showing you the junctional activity at the top. And there's a medium part of the top, and there's the bottom. And if you compare the top to the bottom cell size, you see there's no difference at all. It's not maturing in terms of cell size. And there are mitoses, superficial mitoses, another one there. There's a deep one, there's the deep margin there, and there's another one there. And here we see melanoma with key 67. Key 67 are the red nuclear dots, and they're pretty conspicuous once you get your eye in. So that's a Spitz melanoma. And this patient also had regional lymph node metastases. This is an example of spitzoid melanoma that I picked up from Reichhaven's series because I don't have the molecular data of one of my own. But again, it looks very spitzoid, but the size of the cell nests alone are very disturbing. And there you can see loads of mitotic figures. So it would worry you, but this in fact did not have ALK or didn't have MAP kinase mutations, and so it fits into the bad category. And then lastly, this is a case that Wayne Grayson from Johannesburg shared with me, and I've forgotten the size. It was 7 or 8 centimeters or millimeters in diameter. At low power, it looks as if it's maturing, but the thing you can see here is it's not symmetrical. If you compare the population on the right with that on the left, they're totally different. This is a sort of a spindly population maturing. Here we've got this focus of epithelioid cells which are not maturing. So that makes you sit up and think. And there we have a closer view. Compare the left and the right, and it's asymmetrical. And this is coming down towards the base of the lesion, and you can see there's no maturation towards the base. And here are some mitotic figures. This lesion was teeming with them, but I highlighted 4 for you. And the tumor also showed lymphovascular invasion, very extensive. And so again, one was left with no doubt in my mind that this was melanoma. And this is the S100 protein. And it's quite good because it highlights the difference between the 2 cell populations. And this is HMB45 showing that there's no loss of HMB45 expression with depth. And this one just shows CD31 highlighting the intravascular component, and their cyclin D1 indicating expression throughout the entire depth of the lesion. So I hope this talk has given you some thought. It's given you some references that you really need to read. And I want to remind you, and really, that don't be frightened with Spitz nevi. Most Spitz nevi, that's all they are. And don't focus at high power on one particular feature. And let's say you find a deep mitosis. Don't let that lead you off the garden path. It's the aggregator features that will give you a diagnosis. And in difficult cases, immunohistochemistry, molecular studies, and don't forget to show the slide to a colleague or send it off for consultation. And lastly, don't shove everything into atypical spitz nevus just because you can't make up your mind. It doesn't do the patient any good. So thank you very much for your time, and that's all I have to say.
So thank you, Dr. McKee, for this very comprehensive lecture about the spitz nevus. And then, of course, it's not truly possible to make sufficient questions and answers. And therefore, we will continue with the next speaker, which will be Dr. Anil Pavani. So, Dr. Pavani, are you prepared?
I am prepared, yes. Can you see me?
Very
Can you hear me?
Well, we can hear you, and well, you are cordially invited to take the stage and share your screen with us.
Okay, I'll do that.
So actually, this looks good. Very well.
Okay,
We can
are
see
we good? You can see me, you can see my screen.
Yep.
Okay, excellent. Thank you so much. It's wonderful to be here, and I look forward to speaking to you today about digital pathology. I heard really outstanding lectures today. So thank you so much for the organizers of the conference. And I'm looking at the agenda. It's really, really comprehensive. So I would like to talk to you today about road to digitization and using AI in pathology diagnostics. Where are we today? Where are we going? So what I like to do is, so I'm from Columbus, Ohio. I'm at the Ohio State University, and you can see this beautiful campus and the photos, and we are excited to start the football season here in Columbus, which is happening in 2 weeks. So I want to give you an overview today of what's the current state of whole slide imaging for clinical diagnostics in the United States. Why do you implement digital pathology? What are the key reasons? What are some of the challenges? What are some of the barriers? How do we implement digital pathology to enable AI? And where are we going with this, right? So I heard some really interesting discussions today about digital pathology and AI. So all of the speakers have talked about digital pathology as an enabling tool for pathology, workflow, clinical uses, education, and research. So without question, digital pathology brings clinical efficiency. Without question, it brings workflow integration and an opportunity to review your diagnosis again and again. Education and training of residents, research, AI tools. So all of these will not be effectively possible if we do not have a digital workflow, or at least a portion of our workflow is digital. Like think about the tumor boards that we do as pathologists. So there is a lot of opportunity to to make this a process for everyone to really engage in. So as I think about my own workflow, why do we need digital pathology, right? So if you look at from a hospital's perspective, we heard about from the UK, from other parts of the world, where there is a shortage of pathology practitioners. There is an increased need for access to subspecialists. Care is fragmented, right? So I might have a patient who had a biopsy in July, and they would go to see an oncologist in September, and the oncologist requests a second opinion of their pathology. And in a traditional glass slide workflow, that consultation may take a few weeks. So there is a need for modernization in pathology practice. There is a need for, if you are a provider, from a provider's perspective, if you're an oncologist, the needs are the same. They want to engage with the pathologist. They want to be able to increase the accessibility to subspecialists. And not all centers have all subspecialists. Not everyone has subspecialty expertise. Like at Moffitt, for example, Dr. Bowie's soft tissue, cytology, breast. Not everybody has that expertise, the depth of their expertise. So again, we need to focus on why digitize pathology, right? So if you're a third-party entity, again, you're dealing with the same issues. At the end of the day, the patient wants the right diagnosis for the right treatment with the right slides being reviewed by the right pathologist. So I'm not saying we need to have every slide reviewed by a subspecialist, but there is an opportunity to have access to more subspecialists. So our pathologists who are signing out in the community by practices, they are general pathologists, they're excellent at their job, and they can probably sign out 90% of the cases with no difficulty. But there is a 10% of the cases where they may need help. So digital pathology enables that to happen. So the value driver is really engaging with the pathologist and the patients to increase the quality of the reviews and the speed of diagnosis, right? So, if I have a patient who has melanoma and the lab that the slides were being delivered to, they need help with their diagnosis or they need a second opinion. Traditional pathology workflow, glass slide, packing, distributing may take several days. With digital pathology, you can do that instantaneously. I am a GU pathologist, so if I have a question about a penile lesion and I want to send it to an expert, Dr. McKee, I want to send it to them, I can enable that easily with digital pathology. So you have an opportunity to create an expansive pool of pathologists who are covering a range of specialties and send those consults to them digitally. You are also able to see these cases across different electronic medical records, different IT solutions. So the patient's care is continued. The patient care doesn't stop, right? And at the end of the day, if you can find a way for this data to come back into a warehouse or a database or a repository, you can enable research, you can enable clinical research, AI development, you can enable a way for this data to be leveraged for these different opportunities. So it's really, really, really powerful. So at the end of the day, when we think about digital transformation, you have multiple types of image acquisition devices, scanners, hybrid microscopes, robotic microscopes, pathologists with cameras on their microscopes, images from the autopsy suite, the gross room, all those images, they are sitting in silos today. So we need to find a way to bring them together into one environment. And it doesn't have to be in a particular image format. It has to be able to be useful in a universal image format, right? So any scanner, any lab information system, any image analysis tools. So when you think about image analysis tool, as a pathologist, when I'm looking at a glass slide, I really cannot do much more with that glass slide. I can go to the tissue and cut some unstained slides, run some immunomarkers for ER, PR, and I can quantitatively review those. But with digital pathology, I can apply image analysis tools and AI tools. So really the goal, if we want to use digital pathology and computational pathology, is to create an open platform for digital pathology and AI tools. The goal is also to increase productivity of pathologists, improve management of information, workflow distribution, integrating the data. So if Dr. Bui is looking at a bone sarcoma case, she has available all the images that she needs for that case. Improve the quality of your diagnosis, right? So as a pathologist, I make mistakes, right? Is there a pathologist who doesn't make mistakes? Probably none, right? So you need the QA tools, you need the quality control. You need to be able to rapidly consult a pathologist easily and in real time. You need to be able to increase your revenues if you're in a practice. Somebody has to pay for that storage. Somebody has to pay for that scanner. So this can provide opportunities to increase your revenues, provide consults that come to your hospital, provide patients who come to your oncology center now because you as a pathologist delivered an outstanding diagnosis. You're able to use digital pathology and AI and computational tools to create a more objective and accurate diagnosis. There is an opportunity to consolidate. So recently we moved to a central lab where histology was producing the glass slides and the digital slides. And as a result, we were able to bring several labs together, move the technologies into one location. So we don't have to move slides anymore. We don't have to move pathologists anymore. We're just moving images and the data. And this provides you with an opportunity to thrive in the innovation. Look at all these images that were created and make an opportunity to provide image analysis and workflow algorithms and AI tools. So this is a huge opportunity for labs. So how do pathologists perceive it, right? So if you look at pathologists, if you look at any technology that's adopted by pathologists, you have the innovators, you have early adopters, early majority, late majority, and the laggards, right? So in digital pathology, it's interesting. Most people are still in the innovator phase or early adopter phase. We heard this morning from the UK, it's like 5 to 10% of adoption for primary diagnosis. And it's pretty similar to the United States. So pathologists in general, if they were slow to adopt digital pathology, but they're coming around. So pathologists did not completely trust digital pathology systems, but they're now more and more comfortable. There are many countries out there which have adopted digital pathology, many labs in these countries. Pathologists are traditionally afraid to give up their microscopes, but they're becoming more and more comfortable. They can understand the limitations of the technology. They can understand that the glass slides are not going away, but they can do most of their work digitally, but there will be needs for special stains, polarizations, looking for crystals. If you look at digital pathology hurdles, regulatory issues have been very, very important in the forefront, and they have somewhat impacted the adoption. But now we have scanners which are approved, and we have technologies which are approved by the regulatory environment. Even though the financial gains are not clearly defined, there is more and more data now which points towards efficiency and quality gains. So we saw this during COVID. We actually saw a jump in our adoption about 20%. Pathologists who were reluctant to sign out digitally, review cases digitally, do remote consults, they are now more and more comfortable. So if you look at workload issues, right? So as a pathologist, you have to qualitatively review each cancer case. This requires a more efficient throughput system. This requires an increased ability to communicate inside and outside the institution. So the goal is to promote multidisciplinary collaboration, and pathologists work with oncologists, radiologists, radiation oncologists, and sometimes social workers, right? To get the best care to the patient for the diagnosis that they have, which has been reviewed multiple times potentially. So if you look at the reports, they're becoming more complex, right? So I am a GU pathologist. I look at kidney cancers. So in the last 2 years or 3 years, we now know of new mutations, new changes in the genetic code, new changes in the tumor, in the morphology, which we did not know before. So there is a huge knowledge explosion. We also have new information about the tumor that's needed as part of the data which goes into a pathology report. So if you look at the number of hits and events from a pathology report that then make their way into the electronic medical record, it's about 70% of the data that is coming directly from anatomical or clinical or molecular or digital pathology. If you look at the state of the industry, we now have scanners which can hold up to 1,000 slides, anywhere from 1 to 1,000 slides. And they're producing diagnostic quality images. And they're doing it rapidly within 1 to 4 minutes. If you look at the spatial sampling period of microns per pixel, we've gone down to 0.25 microns per pixel. What that means is if you're looking at a nucleus, inside a nucleus, you're looking at nucleoli. And if there is more than one nucleoli, with this resolution, you're able to separate those two nucleoli. So this is huge. In the United States, we have 2 scanners which were approved by the FDA. And over the last 3-4 years, and that's really increased the adoption overall. So 2 things which has accelerated adoption in the United States and several other countries is adoption is dependent on regulatory hurdles, right? So if you have 2 scanning companies which now have systems in place which are FDA approved, it increases the adoption. Also, if you have a need to share cases remotely because you're caught in a pandemic, that increases the adoption. So we've seen both those things happening. I expect there will be more scanning companies which will be approved very soon. I expect several of the AI algorithms that I mentioned will be approved by the FDA in the near future. So the future is already here. So overall, there is an increase in adoption, right? For all the reasons that I talked about. And overall, whole slide imaging is getting better, getting faster and smaller. When you store these images and you want to share these images remotely, the storage could be on the cloud, could be in your internal service. The ability to access those images within seconds is a huge impact on adoption of digital pathology. So at the end of the day, if you look at the oncologists and clinicians, they love digital pathology. There are opportunities to discuss cases with patients and their families, discuss this at tumor boards, at the conferences, get second opinions rapidly. And you have, once you have the digital image, you can access these tools for prognosis, treatment, common, and for diagnostics. So if you look at the landscape, look at the vendors who are in the space, it keeps increasing every day. Like 20 years ago, when I was training, we had a handful of vendors who were making their first scanners. We didn't have AI tools. We didn't have slide scanning and distribution software. we didn't have image management, we didn't have ability to do secondary consults. But today we have all this, and it's really impacted our practice as a pathologist. So, you know, I know there was questions this morning or this afternoon about use of AI in pathology. So at the end of the day, as a pathologist, I still love my H&E slide. I still want to be able to look at a good H&E slide, because to me, a good H&E slide is equivalent to a good history and physical. So if I was a family doctor or an internist and I was doing a history and physical on a patient, this is the tool that we use as a pathologist. So when I digitize this slide, I want to be able to share this rapidly. I want to be able to decipher it with AI tools. I want to be able to consult a pathologist anywhere in the world who has more knowledge about this disease than I do. So with digital pathology, you can enable all this. And with digital pathology, you have converted your H&E slide into computational H&E, computational histology. So it's really, really a huge thing for the industry. So if you think about what value does it bring from an AI perspective, right? So you have all these slides, you have all these images, you have these valuable slides that you screened for a patient with melanoma, with a Spitz nevus. Once you digitize this information, the slides, the images, the blocks, you can share it rapidly. You can apply information management, image sharing, and you can apply AI tools to enable you to go beyond the glass slide. So many labs have already gone digital or in the last 5, 6 years, 7 years. They have, in the UK, for example, this has really transformed the practices of pathologists and the patient's perspective, the patient's ability to get a second opinion more rapidly, and the pathologist's ability to not only use morphology, but go beyond morphology. You know, so these are some examples in the United States of centers like UPMC, like Cleveland Clinic, Mayo Clinic, Memorial, Johns Hopkins, Toronto, UCLA, and I can name several others like Moffitt, who have excelled, who have partnered with vendors, who have partnered within their institute with radiology or with other specialties to enable rapid transformation of pathology review, to enable revenue generating opportunities, to enable AI algorithms that could be used on top of these. So at the end of the day, if you look at AI technology, right? So what does it really mean for a pathologist? So if you're a pathologist and you're looking at a glass slide and you're looking at breast cancer, you're looking to grade it, you're looking to look at features like mitosis or cell density, or look for pleomorphism or giant nuclei or hyperchromatism. If I can find a way for each one of those attributes to be reviewed by the machine learning or deep learning and present that data to the pathologist, you know, like inside this box, there is a convoluted neural network, which is looking at this data and categorizing them into different buckets. You have really achieved what a pathologist does, and you've gone beyond the subjectivity of that interpretation. You've made it more objective, right? So at the end of the day, as pathologist, I'm predicting, I'm looking at patterns, I'm looking at profiles, and I'm making a prognosis. I sometimes am not objective in that because it's time consuming, it's labor intensive to count every nuclei. You know, if I looked at this prostate biopsy, every field has data in it. So what AI delivers to us is an ability to be more objective as pathologists. AI is not going to replace you as a pathologist. It's going to make your job easier. So I want you to understand that. I don't want you to be afraid of AI. I want you to use AI as a tool, just like immunohistochemistry, just like next generation sequencing. So this is an example of a paper that was published at UPMC, where they looked at prostate needle biopsies, and they looked at patients and a manual interpretation of prostate biopsies for grade of the tumor, for perineural invasion, for high-grade PIN. And at the end of the day, they were able to compare what the pathologist looked under the microscope and made a diagnosis with what the computer did with the digital scans, and made an inference and compared it. So if you look at it, the AI algorithm achieved an area under the curve of 0.997%, 95% confidence interval for cancer detection in the internal test set. And if you apply this to an external validation set, so outside of UPMC, that was 0.991, so very, very similar. Not only was it similar in diagnosing the cancer, but also staging the cancer, grading the cancer, calling it Gleason score 6 or beyond. So this is huge. And present this in a format which is easy for pathologists. So my slides are digitized. I come to work. Before I even come to my office, I can see this dashboard. I can see how many of these biopsies have a likely malignant needle biopsy. I can look at it first. I can see what the computer called it, and I can approve it or not approve it. I can change the diagnosis. I can edit it. So this is huge. This will be huge for pathology in the future. So I can look at this heat map and look at, make it disappear and see the cancers underneath it. Look at the H&E slide and then overlay it with the heat map. So this is not just only in prostate. This is an example where this was done in lung cancer, in classifying lung cancer. So you can see on the right-hand side, on the left-hand side on my screen is pathologist annotation of the different subtypes of cancer in lung, carcinoma, papillary versus solid versus cystic. You can see the AI did the same thing, like papillary, micropapillary, solid. So this is exciting. So you can see here in this study, these are unstained H&E slides of patients with prostate cancer or benign prostate. The computer was able to generate a artificial H&E stain. And if you compare it to the real H&E stain, they're very similar. So if I gave you this slide, an image of this, and that was generated from an H&E slide, you will not know the difference. The human eye will not be able to see the difference. But more importantly, you will be able to press a button and see where the cancer is. So this is huge. This will impact pathology practice in the near future. So with this, I want to share with you what we have done at our institute. We started about 4 years ago with creating a digital pathology lab. We started to scan slides retrospectively, and we started to sign out cases digitally, and we moved to a new electronic medical record. So over these past few years, this is the space that we got. We were able to go back and retrospectively scan slides, put barcodes on the slides, integrate them with our lab information system. And we were able to create a digital workflow, which was very, very powerful for us as an institute, as a department of pathology. So this shows you the network where we were able to push slides into these robotic scanners, get them digitized, and make them available to pathologists, make them available in the storage that they have created. So this is an example of a small scanner that is now used for frozen sections, that is now used for H&E, cytology, and everything else. This is in a hospital which is about 90 minutes away from Columbus, where pathologists can show cases to each other. They can get these slides scanned quickly and do a consultation with a subspecialist, do a consultation for frozen sections easily. And then we have the high throughput scanning lab, which is right now in the histology lab. So this is a workload. Slides are prepared, stained, digitized, and automatically assembled into cases and sent. The images are sent to pathologists. So we now have over 40 pathologists who are using digital pathology every day, and over 2 million slides that have been scanned. So it's really been a game changer where pathologists are excited about looking at these images. They are excited with the collaboration. They're excited with sharing cases. And they're working remotely in some cases. And they're teaching the residents. So overall, especially during the pandemic, we were able to create increased flexibility for pathologists in staffing, in reduction of in-person, face-to-face interactions, improving efficiencies, making the digital images available to pathologists. And more importantly, we were able to do research. We were able to use these images for AI development. There were some issues, right? So not all internet connectivity was the best at these different locations, like working remotely. There was a potential to buy new hardware for home use. We could not easily see special stains and histological findings, and but luckily we could revert to glass slides. Or come to the main hospital. There were issues in terms of special stains, in terms of finding polarizable material, in terms of finding borderline nuclear features, and suboptimal slide scanning. So in our lab, about 2.57% of the daily slides fail to properly scan. So if on average, we're scanning 2,000 to 3,000 slides a day. So about 2.5% of them fail scanning. And most of them are due to barcode failures. But we can collaborate easily. I can connect to any pathologist in the network. And I can look at the images. I can look at the clinical data. I can click on these images, look at the immunohistochemistry, look at the special stains. So it's easy for case navigation and for collaboration. I don't have to wait for the delivery of the slides. I don't have to wait for gold ring. And on top of that, you can go beyond the glass slide and open up new avenues for AI development that we could not do with glass slides. So click a button and you can see objectively how many nuclei are 3+ in a patient with breast cancer for ER. Look at HER2-neu, look at ER, look at PR, and do consultations, right? So we use Path Presenter as a consultation portal, and we can get consults now from anywhere in the world. So this is huge. Images are of diagnostic quality, and you can chat with the referring pathologists, you can chat with the coordinators. So you can see the images are, and you have a lot of tools, right? Annotation, measurement. So putting this all together, digital pathology has transformed pathology. In the future, there will be no digital pathology. It'll all be pathology. And at the end of the day, all these different applications have enabled us to create high quality patient diagnosis, second opinions, and also create opportunities for machine learning and AI development. So with this, I want to end, and I want to thank you, all the participants and the organizations for this amazing conference. So thank you all. And thank you, Andreas. And I can answer questions if there are any.
So, well, thank you for this very interesting talk. Again, another very, very interesting perspective of the use of artificial intelligence in pathology. I'm pretty sure there should be some questions, and I read out the first question. Do you think the next generation of pathologists will be more reliable on artificial intelligence?
So I think what the next generation of pathologists will find is they will have more tools. You know, they can go beyond the glass slide. They will find a way to interact with this data more easily than ever before, right? So like we heard from several outstanding talks today about in pathology, where there was a question in the diagnosis and they use ancillary tools. So digital pathology will enable the use of more of these tools. You know, so there might be a tool for a pathologist to quantitate things better, right? So if you look at the treatment of immuno-oncology, you know, for PD-L1, it's highly dependent on ranges of these diagnoses. So with AI and digital pathology, we can provide a more objective diagnosis to these patients, to the oncologists, and they will be able to use these tools. But the precursor to using these tools is to adopt digital pathology. So the more rapid adoption we have, the more easily we will be able to use these tools. You know, if there are only 5% of the pathologists around the world who are using digital pathology, then the value will not get to the, you know, the value proposition will be weaker. But if 20% of the pathologists are already using digital tools, that value proposition will increase significantly.
Yes, thank you. I think we all agree that if we adopt more and more of those tools, we will make a great progress. Because as a summary from all the experts we heard, those tools are available, and it's just the matter of making the first step and seeking, for example, discussion with people that already use artificial intelligence or digital pathology facilities, because it's not that far away, like it was 3 or 4 years ago, especially before the Corona situation. So if there are not more questions, again, thank you, Dr. Palani, for this interesting impressions and also displays. So, and now it's a great honor for me to present our last keynote speaker. This is Dr. Zev Leifer. And we had Dr. Leifer on the previous meetings. It was always a very inspiring talk. And so we are very interested what the next presentation will be. And I'm opening the stage for Dr. Leifer.
All right, can you see the slides? Are we sharing?
Yes, and we hear you loud and clear.
Very good. One moment. All right, first of all, thank you very much for this invitation. Thank you for attending. Title is regulogenesis, which I will explain as a term as we proceed. This is the search for a new class of pathogenic chemicals, hypothesis, a website, and an assay. Declare that I have no conflicts of interest with any commercial products referenced herein. And by way of introduction, I want to start with the background. The general subject is short-term tests for genotoxicity, some of the earlier work in the field, and let that be a model for a new kind of test that I'm going to propose. In order to understand that, we need to discuss changes in DNA structure at the secondary and tertiary level. I'll talk about development and publication of a website, development of an assay, and some thoughts and plans for the future. Let's begin with cancer. The question is, what causes cancer? And the answer is lots of things. These are all at least suspected: immunology, radiation, for chemicals, for viruses, some more recent observations. We're going to focus on chemicals, chemical carcinogens. The question is, what is the carcinogenic potential of a particular suspect chemical? The old way was animal testing. Even today, of course, that's still very much used. If you have a suspected chemical, and the problem is that it's simply very expensive. I mean, it certainly is a good endpoint when you get it. It gives you a lot of information, but you need a large animal facility, care and feeding of the animals. You need a veterinarian on staff. You need special flooring for frequent washing and draining. You need special ventilation. And what that means is that you're greatly limited. Just because of the expense and difficulties involved, you can only test a few chemicals. For each chemical, you can only test a few doses. And related to this, by its very nature, it's time consuming. It takes weeks to months until you get a tumor or no tumor endpoint, whether it's mice or rats or rabbits or monkeys and so on. And we're looking for a way to get the kind of information that we want without the expense or the time. And the world changed when Bruce Ames, University of California at Berkeley, developed his Ames assay. The assumption based into this assay was that, first of all, chemicals cause mutation. And secondly, that mutations cause cancer. And there's certainly lots of evidence that there is a relationship between mutations and cancer. Strategy was to develop a simple assay using bacteria to screen for chemicals that cause mutations. All right, so we're using bacteria and we're looking for mutagens. And then we develop the argument. If it causes mutations in bacteria, it will, or at least may, cause mutations in humans. And then the next step, if it causes mutations in humans, it will or may cause cancer, although that's subject to verification. The Ames assay is very straightforward. It uses the organism Salmonella typhimurium. This organism has a mutation in the histidine biosynthetic pathway. All right, histidine is regular normal amino acid needed for protein synthesis. It's actually a 10-step pathway. So one of those 10 genes is non-functional, and we'll call that His minus. Now, you can have a reverse mutation. Product is called a revertant, and genetically speaking, it's His plus now. All right, so we'll say His minus is converted to His plus. What that means is that a mutation is a mutation. Now, we are used to thinking of the normal strain, the wild type, as being the functional gene and the defective gene is the mutant. So now we're reversing that, but at the genetic level, it doesn't make a difference. Functional to non-functional or non-functional to functional, right base to wrong base or wrong base to right base is still the same. It's all a mutation. And obviously, as you will see, it makes a difference from a functional laboratory perspective. Now you can do this assay in form of a plate assay. This medium in the plate means petri dish, medium that does not contain any histidine. So it's not present in the medium. And secondly, the tester strain, by definition, is cis minus, cannot make its own histidine. Right? You spread a petri dish with a lawn of the tester strain. Lawn means wall-to-wall bacteria. Spread them out. Put the test compound on a filter paper disc in the center of the plate, and over time, it diffuses out for 24 to 48 hours. Bottom line at this point is that the strain will not grow. No colonies will form. Why? The cell needs histidine. Doesn't care where it gets it from. You can make it itself or you can feed it, but one way or the other, it needs histidine. Here, the medium doesn't contain histidine. The cell can't make histidine. No histidine will not grow. What will grow, this is repeating, this is new. What will grow is only revertance, meaning a mutation from His minus to His plus as a result of the test compound. Only those will grow and form colonies. From an experimental point of view, the observation is colonies around the disk. If you get the growth of colonies of revertance, the interpretation is the test chemical is a mutagen. All right. Implicit in this is if it's not a mutagen, no colonies. So we're testing for mutagens. Operationally, you can do this in the form of a liquid assay as well. You can add the test compound to a tube of culture at the appropriate time. So here are your cells. Here is compound in. Here is a sample being spread out on a plate. Incubate and look for colonies again. And now here is a group of colonies, countable colonies. Again, no colonies means negative result. That's fine. It's not a mutagen. If you get colonies, bingo, it is a mutagen. But what's advantageous to the liquid assay versus the plate assay is that it's quantitative. All right, now you can get a number to it. You can count the colonies, first of all. Secondly, you know exactly milligrams, micrograms, nanograms, how much you put in and how many colonies you got out, from which you can generate a dose response curve. Well, this is number of colonies, this is amount of suspect chemical, and you get a curve like this, which means you can get a curve with a lower slope, you can get a curve with a higher slope. In other words, the slope tells you how, not only plus minus, it is a mutagen, but it can tell you how potent it is as a mutagen, which is important information in your overall assessment of the danger of this chemical. Coming back full circle to animal testing, it's much less expensive, which means now you can test more chemicals. Now you can do more doses for each chemical. You get a result in 24 to 48 hours, not weeks or months. So it has many advantages at this level compared to animal testing. And presumptively subject to further testing, it'll be shown to be a carcinogen, which is all to say that at the very least, you have a screening system. Although you have 100 chemicals you want to look at, can't do all 100, too much, too hard, too expensive. So you run it through the Ames assay, you find out that 10 out of those 100 are in fact positive in the Ames assay or mutagens. So those become your suspects. And then you do your animal testing and get a real tumor and you advance the course. But you have simplified your challenge. And when Ames came out with this, they were testing everything under the sun, a lot of common chemicals, and they found there's a component in ladies' hair dye, which is mutagenic, and they reformulated that to get rid of it. They found that there was a mutagenic component in the flame retardant. People don't even know about this, but there is a flame retardant naturally put into children's pajamas. And that contained a mutagenic component, which was reformulated to get rid of it. They found it in Xerox toners, and that was changed. So a lot of these environmental chemicals turned out to be mutagens. Finished with Ames assay, new topic, new genetic endpoint, new assay. This is called the Parlay assay. Background is that we're talking now about DNA damage, which could mean thymine dimers, methylation of bases, deamination of bases. Bottom line take-home message is that DNA damage is lethal, kills the cell. Not to worry, there is an excision repair system that will undo the damage. And this consists of 4 enzymes, 4 steps. If you have double-stranded DNA and you have damage, let's say in one strand, in that strand, first of all, is an endonuclease that makes a nick that allows you to sort of separate out the damaged strand so that you have a free open end. There's an exonuclease that removes, cuts it out to give you a gap. So you have a complete other strand and a damaged DNA, formerly damaged DNA with a gap. DNA polymerase, Pol A, fills in the gap. And because of the enzymology involved, it's not able to make the final 5' to 3' bond. So you have a 4th enzyme, DNA ligase, which will make that bond. And compared to what you started with, you now have repaired DNA. Hero of the story is Pol A, otherwise known as Pol 1, or the Kornberg enzyme needed for excision repair. Without it, can't carry this out. Damaged DNA is lethal to the cell. Now we come to taking all of that knowledge and putting it into a simple laboratory assay. For this test, we'll use 2 strains. One is Pol A+, it's the normal strain, we'll call that repair efficient, capable of carrying out DNA repair, as we just discussed. The other is Pol A-, repair deficient, missing the critical Pol A enzyme. Now we'll use 2 plates, spread a lawn on the 2 plates, add test compound to the filter paper disc in the center of the plate. Compound diffuses, incubate 24 to 48 hours. Now we're going to measure the diameter of the zone of killing in each plate. All right, take your ruler. Today we can automate it, but idea is the same, millimeters diameter. The interpretation is that if the Pol A- strain gives a larger zone diameter, the conclusion is that the test compound is a DNA damaging agent. So here is your assay. Here's when you first set it up. Here is your filter paper disc with the test compound. Here is invisible Pol A+ strain and Pol A- strain spread out as a lawn. Invisible means hasn't grown yet, you haven't incubated it yet. So now you incubate for 48 hours. And here, this is now your lawn of cells grown up. Here is your zone of clearing, meaning killing as a result of this test compound. Here's your Pol A+ strain, here's your Pol A- strain, and the critical observation is that your zone diameter is much larger. In other words, in general, the diameter represents a balance between bacterial growth and killing by the chemical. So here you are able to repair it, so the net is less killing. Here you're not able to repair the damage, and the net is more killing as represented by a larger zone diameter. And this just shows you sort of a real life photograph, exactly the same thing. Here's your lawn, and here's your zone of killing, and here's your test compound. Now you can also do the same Pol A assay in the liquid form. Now we're going to add test compound to 2 tubes, one containing the Pauli plus strain, the other containing the Pauli minus strain for appropriate time. Again, sample and spread as a lawn on 2 plates, incubate for 48 hours, count the colonies. And now you're going to look for differential killing. Concept is the same, but now you're counting colonies. So here, 2 tubes, Pauli plus strain, Pauli minus strain, equal test compound put in, sample, spread, incubate. Here you get, we'll say, lots of colonies. Here you get much fewer number of colonies. This is the organism Pauli plus able to repair the damage. This is the organism which is not able to repair the damage. Or, once again, to flip it around, if you get this differential killing, if you get this reduction in the number of viable cells, take that as an indication that the compound is causing DNA damage, which is the end result that you want. And once again, if it causes DNA damage in bacteria, it will probably cause DNA damage in humans. And if it causes DNA damage, we'll suspect it as a carcinogen. Once again, liquid assay has an advantage compared to the plate assay. Millimeters diameter is kind of sort of fuzzy. You certainly don't know how many milligrams, micrograms that represents, but if you do it in this kind of a fashion, you know exactly how much you put in. You can vary that, get a change, get dose response curve, change in the number of colonies. Pauli plus versus Pauli minus is a function of number of milligrams you add in. So, you know, as I said, not just plus minus DNA damager, but powerful or weak DNA damaging. Now, without repeating myself, you can see how that's advantageous, at least as a screening system compared to animal testing. But now I want to compare it to the Ames assay, one test versus the other. 2 important points to mention. First of all, the target in terms of, you're talking about E. coli, bacteria, circular chromosome. So you're not restricted to a single gene, right? The Ames assay asks you to look for a chemical that will affect a single base in a single gene in the entire chromosome. Whereas Pauli assay, you're not limited to that physical location around the chromosome. It can be anywhere around the entire chromosome. So that's a plus. And secondly, in terms of mechanism, you're not restricted to a single base change. Any of a variety of kinds of DNA damage can you pick up. Bottom line, you may detect a genotoxic chemical by this Pauli assay that the Ames assay may not detect. So that's a plus. And in fact, following up over the years from these 2 kinds of assays that I've discussed, many common denominators, a short-term test for genotoxic chemicals, that's the field. And there are yeast systems and there are tissue culture systems, sperm abnormalities, whole different kinds of experimental organisms and different kinds of genetic endpoints, prokaryotic endpoints that I've been discussing. You can have eukaryotic organisms, you can have sister chromatid exchange, other kinds of genotoxic effects. What follows from this, just as an important aside, is that you can have one test that will detect 70%, let's say, of known carcinogens. Right now, you are evaluating the test itself against a base of known carcinogens, and this test will pick up 70%. You can have another one of these tests that will pick up, again, 70% of known carcinogens, but not necessarily the same 70%. You have an overlapping of that list. So if we used A plus B together, we may detect 80%. And if we use 3 tests we may pick up 90%. I'm making up numbers, but the more you can't do 40 tests. But what kind of combination of different tests for different genotoxic endpoints will enable you to not miss a chemical which may be potentially carcinogenic? So I spent some time working on these DNA repair deficient bacteria, which was done for the US EPA's gene tox program in the Rosenkrantz lab. Just came out as an extensive paper in mutation research, along with a series of other papers on these other 40 tests, and these, in the end, probably thousands of different chemicals. Having done all of this, this was background. This brings you into the area and the field and the issues involved and the advantages of short-term tests for genotoxicity. And I gave you one example of mutations and one example of DNA damage, which are, in the end, changes to the DNA. I want to introduce you to what I call regular genesis, a new endpoint. We want to look for chemicals that affect DNA secondary or tertiary structure. In other words, we'll say this in a minute, primary structure is sequence, so mutation is a change in primary structure and sequence and so on. This is secondary or tertiary structure in such a way as to affect the binding of regulatory proteins. So we're looking at regulation, not just you make a protein, you don't make a protein. Some background information relevant to this discussion, we will assume, and a lot of it, there's evidence for all of this, and it's well known, small molecules bind to DNA. Such binding can cause changes in the secondary or tertiary structure of the DNA. There are proteins in general, in particular regulatory proteins that bind to DNA. Distortion of the structure of DNA can make the binding tighter or looser. Such alteration and regulation can have effects on microbial physiology, and in the end, we hope it'll work the same in humans. Now, let's get into the field. Here is DNA. Here is your double helix, nice line. Here is just different ways of representing the same thing. You have your backbone, sugar phosphate, sugar phosphate, sugar phosphate, sugar phosphate. You'll have bases attached to the backbone, and there's the second backbone, double helix. You have hydrogen bonding, forming specific base pairs. I'm coming back to this one, sugar phosphate, sugar phosphate, sugar phosphate backbones. Note specific base pairing, A always with T, adenine with thymine, G always with C, guanine with cytosine. So specific base pairing. And I will come back to this picture. All right, this slide is vocabulary. Primary structure, we just said, refers to the sequence of bases. Secondary structure refers to the properties of the double helix. So base pairing we just showed you. Backbone on the outside, base pairs in the middle. Can't see this in either of these pictures, but the base pairs generally are flat and planar. We have a smooth backbone line. We'll follow this line all the way down very nicely, round and round. Pretty much uniform pattern. 10 bases per turn. That's maybe a new idea. That means on one strand, if you go 360 degrees around, all right, and you start at this point, you go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You come to this point, precisely above where you started from, you will have encountered 10 bases. And it's a right-handed helix. What that means is that if this DNA structure were a gigantic spiral ramp. And you stood at the top of the ramp with a pair of roller skates and you stepped off. You go round and round and round and round in a clockwise direction. So this kind of a picture doesn't give you that. If you look at it from the top down at an angle, you can begin to see it. You go starting here, you go in a clockwise direction around, and this combines the two and again gives you a better sense of going clockwise. So that is the definition of right-handed helix. So all of that is secondary structure. Tertiary structure refers to the features of the whole genome, whether it's circular, whether it's supercoiling, if there's bending, twisting, stretching of double-stranded DNA. With that, let's look at what kind of changes you can have in secondary structure. All right, what I gave you was bDNA, it's the original classical Watson-Crick bDNA. Now there is zDNA. First of all, this is a left-handed helix. Same building, same roller skates. Now you go in counterclockwise direction. Instead of a smooth backbone, it zigs and zags. That's the Z and zDNA. There are 12 bases per turn, irregularity. Some of the bases are turned and flipped. And what that means is as follows. Here's regular bDNA, look at nice, smooth backbone line. And here is your backbone line, the same sugar phosphate structure, same bases in between, but now your line goes this way and this way and this way, irregular angles, which means distortions in bond angles and bond lengths and so on. But more to the point, if you look at this DNA structure as a target, as a landing place for a protein, here is this surface. Sort of imprint that in your mind, compared with this, right? Clearly it's very different, and that has important implications in regulatory DNA. You can have what's called cruciform DNA. You have this little loop going in this direction and a loop down here. This is regular double-stranded DNA. It's a different form of secondary structure. There are cases where you have triple-stranded DNA, where you have this base, hydrogen bonds to another base, another strand, and a third strand. You can have that as an added, inserted third piece of DNA, or even within one piece of DNA, you can have it sort of fold back on itself, and you can have in this region, and it's all very limited, but in this region, triple-stranded DNA. Depending on sequence and other factors, you can have what's called G quadruplex, guanine quadruplex. You have, right here, it's all continuous. You follow this around. This is a continuous piece of DNA, but if you've got 1, 2, 3, 4 guanines that form this quadruplex structure, and you can have stacks, layers of these. Now this is all in one strand. You understand if there's a G here, there's a C here, and you can have similar related structures based on cytosines. So if we illustrate it in this fashion, here's regular DNA, here's your G quadruplex locally over here on this side. Or if you look at the corresponding, this one's called an I motif, the cytosines bound in this way. So all these are irregularities based on comparison to secondary structure. You can have changes in tertiary structure. I take the whole double-stranded DNA, connect the ends and form a circle, and then you can have twisting of that circle, and this is real, you can have it. See it in an electron microscope. You can have bending of the DNA, a little bit, a lot, very lot. This is a protein, so we're talking about DNA protein binding. You can see that the curvature of the DNA can have an important effect on binding. You can have twisting of the DNA. If this is what your normal DNA looks like, here is overwound and tightly wound. Or you can have underwinding, as if you took it twisted and untwisted in your fingertips. You can have stretching. Here's what we'll call regular DNA. Here's a fist pulling it out. And you can just pull it out linearly, slightly and dramatically. So these are changes in effects in DNA. Putting it all together, I have constructed a website called the Leifer Institute for Molecular and Digital Pathology, limdp.org. This is what you get to when you log in. Call your attention to this tab at the top, which is ligands. And you go there and you get a little write-up with references on the basic issue that we're talking about. Go to ligands list, next tab, and you get this drop-down menu. And if we focus on it, it lists curvature and length and zDNA and quadruplexes and line motifs and so on. And what I have done, at least I'm in the process of doing, is going through the literature and gathering information on those ligands that, in this case, curvature, that decrease curvature, lexicrops and donomycin and so on, also ligands that increase curvature. We want to give you literature references where possible, URL links to the papers. This is a work in progress, but you can see where this is going. We want to have a handle at the chemical level of what interacts with DNA. This is a sample, literally, of one particular case, the ligand, the effect, and the reference. And the goal is to expand that website to include the effect of such a change, curvature, G4, etc., on protein binding, and ultimately to look for biological relevance, not just theoretically effect on a protein, but is it a biologically important protein? Is it a protein that is involved in some major biological process relating to health and disease? Just as an example, recent work on zDNA, this was in the Scientist in 2020. There's regular DNA that we're familiar with. Here is a section of zDNA. This is RNA polymerase, and in the normal process of RNA polymerase function, you initially generate double-stranded RNA. Double-stranded RNA, in turn, is a trigger for interferon response, and that could be problematic, as we'll mention. So now comes our story. Here is a protein, ADAR1. It binds specifically to zDNA. That's the story of today's talk. As a binding site for zDNA, and it also binds to double-stranded RNA. It changes it so that it does not function as double-stranded RNA, and the bottom line is it reduces, limits the interferon response. And so if you have a biological problem of too much interferon and you have inflammatory diseases and so on, this is the way, this is the body's way, cell's way to modulate that. And in this paper is a reference to Kim Lab that found that there are small molecules that convert bDNA to zDNA, which is what this talk is all about, and how it can be applied in a real life health and disease biological context. I should mention that there are naturally occurring molecules like polyamines, which bind to DNA and affect the structure. That's a whole area to look into. And by analogy to the Ames assay and so on, we want to look at environmental molecules, heavy metals, started looking at. But the whole world of all thousands of things that the Ames assay and the poly assay looked at for their particular targets would like to look at that for things that affect DNA structure and regulatory mechanisms. Just as a passing mention, there is a new journal, first issue, Volume 1, Issue 1, March 2021. devoted to what is now called the exposome, all different chemicals and other factors that cells are exposed to and their effects. So this work fits right into that. With regard to regular genesis assay, the goal is to develop a genotoxicity test, as I've said and saying, that affects DNA secondary or tertiary structure in such a way as to affect the binding of regulatory proteins. Regular genesis assay background is as follows. This is E. coli. We're looking at the lactose operon. Basic elements are that you have a promoter site on the DNA, which is a binding site for RNA polymerase. It sits next to the beta-galactosidase gene, which is the hero of the story. So in normal biology, promoter site polymerase binds, you have transcription, you make the gene product, which enables the cell to use beta-galactosidase, to use lactose as a carbon source. There is secondly an operator site sitting between the promoter and this beta-galactosidase gene. There is a regulatory protein that's important for our story, that's called the repressor. So that blocks the polymerase and blocks transcription. No beta-galactosidase made, you can't use lactose as a carbon source. There is an inducer, usually lactose or something closely related to it. We'll use an analog, IPTG. That pulls the repressor off the operator. You get rid of the repressor blockage, you allow transcription. So we're going to measure IPTG concentration needed to pull the regulatory protein, the repressor, off the DNA. The assay is straightforward. We're going to incubate E. coli in the presence of varying amounts of IPTG, expose it for a set time, let's say a half hour, measure enzyme activity, and then repeat with increasing concentration. So we're starting from 0, very low, and increasing IPTG concentration. That is the basic assay, and then we'll test with or without test compound. So here's your basic assay, increasing IPTG, measuring enzyme, straight, nice slope. The more inducer, the more you pull off repressor protein, the more enzyme you make. Now, you can have inhibition. Now we're going to add to this basic assay presence or absence of BUDR. This is bromodioxyuridine. A uracil analog. Here is your control. Here is with BUDR. It's an inhibitor. In other words, as you increase IPTG, you get less enzyme, lower slope. So lower slope means inhibition, means it takes more, means a tighter binding of repressor protein to DNA. It takes more inducer to pull it off. Same thing with cadmium, different mechanism, different target. Here's your control. Here's one level. Here's another level of cadmium. Both cases, the slope is decreased, means harder to pull off. You can also have stimulation. You can have now an increase in the presence of spermine. Spermine is a stimulator. Slope goes up instead of slope going down. And as you increase the spermine, slope going up means easier to pull off repressor protein from the DNA. Now we're going to use two compounds. On the one hand, you can have enhancement. We'll just look at this information on the right. Percent of control, this is 100% with nothing added. BUDR is one inhibitor and it goes down as you would expect. Cadmium is another inhibitor, it goes down as you would expect. And if you use both together, you get a really dramatic inhibition of enzyme activity. It means much harder to pull repressor protein off the DNA. To me, more exciting is observation of reversal. Here's your control. Here's BUDR, the inhibitor, down to 66. Here is spermine, the stimulator, up to 117. When you put them together, you get 85. And the way I would like to think about this is that take this 66 and add this 17, you get 83, which is close to 85, which means, first of all, you have reversed the effect of the inhibitor. As an extra interesting point, it's almost very nicely quantitative. So that was BDR. Now with same idea, cadmium is another inhibitor, plus spermine, the stimulator. 100 to start with, add cadmium down to 72, add spermine by itself up to 113. And once again, 72 plus 113 is plus a 13% increase is 85, close to 88. So once again, you have a second chemical reversing the effect of the first chemical. And as an added attraction, it's nicely quantitative, at least in this case. So I propose that there are chemicals in the environment which will affect DNA structure in such a way as to affect the binding of critical regulatory proteins. With gene regulation, no one here needs a speech about the role of gene regulation in cancer and development and aging. All of these require making a protein or not making a protein, usually at a specific timing and in a specific point in the development of a changing process. So now you throw in some environmental chemical and that may have a role in that process. And as I said, to me, the exciting observation is the inhibition and stimulation. In other words, if you have a condition and you can associate with it, associated with a chemical that is causing a change in curvature or a change in twisting or whatever, now you have another molecule that can reverse that curvature and can reverse that change. Will that lead to a cure? Lots of things to investigate, but that's the direction. I should mention that there are very sophisticated, which means not so easy and certainly not cheap. But if you want to look at the question of DNA protein binding, the surface plasmon resonance, bilayer interferometry, atomic force microscopy, ultimately that's where the closer scientific looking. But my goal is, as we saw with the Ames assay and all the others, a simple bacterial test to give you a quick answers, to screen chemicals of interest, and then do for all this further work. There are some scientific questions that need to be addressed. For example, even taking what I just showed you, does the compound bind to protein or the DNA? I'm assuming it's a effect on DNA, but that needs to be verified that whatever test compound you're doing is not affecting the protein, right? We're looking at binding a protein to DNA, but you need to, for my purposes, make sure that it's affecting the DNA. There's a basic problem that I haven't addressed in theory. In other words, you can have gene-specific, sequence-specific methods, antisense RNA, aptamers, and so on. But something that affects curvature or affects G quadruplexes or and so on. How do you get a chemical to affect the one that you want without affecting curvature generally around the whole bacterial cell? It may be a question of sensitivity. You can have very low concentrations, not enough to affect the whole cell, but this cell of interest, gene of interest makes a difference. You can rely on the fact that some of these structures are fairly rare and keep that as a, but there's always a toxicity question that you want to address. What I am leading up to is an area of study which I will call diseases of DNA structure. Sum total of all of these things that we want to do. It may be something that's transient exposure to an external chemical, crucial, let's say, in the development of the fetus. It may be internal molecules, as in the polyamines. They're subject to regulatory control of their own. They bind to DNA. That has to be looked at, and as reference to the exposome. And the goal of this work, environmental variable factors that may affect the structure of DNA so as to affect genetic regulation. I thank you, one and all.
So thank you, Dr. Leifer. For this very complex presentation. I'm just looking forward. Are there any questions from the audience? No questions for Dr. Leifer. Okay, this is a question that has been asked before. No questions related to the topic. Of course, it's a little bit difficult because this is another field and another topic. Anyway, so well, if there are no spontaneous questions, of course, we've got plenty of opportunities on the next days. And are there maybe any other questions or discussion points regarding our whole day? As we see a lot of different topics and different fields of pathology and general medicine also. Just to prevent that we forget any interesting thought. Well, if not, I would like to take the opportunity to thank all the speakers, thank all the participants, and of course, thank Utilitarian Conferences for providing the facilities and the platform for this very complex and very interesting day. We've seen many different inspiring talks with classic pathological topics and comprehensive state-of-the-art presentations dealing with artificial intelligence and digital pathology. Well, I learned a lot, and I hope so have you. And there's one last question. Will the deck slides be shared for the presentations? I maybe give this question further on to the conference committee. Maybe there's already a solution for this, so I think we will take care about this. Yeah, and as we see, the presentations are all recorded. For those people who haven't participated at the Utilitarian Conferences, I think this is worth to mention and quite informative. Usually every day is recorded as a whole, so if you missed something, there's no problem. You can review this because the whole day will be recorded, and it's usually available after a short period of time. And in addition to that, after a little time gap, usually all the presentations are prepared as a single presentation. So you can look for the Utilitarian Conferences platform, so you can review any of the conferences in case you missed something. I know we are quite busy. There are phone calls, there are interruptions, there are disturbances, and it's very difficult to stick to every presentation. And it's a great thing that all the presentations and all the talks and discussions are available and recorded. So very well then. Again, thank you all for participating. So I will close this first day, and we will go further on tomorrow at 8:15 London time with some introductory passage, and we will start at 8:30 London time sharp with the first presentation of Professor Tarek Ali. So we will resume at 8 London time, I see, as a direct message. So we will meet at 8 sharp London time tomorrow. So again, and yeah, I'm happy to have moderated this second session, and I'm look forward for tomorrow. Take care and bye-bye.